Very good morning to all of you. We are going to start our session. A very good morning to respected faculty and my dear delegates. With the proceeding, we'll start the session. With respect to Dr. Sandeep Tharkar and Dr. Himanshu Patil sir to chair the session for Dr. Shalini Jaggi ma'am. Dr. Sandeep Tharkar sir, consultant, general medicine, internal medicine, qualification MBBS, MD, experience for 16 years. He is located in Ganga Care Hospital Limited, Nagpur. Dr. Himanshu Patil sir, consultant endocrinologist and diabetologist, FRCP, fellow of Royal College of Physicians, fellowship in the endocrinology, England, MRCP diabetes and endocrinology, UK. Advanced training and fellow in the pituitary and neuroendocrine disorder, England. Diploma in diabetes and endocrinology, UK. Thank you, sir. Dr. Shalini Jaggi, ma'am. Ma'am, please proceed. Topic is fit fat concept, myths versus reality.
Am I supposed to use this? So हो जाएगा ना?
Morning all. So today we'll be starting the session of which is very controversial subject, fit and fat. So it has been debated in a long term by activists, by the physicians, by the scientists, and Madam will tell about what is the concept, which is the myth, and how to clarify this concept. Thank you, Madam. Over to you.
So thank you so much, sir. Good morning, everyone. Starting today's innings, I'm the first batsman. The topic allotted to me is fit fat concept, myth versus reality. I hope the topic has nothing to do with the speaker's BMI. So I think this is everything all of us know. Obesity, overweight and obesity defined as abnormal or excessive fat accumulation that impairs health. That is the most important part. So obesity, we know, is associated with a number of metabolic disorders and increased cardiovascular risk. You can see here all the different complications of obesity which have been discussed last 2 days. What we understand is, yes, obesity is associated with all these metabolic dysregulation, all these problems. So does it mean that fat is not fit? So anybody who's fat, who's obese or overweight may not be fit? Well, if you look at the phenotypical subtypes, as the weight gain happens from normal weight to obese, if you look at the metabolic parameters, the metabolic status of these people, you have 4 different broad categories. First is people who are normal weight and are metabolically healthy. Then you have people who may still be normal weight, but they have excess visceral fat, insulin resistance, diabetes, all these parameters of metabolic health may be deranged. On the other hand, once somebody gets obese, again you have 2 major phenotypes. One being people who are obese but still metabolic health is not altered. And on the other hand, you have the typical people who are obese as well as metabolically unhealthy. So metabolically healthy obese is the term that describes individuals who may be obese based on the BMI criteria, which could be more than 30 for Caucasians or more than 25 for Indians. But these are people where, despite being above those particular BMI cutoffs, their cardiometabolic risk factors are largely absent. So, essentially, if you look at their metabolic profile, they seem to be healthy, although they are obese. Now, the definition of metabolic health is also pretty heterogeneous if you look at different studies. And conventionally, metabolic health has been defined a priori as a clubbing of cluster of indicators of metabolic syndrome or insulin resistance with different results. So the essential parameters that talk about metabolically healthy obesity means A, the person is obese based on the BMI criteria, plus his fasting triglycerides are still less than 150. HDL is still in the normal range, which means more than 40 for men or more than 50 for women. The blood pressures are normal, systolic less than 130, diastolic less than 85. Fasting glucose is also less than 100, and this is somebody who, despite being obese, is not on treatment for any of the metabolic diseases in terms of dyslipidemia, diabetes, hypertension, and has no cardiovascular disease manifestations. So prevalence of metabolically healthy obesity is essentially varied depending on different criteria that are used in different regions. So anything from 12% to 35% in different studies. So what we need to understand is what causes this metabolic state in obesity, and this is where the role of adipocytes in metabolic health becomes very, very important. We know that normally adipocytes have two functions. First is storage of triglyceride, which is synthesized from the fatty acids and glucose once food is ingested. And this is essentially because of the anabolic role of insulin hormone. And second is during fasting or starvation, the triglycerides undergo lipolysis to produce free fatty acids, which are then by beta oxidation used for energy by the peripheral cells. So this liporegulatory function of adipocytes is essentially governed by the adipocytes themselves through adipokines. The different adipokines that are produced, including adiponectin and leptin, and these enhance the beta oxidation of free fatty acids in mitochondria of the peripheral cells. So what happens is, if there is a dysfunction in any of these pathways, either the lipid storage or the liporegulatory role, this leads to a change in dynamics when it comes to all these different metabolic pathways, leading to the peripheral tissues being overloaded with free fatty acids and the metabolites of lipid metabolism. And this leads to an inflammatory milieu and increased insulin resistance, which predispose to all these metabolic disorders. So basically, what we understand is, in terms of excess calorie intake, the excess energy is stored as triglyceride in adipocytes in the white adipose tissue. These triglycerides are released whenever there is a time of need or energy demand. The white adipose tissue can store more triglycerides by increasing the number or size of adipocytes. So either the number of adipocytes will go up or the size will go up. So subcutaneous tissue has limited expandability. Now, whenever there is excess of fat, it spills over into the subcutaneous and the peripheral tissues. Peripheral tissues have very limited capability of accommodating this fat, and therefore the fat deposition in wrong places happens. So the link between obesity and insulin resistance is very clear. If the person is consuming excess calories stored as triglycerides, the adipocytes, if they become very large, this predisposes to inflammation, increased free fatty acid release, insulin resistance, and therefore this is the phenotype that we call as the metabolically unhealthy obese. On the other hand, if the number of adipocytes increases, the small adipocytes are more insulin sensitive. There is no increase, no major increase in size. So there is no inflammation, and therefore this is the metabolic healthy obesity. So the adverse metabolic effects of obesity are partly mediated by a close relationship between obesity and insulin resistance. So if there is no insulin resistance, person remains metabolically healthy. If there is insulin resistance, the person becomes metabolically unhealthy despite being obese in both the categories. So why these different effects happen in obesity is because the critical determinant for insulin sensitivity is not the degree of obesity per se, but the distribution of fat in the different adipose compartments. So when there is visceral adiposity, under conditions of excess nutrient intake, what happens is the adipocytes will become hypertrophic and dysfunctional. This leads to lipid deposition in peripheral tissues that I just spoke about, commonly seen in insulin resistance and all the different metabolic syndrome states. So what happens is, when the lipid metabolites accumulate in the liver, hepatic steatosis, This leads to increased hepatic insulin resistance and consequently an increase in the hepatic production of glucose and triglycerides. On the other hand, similarly, if there is lipid accumulation happening in the muscle cells, so the intramyocellular lipid, this again causes muscular insulin resistance. Similarly, on same pattern, ectopic lipid deposition in the pancreatic islets will induce beta cell dysfunction and apoptosis, predisposing to dysglycemia, diabetes, and all the different insulin resistant states. So there is a direct link between obesity and insulin resistance, and three distinct mechanisms have been highlighted. A, like I said, the increased production of adipokines and cytokines. B, the ectopic fat deposition that I described, that could happen in the liver, that could happen in the peripheral muscles, that could happen even in the pancreas, and the mitochondrial dysfunction. So there is a reduction in the mitochondrial mass and function as well. So this is one of the most important underlying pathways that links obesity to diabetes, both by reducing insulin sensitivity and compromising the beta cell function. So whenever there is a state of positive energy balance, the expansion of the healthy adipose tissues happens. Now, if there is hyperplasia, there is normal angiogenesis, normal adipogenesis, small insulin sensitive adipocytes are produced. So there is increase in number, but the smaller adipocytes are still insulin sensitive. Therefore, the protective signals are generated and the person remains metabolically healthy obese. On the other hand, if the size increases, there is adipocyte hypertrophy, there is hypoxia, apoptosis, there's increased immune cell infiltration, adipose tissue is under stress. So the stress markers, inflammatory markers are produced. There's ectopic fat storage that is built up in all these different peripheral organs, leading to diabetogenic, atherogenic, pro-inflammatory signals, and the person becomes metabolically unhealthy obese. So the missing link is not all obese individuals display a clustering of metabolic and cardiovascular risk factors. Likewise, not all people who are lean are metabolically healthy and disease-free. And some lean individuals may have metabolic profiles that are almost similar to the obese. So let's look at this again. So this is again what I'm showing you, obesity divided into metabolically healthy obese and the metabolically unhealthy obese. And you can see that essentially high liver fat and abdominal or visceral adiposity are linked to metabolically unhealthy obesity. On the other hand, if the person remains insulin sensitive, there is better insulin secretion, there is cardiorespiratory fitness and lower body subacute fat mass. These are associated with the metabolically healthy obese phenotype. So this is the obesity mortality paradox, again telling you that irrespective of the BMI, it is essentially the cardiorespiratory fitness. It is essentially the metabolic profile that is related to the mortality. So whenever you have a person, be it normal weight or be it obese, if his metabolic health is fine, the mortality is less. But if the metabolic health suffers, the mortality goes up. So this is a study, the CURES data that looked at the prevalence and clinical profile of obesity in Asian Indians, clearly dividing people into metabolically obese but BMI-wise non-obese, metabolically obese and BMI-wise obese, the MOO, metabolically healthy but still obese, and metabolically healthy and non-obese, 4 different phenotypes. And as you can see here, prevalence, 57% were still metabolically healthy and non-obese, and the remaining fraction you can see divided into all those 3 categories. Now, if you look at the prevalence of CAD, clearly in the metabolically healthy obese, the CAD prevalence is much less. But however, if there is an age standardization nullified, then there is no significant increase in the risk of CAD in any of the groups when you compare them to the metabolically healthy non-obese, clearly telling you that there's something more. Now, what are the determinants of metabolic health? Let's look at that. We all know lifestyle, genetic factors, visceral adipose tissue and ectopic fat and inflammation. So we know that increased physical activity keeps away dangerous effects of obesity, and the best example is the sumo wrestlers. We know they are huge people, huge BMIs, but if you look at their metabolic health, they are very, very healthy. Blood profiles are good, excellent glucose tolerance, they're not even diabetic or IGT. But the moment they stop active wrestling, you see a huge increase in cardiovascular mortality in these people, a huge mortality rate of within 1 year. So basically, the moment they retire, it is almost a death sentence for them. And this is where the role of exercise comes in again. So this is a study that looks at the risk of cardiovascular disease, cardiovascular events, and type 2 diabetes in metabolic healthy obesity. And what this tells us is, although compared to the metabolically unhealthy obese, the metabolically healthy obese people have a lower risk of CVD, cardiovascular events, and type 2 diabetes. But when you compare them to the lean metabolically healthy people, their risk is still high. So it does not mean that metabolic healthy obesity does not have an increased cardiovascular risk. So are the metabolically healthy obese always protected? Well, this was a very famous study in weight discordant monozygotic twins, unique study where 16 pairs of weight discordant identical twins. So one twin was obese, one twin was not obese. They were compared. So the intra-pair difference between BMI was a minimum 3, that means 17 kilograms. Young people and metabolic health was assessed. Results were very surprising. In 8 pairs of twins, the obese twin was metabolically healthy, same as his lean co-twin. But in the remaining 8 pairs, the obese twin actually had poorer lipid profile, higher liver fat, increased insulin production and resistance, and higher blood pressure, all hallmarks of metabolic unhealthy. So when they studied what was the difference between the two, what they discovered was in the obese co-twin, there was downregulation of the subcutaneous adipose tissue expression of the mitochondrial oxidative phosphorylation, fatty acid oxidation, adipocyte differentiation, and there was an upregulation of chronic inflammation in these. So all of this we know contributes to complications and disease. Therefore, the study very clearly said that only those individuals who, along with obesity, will develop subcutaneous adipose tissue dysfunction, they develop fatty livers and hallmarks of metabolic syndrome. So clearly it is the inflammation and the insulin resistance which is twisting the story against them. Again, important question is, do the metabolically healthy obese individuals stay healthy for the rest of their lives? Is it just a stage and eventually they do become metabolically unhealthy obese? So the important question is it a myth or the metabolic healthy obesity, is it a fact? Well, the fit fat concept suggests that high levels of cardiovascular fitness will attenuate or potentially eliminate the risk associated with several metabolic and cardiovascular disease outcomes independent of the BMI of the person, even among people who are obese. Now, this was a study that actually assessed this, looking at the exercise tolerance between the metabolically healthy obese versus the unhealthy obese. And what they clearly said was, yes, the exercise tolerance in the metabolic healthy obese was definitely better compared to the unhealthy obese. But clearly, there was still a large fraction of people where obesity was independently associated with reduced cardiovascular fitness. So it does not really mean that the MHO phenotype is free of disease. Again, this is the MESA study, transition from MHO to MUO, clearly telling us that compared to the metabolically healthy normal weight individuals, people who are metabolic healthy obese were not significantly associated with incident CVD. However, when they were followed up over 12 years, what they discovered was almost 50% of these participants did develop metabolic syndrome in their follow-up, and those people who were unstable MHO, that means they converted to MUO. These are the people who had an increased odds of cardiovascular disease. So clearly, MHO is just a transient state, and eventually a large number of follow-up studies have shown how people who are metabolically healthy obese do transform into metabolic unhealthy obese in their lifetime, and it is just a to and fro. They gain weight, they become metabolically unhealthy obese, there's inflammation, the metabolic health deteriorates, they lose weight, implement an active lifestyle, they go back to MHO, so they keep going here and there. That's the unstable MHO profile. And clearly, all these different studies that you see, the Pizarra study, the Northwest Adelaide Health Study, the CPRD database, a follow-up of about 12 years to 20 years, clearly showing that a large number of them do transition to metabolic unhealthy obese. The EPIC CVD study, again, a medium follow-up of about 12 years, clearly telling that irrespective of metabolic health, overweight and obese people do have a high cardiovascular risk compared to the lean people. So the risk is there. And the biggest study, the Nurses Health Study, a 30-year follow-up of these nurses. This was the prospective cohort study. This study again showed that the cardiovascular risk of women with metabolic healthy obesity was increased compared to the women who were metabolically healthy but normal weight. And the risk was considerably higher in women who were metabolically unhealthy and normal weight, women who were overweight, as well as women who were obese. So clearly, the study robustly confirmed frequent transition from metabolic healthy obesity to metabolic unhealthy obesity, clearly showing that across the entire BMI spectrum, there is an age-related deterioration also in the metabolic health that happens. And people who maintained metabolic healthy obesity over a longer time, they still had a 57% higher risk of CVD compared to women who had a stable body weight. So friends, to conclude, fit but fat obesity is just a myth. There is sufficient data to show that obesity in any form is detrimental to health. Metabolic healthy obesity is a concept that is derived from clinical observation that people who are fit, who are fat, appear to be fit in terms of their metabolic health. But most longitudinal studies have clearly demonstrated that metabolic health is not a stable condition. It does not only depend on the obesity status or the BMI, but it deteriorates with aging, and as the metabolic health status changes, so does the increase in cardiovascular risk. So MHO is a transient phenotype which can convert into and from MUO during the natural course of obesity and in response to obesity treatment. Importantly, it is important that timely treatment of obesity should also be recommended to these individuals with MHO, because the risk of developing cardiometabolic disease is still higher than the metabolically healthy lean people. Fat but fit may just be a stage of transition to full-blown obesity with its associated risks, and therefore weight loss, lifestyle management is to be recommended to all individuals who are overweight and obese. Thank you.
Ma'am, for your excellent presentation. Thank you for clearing the concept of fit and fat, ma'am. It's much more vivid now.
Questions from audience? We have the good question and good comment award also, and for each session. So it's not for the award, but it's just to encourage discussion on the topic. If someone has any comment, may I expect some comment from Soumitra? Soumitra, can you have just some comment on this, please? Is the Vice President of RO. Over to you.
Excellently actually discussed by Dr. Jaggi, and it is a transition phase that has to be accepted, and everything has to be, I mean, preventions of complications in the later stage. As Professor Mishra was telling yesterday, the stage 1 and stage 2. So stage 1 will finally go to stage 2. We'll have to understand this. And new classification as described by Professor Mishra yesterday will definitely prove this transition better. But if anyone has to be accepted, then becoming fit is much better in any stage. Even the person is fat, irrespective of the BMI, being respiratory fitness, that is much more important, and everybody has to understand. Thank you very much.
Thank you, sir.
Thank you so much, sir. I kindly request the chairperson to felicitate Dr. Shalini ma'am. I kindly request Dr. Gupta sir to felicitate to chairperson. Dr. Mak.
Thank you. Now, I will like to request Dr. J. Deshmukh sir and Dr. Mukesh Mishra sir to chair the session, or Dr. Anup Mishra sir.
Dr. Jay Deshmukh, sir, he is a very senior physician and director of Sunflower Hospital, Nagpur, and he has been an honorary physician to Honorable Governor of Maharashtra and in Pondicherry, and he has to his credit a number of awards and honors, and we are extremely delighted to have sir to chair the session. And we also have Dr. Mukesh Mishra, sir, who is the founder chairman of Shatayu Hospital as a cardiologist, and he has a vast experience of more than 40 years in this field, and we welcome you both. So over to you, chairpersons.
Well, good morning, all. It's indeed a pleasure to have Dr. Mishra to proceed with his deliberations over here on a very important topic of dapagliflozin and its utility in cardiometabolic profile, particularly treatment of obesity, and how a combination of drugs would be useful in managing type 2 diabetes. There would be many questions, I hope, because this is a very clinically oriented topic. Now over to Dr. Mishra. Thank you very much.
Thank you for keeping that introduction brief. Already Shalini has spoken, and that makes a good background for my lecture. And yesterday, those of you who have attended, also there was a good background. But I'll stress on a couple of things before moving on to dapagliflozin. So part one is adiposity targets for diet and drugs. What are the adiposity targets? And specifically keeping in mind Indian population. So while high body fat clearly matters, abdominal adiposity, hepatic fat, and possibly pancreatic fat matter more for generation of several diseases, and number one of them is diabetes. Improving and mitigating obesity-related disease necessitate concerted efforts aimed at reducing excess these fat depots. And at the same time, lean mass or at least skeletal muscle strength must be preserved. These are the basics. Basics whenever you are attempting either diet or any drug for weight loss. Now, how many people are obese with diabetes? Yeah, this is a 20-year-old study with Nawal and myself in All India Institute of Medical Sciences. When you take BMI, about 70% are obese. When we take high body fat, 87%. So only 13% are non-obese. Or possibly this equation has changed over a period of time. Now, as far as waist circumference is concerned, this is the comparative data which we published long time back. This is the Indian population here, up to here, immigrants, urban, slums, rural, and this is the Caucasians, Mexican Americans, blacks, and the Chinese. Now, if you look at the waist circumference data, our waist circumference is not very high. So that's something which, as compared to other population, is not a immediate matter of concern on the face of it. But even a waist circumference like this can become pathogenic, as I will demonstrate. Now, if you look at it carefully, there are number of studies that we have done over last 2 decades. I will look carefully here. This is the single slice MRI image at L3, L4 in all of our studies. Now, this is the subcutaneous fat. Now, here you see the fascia. Here is the superficial. Here is the deep subcutaneous fat. And here is the so-called visceral fat, which is actually intra-abdominal visceral fat, and there is the perirenal fat, number of fat compartments. I will not go into detail, but just to introduce you so that we have a target of this when we are looking at the diet or exercise or drugs. So this is important. Yesterday I have shown this. Deep is more important. Actually, this is possibly more important than intra-abdominal. So often you will hear in lectures that intra-abdominal fat is something which is culprit and this and that. Actually not. We have done number of studies in the United States and here and clearly shown that Indian population, it is the subcutaneous fat. And mind you, subcutaneous fat is 3 times more in terms of total weight and volume than the intra-abdominal. Intra-abdominal is just 3 to 4 kg. That's all. So it is a wrong perception that intra-abdominal fat is something. Yes, maybe in Westerners, maybe in other population, not in Indian population. This is the deep subcutaneous fat. Now, let's look at the subcutaneous fat, because I will come to this once we are looking at dapagliflozin. Here is the subcutaneous fat of a person with a waist circumference of 90. Now, 90, you will say, well, normal waist circumference. BMI 22.7, normal. Insulin levels already high. Subcutaneous fat area, this is the intra-abdominal fat area. Look at the intra-abdominal fat and just concentrate on this. Let's see the second person. Subcutaneous fat has increased. So, if you look at this waist circumference, slightly increased. The insulin has further increased. Subcutaneous fat area is 137 as compared to, see, 105. And so insulin has increased, subcutaneous fat is the only thing which is increased, and plus slight increase in waist circumference. But if you look at the intra-abdominal fat, not much change. So as subcutaneous fat is increasing, the insulin resistance is increasing. Let's look at this. Look at the thick subcutaneous fat here. Now here BMI is slightly high, but waist circumference still remains the same. This is not question of major increase in waist circumference here. Insulin has doubled. So if you look at the comparative data here, insulin is doubled. Subcutaneous fat area 147 here, 137 here, 105 here. Intra-abdominal fat area 146 here, 142 here, 157 here. Not much change in the intra-abdominal. It is the subcutaneous fat which has made a difference as far as insulin resistance is concerned. So it is imperative that we look at this in every study which attempts weight loss and in attempt to improve insulin resistance and other parameters. Now, the second thing is the liver. Now, if you look at the comparative data between Indian population and the Western population, this is the only study where the two populations have been compared. There's around 17 years old study, but excellent, robust data. And if you look at this, they looked at liver triglyceride using the proton MRS spectroscopy. And if you look at this, the 2.6 times more hepatic fat for same BMI, same body fat. These are non-obese, non-diabetic Indians. So we pack a lot of fat in the liver even when we are non-obese. This is another target. This is another target for diet, exercise and drugs. And we are, of course, more insulin resistant. Let's move on and let's look at the pancreatic fat, a less research entity. Nobody knows in the world what is happening there. We are the only ones from the India who are researching this, and this is a complicated diagram taking from the PLOS1 data that we published some time back, where we looked at pancreatic volume as a surrogate marker of pancreatic fat. And we compared the non-obese diabetic versus non-obese, non-diabetic population. And forget about this skin fold thickness and the various adipose tissue depots measured with the MRI, but just concentrate on this. And the pancreatic volume was high in non-obese diabetic versus non-obese non-diabetic people. This is the only study from India, and we are looking at exact pancreatic fat. I'll show you about that. So this is volume, surrogate marker of pancreatic fat. And this is just to show that this is the non-obese person with the type 2 diabetes, and this is non-obese, non-diabetic subject. Both have different pancreatic volume. It is much higher in this. So what happens in a person with good metabolism? Now, many of you may be having good metabolism. So what Shalini was saying, I don't like this term of metabolic healthy and metabolic unhealthy, but whatever it is, the good metabolism, possibly metabolic healthy obesity. Here, if you take a lot of morning time, 4 vadas and 3 parathas or something like that, excess energy, it goes into superficial adipose tissue, does not go into deep adipose tissue so much. So there is adipocyte hyperplasia, but not hypertrophy. And this does not lead to much of the triglyceride outflow to the liver or pancreas. So there is no or little liver fat or pancreatic fat. So good, that's good. That's good, that's our target. Now, person with bad metabolism, of course, with genetics here, the excess energy, you have 3-4 parathas, all will, the saturated fat will get deposited in the deep adipose tissue. And deep adipose tissue is majorly responsible for fatty acid flux, which inundates liver and, of course, pancreas. And of course, there's some other factors like less brown fat and so on, and there starts the diabetes or increases diabetes. So this is what we need to do. Positive calorie balance, increase in the liver fat, resistance to the insulin, increase basic insulin secretion, increase triglyceride secretion, increase in the, so here are the things which are crucial in the pathway. And the vitamin A increases, which is a damaging hepatokine, and increase in the islets. Here is the subcutaneous fat, which is inundated and throwing out a lot of fat in the liver, subcutaneous fat capacity exceeded. And pancreatic inflammation and decrease in the pancreatic insulin secretion. This is what is happening to all of us. So let's look at the one of the commonly used dapagliflozin. Do we understand what it does to the body? No, we don't, actually. Ideally, an anti-hyperglycemic drug should target glycemia, generalized obesity, abdominal obesity, truncal subcutaneous fat, liver and pancreatic fat depots. It should not lead to sarcopenia. So again, re-emphasizing some of the fact that you should keep in mind. Anybody? What is this? Acanthosis. What else? What else? What else? Somebody? Huge amount of fat deposited into dorsocervical region, what is called as buffalo hump. This is not a patient of Cushing syndrome. This person is diabetic. Early age diabetes. Clearly, these two signs are clearly indicating he may have a double chin also. That's a third sign. Here is a 45-year-old male with severe acanthosis indicating excess dorsocervical fat with weight of 97 kg, BMI of 37.5, waist circumference of 120 centimeter, clearly abnormal, fasting blood glucose 178, A1C 8.6, body fat of 42%, usually 25% is the limit. Liver span of 21, the usual liver span is 13 to 14 centimeters by ultrasound. You can do it, and a good indicator of metabolic state of the body. So, but Indians probably 10 to 11 is the upper limit of liver span. So double the amount. KAP control action parameter by the fibroscan is 362, upper limit for 400. KPA indicative of fibrosis 11.6, indicating moderate fibrosis on fibroscan, and fatty pancreas on ultrasound, and if you do MRI. So this is the profile that we are going to study. What will dapagliflozin do? So we know by look ahead study that if we lose 5 to 10% of the body weight, then there will be substantial decrease in A1C, systolic blood pressure, diastolic, increase in the HDL cholesterol, and decrease in triglycerides. So even a little bit of weight loss will produce wonders. And we are looking at that much weight loss. Of course, if it's more, well and good. Here is the dapagliflozin and weight in, if whatever be the background therapy, whether it's a metformin, sulfonylurea, or even insulin, then around 2 to 2.5 kg weight loss is there with dapagliflozin. Let's look at Indian population. And this is the intermediate weight loss. This has been said in Diabetes Care publication. Intermediate weight loss as compared to GLP-1 receptor analog, which is intermediate to very high. Now, this is our study, which we published in 2018, 12 months follow-up, real world data in North India, 1,200 patients. The weight loss is more in Indian population, 3.7 kg. At the same time, there's substantial A1C reduction. So 3.7 kg, probably more in Indian population. But then this is just one study. And this is the best study, Bolinder's study in 2014, which compared a 24 weeks international multicenter randomized parallel group double blind trial. One of the best trials, still stands for any SGLT2 inhibitor. 182 patient with the type 2 diabetes, dapagliflozin was compared with placebo and metformin treatment. And if you look at this, there's a substantial decrease in the weight loss. At the same time, the urinary glucose increased and blood urea slightly increased because of loss of fluid. It's an excellent study. Now, if you look at the DEXA data from the same study, DEXA and MRI data from the same study, now placebo with metformin, dapagliflozin, this is the fat and lean mass. So there is a decrease in the lean mass as well. Beside 3/4 fat loss, 1/4 or 20% about lean mass. On MRI, there is clear-cut decrease in the intra-abdominal fat as well as subcutaneous fat. Look at this. Excellent. This is what we want, both. So waist circumference lost by 3 centimeter, fat mass lost by 2.2%, and more than 5% weight loss. That's what I was talking about, 30%. So we are reaching there. And we know that obesity, lot has been talked about obesity and risk of heart failure, which increases with the grade of obesity, and dapagliflozin reduce weight in every grade of obesity and also decrease the cardiovascular renal endpoints, more so in people who are more obese. And if we combine with dapagliflozin with low carb diet, 17 patients, and they were on low carb, less than 100 gram diet with plenty of protein and fruits and vegetable. After 12 months, mean weight loss was 8.1 kg. So we combine the two, we produce more. And this was mediated by reduced fat mass, clearly reduced fat mass. Lean mass increased by 1 kg. Now, this is important. Lean mass increased. Why? Because they gave a lot of protein and they did a lot of exercise. Now, let's look at Indian data. This is our study, the only study for such population published in Journal of Clinical Endocrinology and Metabolism. We took overweight and obese patients 20 to 50 years, A1C uncontrolled, stable dose of metformin and sulfonylurea 8 weeks, and then we gave dapagliflozin for 120 days. And we did hepatic and pancreatic fat estimation using MRI proton density fat fraction. This is very accurate for liver and for pancreas. So these are some of the voxels. There are 9 regions of interest in liver and 3 regions of interest in pancreas. This is the report of a patient. Right lobe, that 30% approximately is the fat, and pancreas about 6 to 7% is the fat. Now look at this. These are skin fold thickness of multiple regions in the body, which indicate subcutaneous fat. And after dapagliflozin, subcutaneous fat throughout biceps, triceps, subscapular, suprailiac, lateral thoracic, thigh, calf, peripheral, everything decreased. So subcutaneous fat decreased, that's where our interest is. And at the same time, C-peptide improved and insulin levels improved. And if you look at this, weight decreased by 3.79 in 120 days, waist circumference by 4 centimeters, skin fold by 16 millimeter. Excellent. And hand grip, indicative of muscle strength, skeletal muscle strength and sarcopenia improved on dapagliflozin. I'll just take 1 minute. And this liver fat, very importantly, liver fat decreased by 5%. In a diet study, it decreased to 10%. And pancreatic fat decreased by 1.5. Substantial reduction of liver and pancreatic fat, improving metabolism throughout. So if we decrease weight by dapagliflozin or we improve the diet, liver fat becomes normal, insulin resistance decreases, there is decrease in the triglyceride outpouring, decrease fatty pancreas, fat in the pancreas, and normal insulin response to ingested glucose. That's what is happening in this case. So here is a 45-year-old male with severe acanthosis nigricans, buffalo hump after 3 months of dapagliflozin, reduction of body weight to 93 from 97. This is extrapolation from our study. So I'm not making it up. Approximately what our study said, I have extrapolated here. BMI to decreased, waist circumference by 4 centimeters. That's what happened in our study. Fasting blood glucose 130, A1C decreased to 7.5, body fat to 37 from 42, liver span to 19 from 21, and on FibroScan, CAP decreased from 362 to 321 and KPA to 10 from 11.6. Everything improved. So we have, for the first time, Indian data. Now you will see a lot of Western data, but there is hardly any Western data even on this liver and pancreatic fat. This is the only study in the world. And so Indian data, we have to believe Indian data. We cannot just go on quoting the Western studies. These are all Indian data. So what will dapagliflozin do? Use of this drug led to reduction of all important glycemic and obesity parameters. The key benefit of SGLT2 inhibitors, in this case dapagliflozin, addressing hyperglycemia and diabetes, contribution weight loss, impact on subcutaneous fat, reduction of abdominal obesity, positive effect on liver and pancreatic fat. Targeting basic pathophysiology, SGLT2 impact on core diabetic pathophysiology, which I showed you. Holistic approach to disease management and personalized approach, individualized to better metabolic health. Combine the diet, it will be more individualized, and possibility of diabetes remission with this kind of therapy. So thank you again, Sunil, for
you very
giving me
much.
this opportunity. Thank all of you, organizing committee. They have worked hard to make this symposium a success. Lovely to be in this beautiful city of Nagpur. Thank you.
Sir, are there any head-to-head comparisons between different gliflozins in their ability to reduce weight? And number two is that in patients who are non-diabetic but with metabolic syndrome, would you recommend dapagliflozin?
So number one is there is a head-to-head comparison as far as the body fat, and there is hardly any. I have told you there are hardly any data. Bolinder study is the only one which is well conducted study, and our study is the other one. There's hardly any data as far as pancreatic and liver fat is concerned. So though we use every day, actually this research in this area is totally lacking. As far as the non-diabetic is concerned, there is no legal statute there. But what I'm doing out of label, if there is a pre-diabetic person with that kind of profile, I'm using SGLT2 inhibitor or even GLP-1 receptor analog to reduce their weight, and after telling them what are the pluses and minuses of this.
Very excellent lecture. We have been listening lectures on dapagliflozin for so many months. In few aspects, pathophysiology, which you have shown, it is very enlightening. Now, if there are any questions from the audience.
And I had request the chairpersons to felicitate the speaker. I kindly requested the next session chairpersons, Dr. Abhiram Paranjpe sir and Dr. Sunanda Chowji ma'am to come on the dais. Dr. Paranjpe is a well-known gastroenterologist of Nagpur, and Dr. Chowji ma'am is an associate professor of medicine in NKP SIMS. She is a consulting physician, a very known, well-known physician of Nagpur.
Yeah. May I invite the next speaker? What is the schedule?
I request Dr. Amit Gupta sir to come on the dais.
Thank you, ma'am. Thank you for the kind introduction. And I am thankful to Dr. Sunil Gupta sir and Dr. Mahinder Narwaria sir and Bansi Sabu sir for giving me this opportunity to talk about the effect of physical activity on adiposity and the aerobic fitness. So I think this is a very, very interesting topic, and I know a lot of about obesity has been discussed. I thought I will just touch upon some important aspects. So if we look at the physical activity spectrum, so physical activity spectrum can be classified into these 5 major categories. One is that is a sedentary behavior. Second is low intensity activities, which are like slow walking, 1.5 to 3 minutes of the energy you spend. Then there is a moderate intensity category. Then there is a high intensity category. And then we have the high interval intensity training category. So broadly, all of us can be divided into these 5 major classes. तो फुल स्क्रीन कर सकते हो इसको? So with this physical spectrum, it is important to understand that what is the influence of the genetic and the environmental factors on the physical activity. So if somebody is having active lifestyle or the inactive lifestyle based upon the 5 categories which we have discussed, or whether they are meeting the physical activity guidelines or not, you have a environment where somebody may be having physical activity, doing physical exercise, or some may be engaged in the activity which is considered as a sports activity. People with the sedentary behavior, any activity during like walking hours with a low energy expenditure close to resting state, like sitting, recycling, or laying. And then physical fitness has multiple components, whether it is a cardiorespiratory fitness, musculoskeletal strength, or the motor fitness and the body composition again. So all these parameters, it is a complex milieu where the genetic as well as the environmental factors, they play important role. This is just to demonstrate that what is the impact of the aerobic exercise as well as the resistance exercise when it comes to on the effect of the mitochondrial function as well as the muscle hypertrophy. Not going into the details of these complex pathways, but the aerobic exercise, which includes endurance exercises and the high intensity interval training, they ultimately leads to improved mitochondrial functions. Also, they lead to improved mitochondrial biogenesis, while the resistance exercises, whereas there is mechanosensation and the muscle stretch is there, through different pathways, P13 pathway as well as the calcium signaling, they lead to muscle hypertrophy and again mitochondrial biogenesis. This is just to showcase that what happens with the aerobic activity and what happens with the with the anaerobic physical activity. So resistance training. With the aerobic physical activity, there is an increase in the muscle mass, oxygen uptake increases, there is a decrease in blood pressure, heart rate, angiogenesis improves, insulin resistance improves, inflammation decreases, and browning of the fat happens. While with strengthening exercises or the resistance exercises, there is increase in muscle mass, strength. Also, there is a reduction in blood pressure, improvement in angiogenesis, reduction in insulin resistance, but browning of the fat is something which is questionable with the resistance exercises. So this is very important to understand that I know this has been discussed multiple times. So we have a healthy adipose tissue, and because of the obesity and the lack of the physical activity, what is happening in this healthy adipose tissue is that there is hypertrophy of the adipocytes. The adipocytes are becoming hypertrophied. There is inadequate angiogenesis which is happening inside the fat mass. Also, there is increased apoptosis. And there is increased macrophage infiltration. You can see these green and gray cells. These are increasing the macrophage infiltration in this population. and inflammation and the fibrosis is happening. You can see the collagen getting deposited. So this is how the healthy adipose tissue gets converted into, leads to adipose tissue dysfunction. This slide depicts what is the effect of physical activity on various inflammatory markers like IL-6 and soluble IL-6 levels before exercise and post-exercise. And post-exercise, in studies, it has been demonstrated that the inflammatory mediators of the adipocyte dysfunction, they decrease. This is to demonstrate the different signaling pathways which actually work when it comes to the adipose tissue dysfunction. In this, IL-6 is binding with IL-6 receptor, and this IL-6 receptor and IL-6 complex then binds with GP130, and this is the classical signaling is happening. But in the trans signaling, the soluble IL-6 binds with the soluble IL-6 receptor, and they simply bypass the IL-6 receptors which are expressed on the membrane. And in the no signaling, where soluble GP130 binds with the soluble IL-6R and the IL-6 receptors, and there is a blockage of these signal transmission. So this is how the adipocytes expression of the different inflammatory markers happens. And just to understand that what is the effect of exercise on the adipose tissue dysfunction. So we understood that how the adipose tissue becomes dysfunctional and what is the impact of the exercise. So at the local level, there is a decrease in inflammation. There is increase in vascularity following exercise. There is decreased fibrosis, reduction in the cell size, increased insulin sensitivity, increased sensitivity to the stress, as well as decreased lipolysis at the resting position. And what is happening in the skeletal muscles? There is increase in insulin sensitivity, increased metabolic flexibility, increased mitochondrial function, and decrease ectopic lipid deposition and improved glycogen storage. So these are all the physiological effects of the exercise which are manifested at the tissue level as well as the muscle level. This is again important when we talk about the high intensity training or interval training. What happens in this, that is the EPOC, is the excess post exercise oxygen consumption. So after the physical activity, there is increase in the EPOC levels. And this EPOC levels promotes lipolysis and improves insulin sensitivity, while there is a restoration of the glycogen depots and increased oxidative phosphorylation and the protein turnover. So this is a complex interplay between the adiposity, adipocyte dysfunction, which is regulated by the inflammation as well as the metabolic control. We have some anti-inflammatory mediators like M2 macrophages phenotype, while key pro-inflammatory mediators are like M1 macrophage phenotype and different inflammatory biomarkers. So this slide actually summarizes that what is the impact of any kind of physical activity on different reducing body mass, fat mass, hepatic muscle, as well as the abdominal fat, adiponectin, and improve insulin sensitivity. So what is happening in the skeletal muscles? Skeletal muscles, we know there is a increase in muscle strength. In bone tissue, there is increased bone mineralization and decreased bone resorption. While at the respiratory capacity improves, intramuscular adipose tissue decreases, while intermuscular adipose tissue increases. Immune system, there is increased circulating immune cells, cytokines and C-reactive protein. Cardiovascular system, we know cardiovascular health improves. Respiratory system, increased alveolar ventilation and increased pulmonary blood flow happens. GI system, there is changes in the GI motility as well as the absorption in a positive way. Endocrine system, hyperactivity phase, there is initially, which is there is an increased ACTH, cortisol, prolactin and catecholamines, and then there is a hyperactivity phase. So these are the different changes which are brought to at different organ system level following the physical activity. Another important factor is that whenever there is a consumption of the high fat and the high sugar intake, yesterday different classification of obesity was presented here. So it can lead to two types of storage. One is the healthy storage and one is the unhealthy storage. I will not go into the details of the pathways, but physical activity can actually divert this high fat and high sugar towards the healthy storage pathway rather than the unhealthy storage pathway, reducing the risk of any further complications due to obesity. This is very, very important. From the evolutionary point of view, we have evolved as a more active being. But what has happened is that we are becoming less and less activity. Evolutionary, we were not designed to sit the chairs. We were not supposed to sit throughout the day. We were supposed to move throughout the day. But now this is our characteristic phenotype, and we know that this has led to decrease in estimated physical activity levels and a decrease in total energy expenditure and the basal metabolic rate. If you just look at this slide, this actually summarizes the day of a normal person in 24 hours. You get up at 6 a.m., you are still sitting. 6 to 8 a.m., again, you are busy doing your daily routine activities, but there is no physical activity at this point of time if you are not doing any dedicated activity. 1 hour, if you are spending in traveling, again, you are sitting in your car or in some other part of your day. Again, in the office, 9 to 12:30 p.m., again, you are busy sitting, you are doing all the desktop work. Then during the lunch time, we are chit chatting with our friends, we are taking lunch, again we are sitting. Then again the second shift of the office hours, we are again sitting, going back to home, again sitting. Maybe you may be doing some physical activity for 1 hour in the evening, that has been included. But after that, again, what is happening? Again, tea time, chit chatting, watching TV, and retiring to the bed. So we are spending a lot of time in a inactive stage. So this is something very, very important, and this brings up the concept of the NEAT, that is the non-exercise active thermogenesis. And why is it important? Because non-exercise active thermogenesis is all the movement that is not a structured exercise. And when we are spending most of the time in sitting, we are not actually improving the NEAT. So walking your dog, pacing on the phone, cleaning the house, any light physical activity, 1 hour of exercise is equal to 4% of your day. It is nothing. While NEAT constitutes 63% of your day, when most of the time we are sitting. So they are now constantly we are talking about this concept of increasing physical activity during the active part. So what is NEAT and why it is an important part of total daily expenditure? So this concept was brought up by Levine, and it defined non-exercise active thermogenesis as the physical activity other than volitional exercise, such as the activity of the daily living, any spontaneous muscle contraction, and maintaining posture when not recumbent. And together with the resting energy expenditure, postprandial thermogenesis and physical activity thermogenesis, NEAT composes the total daily energy expenditure. Many of the times we have seen in the slides that it is difficult to improve the active physical activity and then reduce the burden of the excess calories. But this is an important slide where you see here is a person who is completely chair locked throughout the day. He may only spend 150 odd calories during the daily physical activity, during the chair locked sitting day. Here is a person who is not sitting throughout the day. He is doing some of the work while walking. He parks his car a little away from the office, walks, takes around some stroll during the lunchtime also, and is trying to keep himself active. So he may end up burning almost 55-60 calories. And this is a NEAT athlete, you can say. So this person goes to the work by a bicycle. Throughout the day, all the work is done standing. There is no sitting involved. The person also during the lunchtime goes for a walk. So this is the highest level where somebody may end up even burning 1,000 calories in such a state. This was the ADA standard in 2015 and 16, and they were promoting this, that every 90 minutes we should be breaking the cycle of sitting. But now with the latest ADA and the ESD update, it says that it should be the sitting should be broken up every 30 minutes. So we should not be sitting for more than 30 minutes. So this is a very important change which has happened, and it clearly states that limit sitting. And there is a term called sitting sickness. I think next time when we are talking about physical activity, this is very, very important, that sitting sickness or sitting disease. This is a common terminology which is very often used nowadays. So we should be looking to break the prolonged sitting with short regular bouts of slow walking or simple resistance exercise, which can improve the different stages of the metabolism. Now coming to last few slides where I will be talking about the recommendations. So this is the recommendation of the American College of Sports Medicine and the CDC. And it talks that at least 150 minutes of moderate intensity aerobic activity every week is to be done. And at least 2 times per week, muscle strengthening activities on 2 or more days a week that work all major muscle groups should be taken. This is the WHO guidelines, and WHO clearly states that what is to be done in children who are 1 to 2 years of age. So the screen time, WHO says that at 1 year of age, 0 screen time. So no children should be given any kind of mobile phone or the screen devices during the first year. This is the WHO guideline, and no more than 60 minutes in a 2-year child, in a child of 2 year of age. Physical activity at least 180 minutes. So 3 hours of physical activity is recommended by WHO in a child who is around 1 to 2 years of age, and good quality of sleep around 11 to 14 hours. This changes in a child of 3 to 4 years of age, and it says that sedentary screen time should not be more than 60 minutes. So up to 4 years, screen time, again, it should be less than 60 minutes. Physical activity, 180 minutes, and it says that, clearly says that, of which at least 60 minutes should be moderate to vigorous. So child should be playing some active sport during this period of time. And again, good quality of sleep, less than the earlier age, but 10 to 13 hours of good quality of sleep. So what is WHO says that every move counts. So it is important that we should limit sedentary time wherever possible, replace with at least some physical activity, and something is better than doing nothing. So for special populations like pregnancy and postpartum women, 150 minutes per week of the exercise is recommended. Adults and older adults, 150 to 300 minutes per week, and 60 minutes per day in children and adolescents. At least on 2 days a week, muscle strengthening activities should be done, and or at least 3 days a week, multi-component activities for balance and strength can be taken in older adults, because balance becomes a major problem during the aging and the elderly population. And this is important to read that everyone should aim for this. If anyone who can achieve this more than 300 minutes per week, more is better. So this is clearly the statement from the WHO. This is the culture. I think one of the good idea of breaking the sitting is that we can have standing workstations, which is very, very popular now. So this is something which can be considered. And what is needed to promote physical activity? So why it is not promoted? So we have understood that lack of physical activity leads to adipocyte dysfunction. Inclusion of the physical activity can reverse the cycle and can lead to adipocyte dysfunctions to healthy adipose tissue. Physical activity can divert the fuel from healthy metabolic to the healthy metabolic pathways rather than the unhealthy metabolic pathways. And we need to have global physical activity levels and trends. Evidence-based interventions, which are very, very important. Learning to like exercise. Many of the time, people, they have never done any kind of regular physical activity. So developing a liking for the exercise is again very important. And maintaining physical activity is something which again will help in promoting the physical activity. So I am very thankful to you for your patience listening.
Thank you, Dr. Gupta, for a wonderful lecture. Especially the concept of NEAT is very, very important. It is said that sitting is new smoking. So sitting is as hazardous as smoking. So importance of exercise is very, very.
I think Dr. Sunil Gupta has ensured that none of us sits in chair for more than 30 minutes. So we must thank him.
Thank you.
And we thank him for, yeah, you can have the question.
Of our also, not for the patient, for doctors. I just have one question and one share. One question is that adults, they always give this school. Really, we are morning 7 to 8 at least in the evening. What we should because most of the schedule they are not part of arrow. What we can relations to the school authorities so that they can implement even a small change can make a difference.
I think, ma'am, we should be promoting regular physical activity as a advocacy point of view from RO. This can be done, and as we have shown in slides, doing something is better than doing nothing. And second important thing is that right in the second slide, I've shown that the environment is very, very important. Suppose somebody wants to do a physical activity, but there are no cycle tracks. Yesterday, Dr. Bansi also talked about that. If there are no cycle tracks, there are no safe spaces where children can play, then even if somebody is willing to do physical activity, they may not find the right environment. So I think as a society, as a NGO, we should be working more on this aspect, that how to ensure and provide the safe and safe places to engage in regular physical activity.
Because on World Obesity Day on occasion, that is on
March.
2012, that is long back in Aurangabad, we have given an application to the collector and all these things. At least they can make a safety roads so that children, if they don't have the different time, they can go on bicycles for the school or classes nearby. And once they become active, the activity, of course, will go up.
I think, ma'am, it is a constant endeavor, and we should be doing it regularly. There are events like Rahagiri by Times of India, where they claim the streets and they engage in physical activity on that particular day. So I think there are a lot of new ways and modalities by which it can be done.
Yeah. And another one important share is that I'm a faculty for the scope, that is a strategic certification of obesity special educations. Whenever you used to conduct the scope schools for the doctors also, in between the two lectures, there used to be gap of 10 minutes. And whatever you want to do, you want to dance like anything, dance also. And that is the good thing apply in our
So
organization.
Mahendra Darwaria sir can incorporate this in RO conferences from next time.
So we short
that
of
is
time,
need of
madam.
our also.
Yeah. Actually, we have to finish the talk now.
Yeah.
Thank you.
so
Thank you,
much.
sir.
Thank
Thank you.
Thanks, sir, for giving us opportunity also.
I kindly request the chairperson to felicitate Dr. Amit Gupta. I kindly request Dr. Sunil Gupta, sir, to felicitate the chairperson.
Forward to the next session. I request Dr. Rajesh Misar sir, Dr. H.S. Bora sir, and Dr. Varsha Dahane madam to please come and chair the session. I request Dr. Anjali Nakra ma'am to come for the session. Thank you. Ma'am is going to speak on chrononutrition link between meal timing and obesity management. Dr. Bora sir is a well-known physician in Yavatmal and now in Nagpur also he is working in Kingsway Hospital. Dr. Rajesh Misar sir is a senior physician and well-known diabetologist. Dahane madam is a well-known dietitian and weight loss expert of Nagpur. Thank you.
Will I begin?
Hello. So now we are starting very interesting session on nutrition. So there is a very important topic whether there is any chronological link between the meal timings and the development of obesity. So I request our speaker, Dr. Anjali Nakra madam, for this lecture. She has got very large her introduction, so I'll just brief. She is a founder of health clinic in Delhi, lifestyle medicine. She has got family physician, see all the patients of all age groups. Ministry, she had been medical officer in the ministry office, health at Abu Dhabi, and so many credits to her this thing introduction. So without wasting time, I will request her to start her lecture.
Thank you. Thank you so much. So congratulations to the organizers, Dr. Gupta and Dr. Kavita, for the excellent conference. And thank you for giving me the opportunity to speak on chronometer link with obesity. This is the outline of my talk. So we've been talking about the pathogenesis of obesity being complex. So from a nutrition perspective, the focus has been on what to eat and how much to eat to reduce the obesity burden. But now there is increasing evidence that when to eat is fundamental to human metabolism, and aligning the feeding patterns to the 24-hour circadian clock has multiple metabolic benefits, with weight loss being an important one. The circadian rhythm is the biological pattern which is the 24, which links with the 24-hour time schedule day-night cycles, and each cell in the body has its own clock, and it is driven by a transcription translation feedback loop of the core clock genes. The central control is the suprachiasmatic nucleus. There are other non-suprachiasmatic nucleus centers in the brain which are linked with this, and then there are the peripheral clocks in the liver, gut, adipose tissue, muscles, which are all important. So the environmental cues or the Zeitgebers are different. Suprachiasmatic nucleus, it's a day-night cycle, and for the peripheral clocks, it's the fasting feeding cycles. Fasting feeding cycles are more called in the local physiological processes, and the central clock is more about the behavior and the feeding patterns. There is a diurnal rhythm for all physiological parameters, cytokines, adipokines, inflammatory markers. Everything has a diurnal variation. Why is this important? This diurnal rhythmicity helps to compartmentalize the major catabolic and anabolic processes. Genes that are active and peak during the day are mainly associated with glycogenesis and lipogenesis. In the fasting phase, the genes responsible for growth, repair, glycogenolysis, and lipolysis. Now, if the day night cycle and the fasting feeding cycles are not aligned, there is a disruption of the circadian rhythm, and this misalignment can disrupt the body's metabolism and contribute to disease. Whatever the cause of the circadian disruption, it leads to obesity, metabolic syndrome, cancer, cardiovascular disease, mood disorders and depression, cognitive impairment. All of these can happen with chronodisruption. How does chronodisruption happen? Is through exogenous and endogenous sources, so nocturnal light exposure, transmeridian travel, the social jet lag, that is the difference. If there is a lot of difference between our sleep timings and meal timings during the week, it leads to social jet lag and subsequently the metabolic jet lag. And shift work, of course, is another source. The endogenous sources are genetic variants, sleep disorders, and aging, because there is age related dampening of the molecular circadian rhythm. And all these can cause circadian disruption. All these cause misexpression of the clock genes, decrease in melatonin levels, increased in the cortisol levels, poor sleep patterns, and increased energy and fat intake. This metabolic derangement and dyslipidemia and fat accumulation finally lead to obesity. So the diet protocols that we have been following so far are the calorie restriction majorly, but it is a resource intensive approach and difficult to sustain over time. Intermittent fasting involves intermittent periods of eating deprivation, can be alternate day fast, alternate day modified fast, the 5-2-4-3 diets. And in this, the fasting day, the limitation of the energy restriction is 100%. But calorie restriction and intermittent fasting are not strictly a part of the chrononutrition strategy, as the focus is not about aligning meal times with the biological. This is another depiction of how the meal timings and the meal patterns and the calorie intake is there during the calorie restriction, intermittent fasting, and the time restriction. Chrononutrition is the relationship between the temporal eating patterns, circadian rhythms, and metabolic health. It has two components: dietary component and the temporal component. While the total energy intake is important, the nutrient composition and social context are also significant parts of the dietary component. The temporal component is about food frequency, regularity, timings, the eating window, and specifically the nighttime fasting. Macronutrients, phytonutrients, bioactive compounds, they all regulate the expression of many genes, including the clock network. High fat diets are the best known circadian rhythm disruptors and lead to reversal of patterns. It can modify the circadian synchronization to high salt intake can also cause phase delay in the gene expression of clock gene. And distribution of macronutrients in a meal is also important. The same meal consumed at circadian cycle can have varied impact and can cause dampening of circadian rhythm. The dampening of circadian rhythm by a high fat diet can be mitigated to a great extent by just having the meal with the daylight within the diurnal. Caffeine also lengthens the period of the cellular clock, so the cellular circadian clock. And regarding the bioactives, melatonin, best known bioactive linked to circadian rhythms, and while it is a bioactive compound, but it also exists in natural foods, poultry, nuts, fruits, and seeds. And this is the way it can help in it can make changes in polyphenolic compounds or phytonutrients. Again, important. I'll just give one example. Resveratrol has been shown to cause improvement of insulin, glucose, lipid metabolism impairments caused by chrono disruption, and the prevention of neuron damage and impairment caused by circadian disruption. So many of the phytonutrients are known to have impact on the cellular on the clock cycles, either directly or through gut microbiota or by modulating the clock gene. Coming back to the high fat diet and circadian disruption, high fat diet can lead to disruptions in the circadian patterns of behavior, lipid, and glucose metabolism. And it can influence both the central and peripheral. The peripheral clocks, in any case, have are more linked to the fasting feeding patterns, but even central clocks can also get a high fat diet. And alterations in the level of fatty acids and glucose affects other nutrient sensing mechanisms, which further affect the molecular clock, and thereby the fat and sugar intake is linked to. Current evidence supports the idea that the amount of nutrients is more important rather than. Coming to the temporal component, time restricted eating is a dietary approach that consolidates all intake to predetermined periods, 6 to 10, 4 to 10, 4 to 12, whatever works for the patient during the active phase of the day. And there is no necessary alteration in the diet quality and quantity. What is an eating window? It is defined as a caloric or any other ingestion event that may affect a neuroendocrine, endocrine, or metabolic factor that is associated with the state of fasting. So even as much as 5 calories can break the fasting cycle. Artificial sweeteners, caffeine, they all break the fasting cycle. So although most TRE trials in humans do not restrict calorie intake, but it has been found that even when they are eating ad libitum, they still commonly reduce their calories by 7 to 22%. And higher levels of adiposity have been shown cross-sectionally to be associated if the midpoint of the calorie intake is late in the circadian phase compared to lean individuals. So the midpoint is is that time of the day when we have consumed 50% of our total calorie. And the later the midpoint of our calorie intake, the weight gain the adiposity tends to be higher. So melatonin also has a role in this because melatonin can attenuate the glucose induced insulin release from pancreas, and thus eating very late in the night can have an impact on adiposity. Adherence has been found to be better compared to calorie restriction. So it's easier to tolerate, easier to implement for most people. There is so 55% over 12 weeks, 62% over 10 weeks, and 84% over 6 times. Now, Martins et al. Have shown that improved adherence from 84 to 95% happened when the window was extended to 8 to 8.5 hours a day. So, to increase the compliance of a patient, we can always customize the window according to the patient's requirements and what is comfortable. Outcomes of time restricted eating is weight loss, glycemic control, biomarkers, cardiometabolic health improve. The mechanisms have been the mechanisms which are being investigated are modest energy introduced by TRE protocols, but which is also consistent, and the alignment of meal timings with this, and the improved metabolic profile. These are some of the molecular mechanisms which work. The improves appetite control, adipokines, improves the functioning of energy sensors like AMPK pathways, sirtuins, improves mitochondrial function, and it enhances browning of the white adipose tissue, modifies the metabolic switch, because changing the use of glucose towards potential use in bodies from fatty acid oxidation during the fasting period is also helpful. Gut microbiome diversity there's an improvement in circadian regulation and increase. What is a best window? There has can have early TRE or late TRE. In early TRE, the eating window starts at 7 or 8 a.m. and in late TRE starts after 12 p.m. There is a mid TRE also, but I will not go into that. So early TRE people tend to skip dinner and late TRE people breakfast. Randomized control trial of time restricted healthy volunteers without obesity in 90 participants, divided into 3 groups: evening TRE, morning TRE, and control group. They showed there's a lower body mass, lower adiposity, lower inflammation, more diverse gut microbiota, improvement in insulin sensitive plasma in early TRE group. There's also, but we must understand that there is unlikely to be a single window which we can say works for everybody. So circadian preferences like the morning chronotype and evening chronotype the chronotype has to be taken into consideration while prescribing a TRE window. The evidence has come from shift workers, study of chronotypes, genetic studies, But first, I'd like to show the eating patterns in India. Gupta, Kumar, and Panda observed. This is an observational study. 94 participants over 3 weeks. They took all the fetograms of all the participants and realized, along with the meal timings, and they realized 60% of the cohort ate in a 15-hour or more window. That's a long time. And less than 30 calories consumed before noon and more than 30 calories evening. So what we eat more in the night is rice, dal, chapati, vegetables, ice cream, milk, and sweet, and salads. So this is where TRE can be beneficial. Shift work, there has been a long study, a British cohort, which has shown that shift work is detrimental to metabolic health. And in a study performed by Di Lorenzo, they showed that the prevalence of obesity in shift workers were 20% compared to 9.7%. Chronotype differences in the body composition are important, and in this review, it was observed a cross-sectional analysis showed that eating behavior and dietary intake, there were different patterns in late chronotypes, and they tend to have higher rates of obesity. There are clock gene variations because your whole process is controlled by some genes, clock genes, and so the circadian rhythms, food timings, and obesity. This study showed that if there are genetic variations or SNPs, the clock gene, they are associated with variations in energy intake, waist circumference, obesity, and metabolic disease. These genetic variants associated directly with obesity or by modifying different behaviors like emotion, and stress eating. So changing the when we eat has an important impact on this on if we have any. So high methylation levels have been observed in the clock gene. They have been observed that obesity genes expression gene expression can be regulated by epigenetic mechanisms targeted. I'll just quickly go through this studies. But this is an animal study, it's a landmark study where at Salk Institute, where Dr. Sachin Panda's lab, they divided isogenic mice into various groups: obese mice on high fat diet, lean mice on high fat, high sugar diet, lean mice on high fat diet, but with a weekly schedule, weekday schedule. And they were divided into ad libitum, 9-hour, and 12-hour groups. There was a consistent decrease in the fat mass in the 9 and the 12-hour group, being more in the 9-hour group compared to the 12-hour group, with preservation of lean. That was a significant part. So they concluded that confining the food access to active phase without calorie restriction, even when briefly interrupted on weekends, is effective against high fat, high fructose, high sucrose. Another study, this was a single arm paired sample trial, 19 participants with metabolic syndrome. They were asked to select a 10-hour window for 12 weeks. They found weight loss, improvement in the metabolic parameters, reduction in weight circumference, percentage body fat, and visceral. This was another study by Gill and Panda, where they used a smartphone app, My Circadian Clock. First, they followed the eating patterns of the people for 3 weeks, and they found 14.75 hours was the eating window in the US, and significant weekend eating patterns were there. So for 16 weeks, 8 people were recruited for self-selected 10 to 12-hour window. I just need a couple of. So this was the window, and this was the weight loss, which was consistently even after 16 weeks. Most people followed the time restricted eating pattern and lost weight. Skip this review. So, but a good practical way to get patients to move on to time restricted eating is to ask them to avoid food for at least 1 hour after waking up, and to avoid food 2 to 3 hours before bedtime. This 2 to 3 hour window before bedtime helps in uh, impact on the insulin release. And so to conclude, time restricted eating is a potentially low cost and sustainable lifestyle prevention. Modifying the diet according to metabolic cycle is helpful in weight loss. Consistent window of 10 hours or less is early TRE has metabolic benefits of late TRE, and behavior modification can help in weight loss even in the presence of genetic variants of clock gene. Thank you for your patience.
Thank you, madam, for that enlightening us. There are few points, even if we go back to our society, because everybody knows that there is no ideal human diet till date, and there is no ideal timing for the human, because it all depends on where you live, what geographical area, what environmental conditions, because the people living in the polar areas where darker nights, longer nights are there, you really don't know. But I think we are blessed in the India that this is the only country you will find all 3 seasons distinct and daily sunlight most of the times. So our society has been designed like that, because if you go to our religious practices, all religious, including particularly Jains, you will find that they will start eating at 9:30 and they will end up at 6:30. So that is their pattern. That is the way they live, and that include that says that it automatically goes to the 17 hours of fasting. If they stop eating at 6 p.m. and they start at 9 o'clock, automatically it goes to the 17 hours of fasting. And we can add a trick to this, that if we have to give a time restricted feeding, so we can design a meal which is high in carb in the morning hours, and at the days goes on, there is no carb after 4 p.m. So that trick might work for the patients.
Yes.
And
the
we need to also
composition is
clarify that what do you mean by the high fat diet? Because there are so many fats which are healthier also. There are so many fats which are bad for our health. I think we should clarify on that to our patients, that what do you mean by high fat diet? Because most of the times fats probably from the vegetarian origin, little bit of healthier fats are there also. For example, the fats coming from the avocado, they are one of the most healthier one. So I think we need to trick all these things during this to make it more successful.
Yes, I think there is a lot more to it.
Lot more to
I
it.
could not cover more than this
Yeah.
in this such a short time. But yeah, absolutely right. Yes, so there is a
Fatty diet.
yeah, so in ketogenic diets, we know that even though they may initially lead to weight loss, but they are just not good for our metabolism. And a lot of there is a lot of derangement of the I mean, in fact, the whole cardiometabolic health suffers because of it. And I have seen so many patients on ketogenic diet where they may have lost a little weight, but then they have to be put on statins. We are looking at a holistic, pattern that we see on health and fitness rather than just a weight loss.
I will just add to that. It is a horrendous failure, the ketogenic diet, because nobody can continue it more than 3 months. So the midway is a partial ketogenic diet, which includes the healthier fats. That is the way go.
Yeah,
With
the
the
type
permission-
of fat is important.
With permission of chairperson, can I ask one question? Japanese people, why they live more as compared to the other? Because their average life is around 97 years, and Indian we are having 69.8.
Okinawa has even
Yes. So what is the cause of that? Because they take a lot of seafoods, and they don't. We are different than them, but they survive more. When the Japanese people they are coming to Nagpur, there is a monk in Nagpur, Bante Surai Sasai, and he is around 95 years, but very active, walking, everything, and so he is following his diet from his country. He is not taking our food.
I would suggest see the documentary on blue zones on Netflix and read the blue zone book. There's a book on blue analyzes dietary patterns, the lifestyle patterns of blue zones where people generally live on 100. But in Japan, they do not have heavy meat. They do not have too much fats. Carbohydrates are limited to. They don't eat. Like they don't even a lot of rice. What we they eat more of other carbohydrates like sweet, and their source of proteins is a lot of soybeans. They do incorporate soy protein or other protein base or fish. They move a lot.
They take, and a lot of antioxidants like free radicals are also not there.
Seaweeds.
One question for you, sir, Dr. Bora. You have narrated very nice. How much avocado should be consumed? Because you said avocado is the ideal. So instead of apple, can I take avocado?
Basically the avocado is the only fruit which has got very low carb, and it has got a very low glycemic index. So any food having a very low glycemic index and a low glycemic load. So there is no upper limit of consumption, but still a human, the average human diets, whenever you go, you cannot eat more than 350 grams at a time. So that is how the 5-star runs.
Yeah. So doctors, they can afford avocado, and we should.
Yeah. Sir, that is how the 5-star meals are planned. If they call a higher society, they will not plan more than 200 grams of plate for each individual. They will calculate in that way.
Yeah. Thank you so
And
much.
if they call some other person, they will calculate probably some labor class or something like that. They will go on to 300 grams. So human cannot consume more than that at a time.
Hello,
so that
ma'am.
is how we can plan that.
The only way that we can consume more is having maybe fried food, like a samosa is about 400 calories. A chana bhatura would be about 1,000 calories.
I think we need to eat lot of calorie, lot of nutritional bombs rather than the calorie bombs.
Yes.
Ma'am, as we see, this is a circadian rhythm or time restriction diet, but how we follow for the day shift worker, like IT worker, who work 15 days morning, evening, or a company worker who has 3 shift, morning, afternoon, and night. Then for
Yes.
them, how we apply this?
Yeah, very, very pertinent because this is happening all the time these days. So in shift workers, we have to train them to, in their whatever schedule they are following, we have to train them not to eat in the night. They have, literally, they eat throughout the night thinking that, yes, I'm awake and I can keep myself. Just mentioning one of my patients was eating, dividing her dinner into 2 meals, gaining weight, even trying to restrict calories, nothing happened. We finally just made sure that after 9 or max 10 p.m., even though she's awake the whole night, we just gave her some fluids, more of fluids, 0 calorie fluids and water. And suddenly her weight dropped and her energy levels increased. So it's not just that we cannot do anything. It's a challenge. Of course, that's another thing that she decided to change her jobs after realizing that she felt so but we do need to give them a very restricted window of.
I think we should, whenever we are hungry, we should point whether it's a hedonic hunger or really you are physically hungry. So I think try to drink some water and see whether you are really hungry or not. That is the way to go ahead.
In fact, thirst is often taken as hunger by us and by each one of us.
Thank you so much, ma'am. We need to conclude the session because we need to maintain the time. Thank you so much.
I kindly request the chairpersons to felicitate Dr. Anjali Nakra, ma'am.
Yes, Dr. Khobragade sir and Dr. Sumitra Ghosh sir to felicitate the chairpersons, please. To the next session, I request Dr. Rahul Mopari sir and Dr. Aarti Dharaskar ma'am to please chair the session. For the speaker, Dr. Jayant Panda sir, he's going to speak on the topic sarcopenic obesity and how to proceed. Dr. Rahul Mopari sir is Director Endocrinologist at Gajanan Hospital Center for Diabetes. He's a famous endocrinologist in Dr. Punjab Rao alias Baba Saheb Deshmukh Memorial Medical College. Dr. Aarti Dharaskar ma'am is a physician, well-known physician and diabetologist of Nagpur. She is a director of Indrayani Hospital, Ramdas Peth, Nagpur.
Hello. Yeah, very good morning to all. Some different topic, that is sarcopenic obesity, as the name suggests. It's a combination of sarcopenia, that is a low muscle mass, and obesity, that is a fat which is on the higher side, percentage of fat. So something different to be discussed today by Dr. Jayant Panda, that is sarcopenic obesity. So let's listen from Dr. Panda about sarcopenic obesity. He is a professor and consultant at SCB Medical College, Calcutta, and to his he's achieved multiple awards. He is a fellow of Indian and American College of Physicians, member faculty of Council, Young Achievers Award by Calcutta in 2018, as well as he is editor for many journals. So I welcome Dr. Panda and hand over mic to him.
Thank you, ma'am. Thank you, chairpersons, most esteemed delegates. My regards to the team Arrow, led by Dr. Bansi Sabo, and Dr. Narware, and Dr. Soumitra, Dr. Breeze, and the whole team who have kept the fight against obesity in the country and around. And I'm proud that I've been invited here as a part of the faculty. And next 20 minutes, I'll take you through a very new concept. We know gaining weight is obesity. And the obesity has been defined by BMI. You heard Dr. Anup Mishra, many other faculties that 25 to 29 and more than 30 is overweight and the obesity by WHO. And in India, we take a blanket cutoff of 23 BMI. But what contributes to that BMI? We know highest part of our weight is contributed by muscle and bone, not fat. And when muscle comes down and fat increases, that is the term given as sarcopenic obesity. And this is a relatively new terminology, a lot of work being done worldwide. And I'll give some highlights which will attract you more towards this topic. It's defined as a functional and clinical condition characterized by the coexistence of loss of skeletal muscle mass and function. Not only muscle mass, but also related function and excess of adipose tissue. Mostly the muscles are replaced by the adipose tissue, and the incidence increasing very rapidly because of the aging of the population. Many people are living long, and also the sarcopenia incidence is increasing, and then the body fat is increasing. And the obesity has become an epidemic. After US and China, India is in the list. And you know, 1/3 of the world population, 30% of the world population are obese. And this is associated with several clinical complications like frailty, fractures, cardiovascular disease, cancer, and increased risk of hospitalization and mortality. If you are not suspected it clinically, you cannot diagnose. And if you suspect, you can work up and prove this entity. The physiological aging may be associated with the modification of the body composition, including the redistribution of the adipose tissue and characterized by decline in the muscle mass, which can lead to the development of sarcopenic obesity. That's why these elderly people are more suffering from this. The sarcopenia and obesity are the distinct entity, but they share common pathophysiological features like the risk factors such as lifestyle, aging, production of inflammatory cytokines, reactive oxygen species, and the endocrine alterations. Moreover, the two conditions act synergistically. One is loss in muscle mass, one is gain in the fat to enhance each other, leading to a detrimental vicious cycle. And the absence of globally adopted common definition and sarcopenic obesity impairs precise epidemiologic assessment and pertinent to the identification and ultimately adapted management related to complications. So this I already told you that 25 to 29 and more than 30 that we define by WHO, and in India we take it as low as 23. And it's a chronic illness. You know, it has been proved beyond doubt in last 2 days. You have been listening about the definition, management, and it represents a big health challenge without shame. And the coming to this particular category, the progressive and generalized loss of muscle mass and strength and associated with harmful outcome like fall, fracture, frailty, and mortality, and especially in the elderly people, but the progressive decrease in the muscle mass begins at their 40s. And after the age of 50, muscle mass decreases every year by 1 to 2%. Many of us have not noticed that, And this is the fact, and the mechanism that triggers sarcopenia are complex and include a decline in the neural function with a reduction in motor units as well as fibers, and that's a part of the aging. The hormonal changes reduces satellite cell function, malnutrition, chronic low-grade inflammation, mitochondrial dysfunction, and behavioral factors such as sedentary lifestyle. Like always discussed, the lifestyle becomes a very important factor in keeping your muscle mass constant till later age. So simple and unique diagnostic criteria have not yet been established to define sarcopenia, but I'll tell you how you should proceed. Because most of the use of set of criteria, muscle strength, muscle mass, the gait speed are used. In 2019, the European Working Group on Sarcopenia in Older People published a guideline, and that's the only existing guideline in sarcopenia at present in the world. And the reduced muscle quantity as well as quality by a DEXA scan or a mid-thigh imaging by MRI or Schwartz muscle measurement by CT were used to confirm the sarcopenia, and poor physical performance was assessed using the time up and go test or gait speed to determine the severity. We can tell it a paradox because the muscle mass is decreasing. The concept of the obesity paradox apply because in the older population, the impact of the obesity on the cardiovascular disease mortality remains unclear. The approximate estimation of the body fat by BMI body composition is not assessed by this index, including the distinction between the lean and the body fat body mass, and opposite impacts on the risk of mortality. So increased risk associated with the fat mass, the mortality risk is negatively associated with muscle mass. Once the muscle mass decreases, the mortality risk increases. And once the fat mass increases, the mortality risk increases. So that's why we can tell it a obesity paradox. Well, muscle mass is coming down and mortality risk is going up. This is a very nice diagram where the sarcopenic obesity is described. You can see the unhealthy diet, lack of exercise, and aging are the most important factors. And this omental fat deposition, ectopic fat deposition, insulin resistance, metabolic rate, physical activity decline, metabolic rate decline, and anabolic hormone decline leads to the sarcopenic obesity, where in one side there is decrease of the muscle mass, in the other side there is increase in the adiposity, and that increases the pro-inflammatory cytokines, leptin, and decreases adiponectin. So the lipotoxicity, accumulation of the immune cells, and the chronic inflammation increases. The mitochondrial dysfunction, oxidative stress, the osteoarthritis, and the anabolic resistance increases. And there is alteration of the myokines. So that leads to sarcopenic obesity in elderly, which is cardiovascular disease, cancer, diabetes, fractures, frailty, quality of life comes down, increasing the disabilities, increasing the hospitalization, morbidity, and mortality. So the sarcopenic obesity appears to be a more severe condition than the obesity alone and associated with a higher risk of several disorders like cardiovascular, reduced bone mineral density, and all-cause mortality that I have already told you. Let us see the potential etiology and pathogenesis. Again, the unhealthy diet, exercise, body change in body composition, change in hormones, multiple chronic disease are the etiology. The inflammation, oxidative stress, and insulin resistance are the key pathophysiology leading to this sarcopenic obesity, where there is sarcopenia in one hand, obesity in the other, and there's a vicious cycle. And this leads to a whole lot of complication that we discussed just now. The diagnostic process for the assessment of the sarcopenic obesity are very simple. It still exists, though not complete. It's screening, diagnosis, and staging. The high BMI or waist circumference that we take for the obesity diagnosis exists. And the surrogate parameters for the sarcopenia, like clinical symptoms, clinical suspicion, or the questionnaire can be used. And both conditions must be present to proceed with the diagnostic process. There must be evidence of obesity, there must be evidence of sarcopenia. Then comes altered skeletal muscle functional parameters, which is considered the considering the strength. If muscle functional parameters suggest the presence of sarcopenic obesity, the diagnostic process will continue considering the body composition and altered body composition by DEXA scan, by appendicular limb assessment, or by skeletal muscle assessment by bioelectric process. They are available at present for the diagnosis. And both altered body composition and altered skeletal muscle functional parameters, they contribute to the diagnosis of sarcopenia. And then we have very clear two stages, like Dr. Mishra told yesterday about obesity. Stage 1, no complications. Stage 2, presence of at least one complication attributable, like a metabolic disease, functional disability, cardiovascular, or respiratory disease. If there is a disability, it is stage 2. If there is no disability, it's stage 1. That's how the diagnostic process and the assessment believes. A long list of diagnostic criteria of sarcopenic obesity. You can see this group, and the muscle mass, muscle strength, physical performance are taken into consideration, and this can be followed for the purpose. It's a very important slide. Different measurement methods of sarcopenic obesity. You can see the DEXA scan, which is the dual energy X-ray absorptiometry, and it looks for the ASM height square or ASM weight. And this ASM stands for the appendicular skeletal muscle divided by weight, or the appendicular skeletal muscle divided by height in meter square. There how you get this DEXA scan or the dual energy X-ray absorptiometry. The anthropometry includes the MAMC. MAMC is the mid-arm muscle circumference, and then the calf circumference is taken. BIA is the bioelectrical impedance analysis, and again it is the appendicular skeletal muscle divided by height square and divided by weight. And the CT scan, the MRI, the HSG or hand grip test, the gait speed, the timed up and go, the short physical performance battery, and the percentage of the body fat are all assessment of muscle strength, physical performance, adiposity, and the fat mass. So this is a very important slide giving you a example how you should proceed. Clinical symptoms is a long list. Suspicion of screening of sarcopenic obesity can be done. So it includes heart failure, kidney disease, bowel dysfunction, everything, and acute diseases also like hospitalization, major surgery, sustained immobilization, and then history of repeated falls, weakness, exhaustion, and frailty. And all these factors give you a clue your patient may have sarcopenia. And here the cardiovascular disease is very important. Quickly I'll go through. We have discussed enough. And worldwide, the most important killer is the cardiovascular disease, and sarcopenic obesity is significantly associated with cardiovascular disease, which is caused by the insulin resistance, metabolic syndrome, adverse glycolipid metabolism, even in the context of divergent comorbidity such as cancer and the peritoneal dialysis. So this relationship extends to point directly influencing the all-cause mortality in the patient after the cardiovascular surgery. And the atherosclerosis is the common pathogenetic point, and the insulin resistance triggers all event that you have seen in the diabetes. The adipokine overexpression by the sarcopenic obesity and the coronary artery calcification are the major pathogenetic factors contributing to the cardiovascular diseases. The myocardial fibrosis, the overexpression of TNF alpha, and hyperinsulinemia, which are common problems associated with diabetes, are also there seen in the sarcopenic obesity. the heart failure, the infiltration of the adipose tissue, and the oxidative stress are the common expressions. If you detect that, you have to assess the patient for sarcopenia and prove the diagnosis. This is mortality related to sarcopenic obesity, and this study tells about cohort studies of different individuals and definition of sarcopenic obesity by the group, outcome assessment, comparison, and the result. And clear cut it concludes both obesity and sarcopenia are associated with the elevated risk of all cause mortality. The coexistence of both conditions may exacerbate the risk of mortality. So, multiple prospective studies assess the association with mortality, and altogether, there is a core body of evidence that suggests sarcopenic obesity must be considered a predictor of all cause mortality along with adults, justifying the implementation of more systemic program to detect it and intervene. The last part is the management. I'll touch upon because it's very simple. The lifestyle, and the lifestyle. Those who have specifically resistance exercises, that is very important. The calorie intake has to be reduced. Weight loss in the older individuals is very important because you have to maintain the nutrition as well. And the high quality protein intake of around 1 gram per kg per day is recommended. The physical exercise, I told, especially the aerobic and the resistance exercise, help increasing the muscle mass. Aerobic exercise improves the cardiovascular function as well. The resistance exercise is the mainstay in the elderly, promoting to check sarcopenia and improve the muscle mass. And the calcium and vitamin D supplementation is a must, which is declines along with the aging. And the emerging treatments include the testosterone, selective androgen receptor modulators, the GLP-1 receptor agonists for the weight loss. Bariatric surgeries are in the experimental level. The myostatin and the activin, the receptor type 2 inhibitors have been developed and shown to increase the muscle mass and strength. These are the drugs in the pipeline for the future, and the whole body vibration therapy, the mesenchymal stem cell therapy, and anomorelin and oral ghrelin receptor agonist are all promoted. The final slide to conclude, to keep a balance between the healthy aging and to check sarcopenia, a healthy diet, a calorie restriction and high amino acid intake, a regular physical activity, resistance training and the aerobic training, and the putative therapies like anamorilin, vitamin D, calcium, testosterone, bariatric surgery, the mesenchymal stem cell, weight loss therapies, myostatin, and the ACTR2 inhibitors are in the pipeline. So, to summarize, the best therapeutic approach for the sarcopenic obesity with the current most effective and largest evidence is the lifestyle modification, and including regular combined aerobic and resistance exercise with diet modifications that should include calorie restriction with the aim of reducing fat mass, increasing the muscle mass and function to improve the quality of life and reduce the mortality. The pharmacological molecules have been considered, but they are not yet strongly recommended because of the lack of strong evidence and the longer studies assessing the effect of the multimodal approach against sarcopenic obesity. The CV events and the mortality will be of interest. So the incidence of sarcopenic obesity is increasing mainly because of the ever increasing aging global population. People are living more and there are risk of more sarcopenia. It's severe disorder associated with frailty, risk of fall, bone fracture, CV diseases, induced independence, and an elevated morbidity and increased hospitalization and mortality rates. Sarcopenic obesity is associated with a higher risk of CV events than those associated with sarcopenia or obesity individually, a significant public health issue. The obesity risk and the sarcopenia risk are compounded in them. It's a pathogenesis multifactorial involving metabolic, inflammatory, and the hormonal aspect, lack of a universal use diagnostic method, the definition criteria prevents a clear estimation of prevalence, which currently remains underestimated. The diagnosis of sarcopenic obesity represents the initial challenge, and the early identification of this condition remains important, and adapted interventions should be considered to reduce the prevalence and the associated deleterious outcomes. Novel therapeutic strategies are required to improve the poor prognosis. So, in a single word, I'll tell, if your patient is elderly, if patient has frailty, has tendency to fall in the cardiovascular disability, try to check whether there is a associated sarcopenia. And if there is a sarcopenia, we have to detect it early, check it, stress on the lifestyle modification, diet and exercise, and other modalities, whatever feasible, appropriate for the patient, which can check the morbidity, mortality in the long run. And it is required, we'll work more on this field and detect the important aspects which will be of use for the management of our patients in the future. Thank you for the time and thank you for the opportunity.
Thank you so much, sir, for a wonderful session. You have made this complex topic in a very simple way. Can we have a question session?
And Dr. Bora. There's- rightly you have told, both diabetes and sarcopenia causes insulin resistance.
Yeah.
And metformin is the drug which works adverse in sarcopenia. So, and also metformin has a risk of depleting vitamin B12, as you know. So, in elderly, those who have a long-standing diabetes, sarcopenic, it's ideal
Yeah,
not to
because
give.
most of the time the prescription will say that he's either on 1 gram or 1.5 gram of metformin,
Yeah,
and he's telling you that I'm unable to eat, loss of appetite, sarcopenia. He's on metformin.
And it also causes dyspepsia, vitamin B12
And
depletion.
the moment he gets the sarcopenia, there is a cognitive decline also.
Yes.
And
So,
they may land up with the heart failure, frailty syndrome.
yeah, rightly you have pointed out.
So I think we should caution about the metformin to all in the case of
Yeah,
sarcopenic
yeah.
obesity.
And in a survey in India, 84% people of diabetes are on metformin. Whereas GLP-1, it is a questionable, almost 0%. And gliptins are with around, next highest is the gliptin, around 50%, and SGLT2 inhibitors are only 4% people are getting. So there, in elderly population with a long-standing diabetes, associated insulin resistance and sarcopenia, we have to look for the alternatives. Yeah, yeah. The message should go clear that you have to take a second thought about using it in elderly. Yeah.
Excellent lecture. With the permission of chairperson, I would like to ask one question. It was there are some patients, they are coming with the erectile dysfunctions, obesity, sarcopenia, and they are interested in this life enjoyment. So what to do with such patient? Can we give some sildenafil or some other drug? Because they are having some other comorbidities also. And it is really practical problem how to manage them,
Yeah,
erectile
sir.
dysfunction.
Very rightly told, sir. Elderly and also with metabolic syndrome, there is a chance of hypogonadism as well. So first you have to look for the organic causes and psychological causes. If there is profound sarcopenia associated with metabolic dysfunctions and the erectile dysfunction, you can, along with the lifestyle, the muscle enhancing therapy, you can use the drugs for their erectile dysfunction and the better quality of life. That's recommended, sir.
Just to add little bit to this
Yes.
question, sir's question regarding the testosterone supplement, there is a terminology called late onset hypogonadism, which usually occur 55 to 60 years. There will be hypogonadotropic hypogonadism. And once you started on androgen, that is testosterone, it will not only increase the muscle strength, but help in bone health also. And moreover, there are now evidences that it will help in cardiometabolic health also. Those patients who are post PTCA, it will do the wonderful job. So it is
Very-
always better. Yeah. Let me complete. But there are some
Yeah, that's a contraindication for the therapy.
there are some prerequisite. There should not be high HB hemoglobin, then PSA, and and their lower urinary tract obstruction. These three should not be there. That is the thing.
Yeah, well, rightly pointed out. In an elderly, you have to look for the cardiovascular function,
Cardiovascular mortality.
function as well. You have to look for the benign prostatic hypertrophy and obstructive lesions. But as pointed out by Dr. Rahul, to the appropriate patient, a dose of testosterone helps in a many way. Johnny.
Excellent presentation, Jayant. I just want to add few points and then question. We did a study in our population with 100 patients, and we found three important, interesting findings. The first thing was we found that in diabetic patients, sarcopenia comes early as from 40 years onwards. Sarcopenia is coming in. We did this bioimpedance study. Second point we found was women had more incidence of sarcopenia than men. The third point was, in that study, what we found was most of the patients who had this sarcopenia incidence had a higher HbA1c. So people who are not controlled with diabetes, in control with diabetes, they had higher incidence of sarcopenia. So that's the point I want to add. Another two questions I just want to clarify. You were showing some muscle stimulant vibration.
Vibrators, yeah.
So there are vibration and muscle stimulants which the physiotherapy people use, and some. Is that helpful in improving? Is there any studies?
Yeah, actually, no treatment has been proved conclusively. This is one of the modalities when they make a vibration and try to stimulate the skeletal muscle mass. That's one of the modalities.
So is there any evidence that it is useful?
The evidence need to be further evaluated, but at present it is also promoted in this sarcopenic patients.
Second thing is about the testosterone supplementation. Yeah. If the testosterones are normal, you still supplement in a sarcopenic patient?
It's not recommended. If it is a hypogonadotrophic hypogonadism, then only testosterone will help. And rightly you have told 2 points that 40 years is the cutoff for the beginning, and poor A1C or poor diabetic control is a stimulation. Regarding the women having sarcopenia, the hormonal assessment and post-menopausal women, they are more mostly they are the victims.
Correct. Thank you for that.
We conclude the session if there is no question.
Thank you. Thank you, everyone.
I request the chairpersons to felicitate the speaker, please. May I now request Dr. Khobragade sir to please felicitate the chairpersons. I request Dr. Jnaneshwar Katyaram, Dr. Arjun Deshmukh, and Dr. Y.V. Bansor sir to please chair the next session. For next session, our speaker is Dr. Rajiv Chawla sir, who's going to speak about diabetes as a cardiovascular disease. Dr. Jnaneshwar Katyaram, he is HOD Medicine, DMCC Vanadogri. And Dr. Arjun Deshmukh, he is an intensivist diabetes specialist, echocardiologist in Sunflower Hospital, Nagpur. Dr. Bansor sir is retired professor in HOD, GMC, Nagpur, and presently is professor of medicine in NKP SIMS, LMH.
Good morning, dear delegates and respected speaker. Today we have a very eminent speaker by the name of Dr. Rajiv Shukla. and he would be enlightening on diabetes, the approach to such kind of cases, and what is diabetes. Diabetes is a pathophysiological link between diabetes and obesity, and it is a new epidemic in modern world. So without so I'll request Dr. Rajiv Chawla sir to start his session.
Thank you, chairpersons. At the outset, I am extremely thankful to Aaron Committee, Dr. Sunil, for this opportunity. Task assigned to me is to discuss about diabetes as a cardiovascular risk. So I think today we are living in an era of hips and waist, unfortunately so, and there is huge amount of clustering, whether you talk about obesity, metabolic syndrome, type 2 diabetes, which are driving this CV epidemic. These clustering of cardiometabolic risk are going to increase overall risk for MI or stroke by almost 3 times, and there is higher fivefold increase of developing type 2 diabetes if you simply have pre-diabetes, or maybe you are having only simple obesity. So this is a very, very simple slide which tells us that there has always been a debate what comes first, whether it is insulin resistance which comes first and then sets in the stage for something like egg and hen theory. I think it is the insulin resistance which starts the entire cardiometabolic risk with some amount of visceral obesity, and globally it is seen that 44% of cases of diabetes are attributable to overweight and obesity, leading to a specific medical condition which we today say as diabetes, and both propel each other. So morning also we heard from Dr. Mishra that insulin resistance, amount of visceral fat or central obesity. Now we are not simply talking of central obesity, we are talking of fat inside pancreas, we are talking of fat inside the muscle, which is contributing to a greater cardiovascular risk. So obesity and type 2 diabetes seem to be a continuum, and this is a serious chronic disease associated with complex metabolic dysfunction, and it increases the overall risk for morbidity as well as mortality. Here is a fat topography. I just conducted a workshop where we were talking of BCA or body composition analysis, and this is what exactly it is that we are looking for. Intramuscular fat, we are looking for intrahepatic fat, we are looking for subcutaneous fat, and the visceral fat. All these fats together, these are ectopic fats which increase free fatty acid levels, TNF alpha markers go on the higher side. There is a much higher leptin resistance. IL-6 levels are, or CRP, which are easy to do, are much on the higher side. Pi is already on the higher side, and this induces rampant atherosclerosis. So any amount of increase in BMI simply by 2, it will increase the overall risk of developing type 2 diabetes. And you could see that starting from as low as 22, moment it is 22 to 23 only. For Indians, 23 is normal, 23 to 25 is already overweight, and you could see the moment there is an increase in BMI by 1 or 2, that is grossly going to increase the risk for developing not only type 2 diabetes but also cardiovascular risks also. So overweight and obesity in people with type 2 diabetes is associated with many more comorbidities, maybe cancer. Various types of cancers are much more common in obesity. Risk of developing micro or macroalbuminuria, progression of renal disease, gradual fall in eGFR, and of course, today we know that it is more like a behavioral disorder. So obesity also increases the risk of depression. All microangiopathies increase. Maybe I told you, whether it is simple albuminuria or retinopathy, the risk of OSA goes much high, and overall there is an increase in morbidity as well as mortality. So overweight and obesity in type 2 is associated with an increased risk of all these comorbidities by virtue of having clustering with dysglycemia, hypertension, or dyslipidemia, and overall there is a greater risk for developing cardiovascular risk. That is why I say obesity itself or diabetes itself carries much higher cardiovascular risk, and it increases the financial burden. Moment there is an increase in obesity, it works like something fuel to the fire. If you are simply overweight, this is a Caucasian criteria. At 25 we are already obese. 25 to 30, the cost of handling all these comorbidities or complication goes up, and so is as there is an increase in grading of obesity, overall cost for handling these morbidities and mortalities goes up. Not only that, moment you have obesity, you are at a greater risk of developing dysglycemia. Moment you have dysglycemia, the further risk also goes up, not only for developing type 2 diabetes, but overall cardiovascular risk also goes up. And this is how it happens. And intra-abdominal obesity, which is a major contributor to increased cardiometabolic risk. I told you there are going to be increased markers of inflammation with free fatty acid levels, secretion of adipokines, reduction in adiponectin, with dysglycemia, dyslipidemia, insulin resistance, and that adds to further worsening of cardiometabolic risk. So, adverse consequences of chronic adiposity and ectopic fat are primarily because of overflow of lipid, which goes into the ectopic places. I told you it may be into the muscles, into the liver, inside the muscle, that is intramuscular, and that further worsens the risk of developing cardiovascular complication like reduction in ejection fraction. There could be actually a reduction in beta cell function, a rampant atherosclerosis, NASH moment it is into the liver, and it is seen that today it is measurable. You may actually look for an epicardial fat, you may look for steatohepatitis by simple ultrasound or by fibroscans or by RFE or by even MRI. And you can also measure, Dr. Mishra has shown you that it is possible to measure even intra-muscle fat also by MRI, which can actually classify the risk or stratify the risk what these patients are going to have. So it seems to be a continuum of cardiometabolic risk. On one hand, you have insulin resistance, which is further worsening obesity, central obesity or increased visceral fat, with dysglycemia, with dyslipidemia, markers of inflammation being on much higher side. So overall cardiovascular risk in these patients is going to be very, very high. So it is very, very correctly said that abdominal obesity probably could be linked straightway to increased risk of coronary artery disease. Moment you have visceral fat or your abdominal girth goes on the higher side, your overall coronary artery disease also gets doubled to 3 times, and it is being established in various studies over last 20 years. So it is a continuous burden of disease with central obesity, hypertension, dyslipidemia, and dysglycemia. I told you which drive this cardiometabolic risk. Cardiometabolic risk is associated with substantial cardiovascular morbidity and mortality, and this is contributing towards an ongoing epidemic of adiposity, which mandates an evaluation of new approaches. So today we simply cannot go with blood sugars, simple with BMI. I just now talked there about Edmonton score of obesity. Now we are talking of BCA, which is a fat analysis and a body composition analysis. We are able to identify visceral fat. We are able to identify fat inside the muscle, fat inside the liver, and fat inside the pancreas to classify these patients at a much cardiovascular risk. So we probably need to have a comprehensive picture of a patient health and potential risk for future diseases and complication by assessment of these parameters, which are now fortunately available. So it needs to be viewed that any amount of extra calories or extra fat or overnutrition is going to add to insulin resistance, with clustering or risk factor like hypertension, dyslipidemia, hyperinsulinemia, and markers being on the higher side. I told you there is going to be a rampant atherosclerosis, which is not only selective to coronary artery, it is also can be seen into the carotid artery by carotid intima media thickness. Even cerebral vessels might be having huge amount of atherosclerosis, predisposing these patients to TIA as well as stroke, and these patients are also at a greater risk of developing PVDs, gangrenes, and amputation. So it seems to be a continuum of CVD in these patients, which simply starts with overnutrition and clustering of other risk factors. So we need to target these cardiometabolic risks. We need to stratify these risks in the form of doing simple lipids. We must address their blood pressure. We must stop their smoking, and if they have dysglycemia other than obesity, that also needs to be taken under control. Unfortunately, all these have been very unmet clinical needs in the clinical practice. That is why with clustering of these risk factor, overall cardiovascular disease continuum has been going on. Not only we tend to develop diabetes almost 2 decades earlier, we also tend to have CVD at much higher in Asians as compared to the Caucasian patient. So priority has to be a greater weight loss. Greater is the greater is the reduction in weight in terms of percentage, there is going to be better outcomes. So any amount of weight reduction by 5% can reduce hypertension and hyperglycemia. If you can get 5 to 10% reduction, it may probably prevent NAFLD, PCOS, and if you can ensure 10 to 15% by drugs and lifestyle modification, you can reduce overall CVD, you can reduce NASH, you can reduce OSAs also, and more than 15% weight reduction we have seen have put patient into type 2 diabetes remission, and overall cardiovascular mortality also goes down. So these days we are talking of primordial prevention. It is said that if you are able to intervene before patient develops central and visceral obesity, it is primordial prevention, because we are trying to prevent the onset of the disease. If patient is already having obesity with hypertension, dyslipidemia and dysglycemia, already now if we intervene at this stage, we will be just preventing complication, and we might be able to cut down on cardiovascular morbidity and overall mortality. So the pillars of cardiovascular risk reduction today to reduce CVD are in form of reduction of abdominal fat by not only lifestyle modification, exercise, their proper assessment, and maybe drugs if required, to cut down on insulin resistance, to get better control of lipids as well as blood pressure by proper drugs. It could be in the form of metformin. Glitazones are wonderful for reducing insulin resistance. Best is, of course, lifestyle modification and exercise. Many patients still having dyslipidemia may benefit from statins and fibrates. And ACE-ARB almost for every patient who has microalbuminuria or hypertension in the setting of obesity or type 2 diabetes. And everything is possible if we can cut down significantly on the calories intake. A wonderful quote as early as 2003 by Stephen Martin: I had done anything to look like all these beautiful people in that Oscar show, all those young females and everyone looking so beautiful. But except, of course, exercise and eating right, that is what I have not done. So minded obesity has overtaken tobacco as the leading preventable cause of cancer. That is why today we must have, I told you, policies for primordial prevention, so that we can not only check the progression of diabetes, we can cut down on overall CVD or NCD. So it is very rightly said that mother of NCDs is only obesity or overnutrition. So not only it is the lipid control which is important, blood pressure control, weight reduction, maybe by diet or drugs, prevention of diabetes by various methods. Again, lifestyle modification, I told you 10 to 15% weight reduction can actually put patient into remission. And overall, it all talks of dietary approach, which is much more important than even drug when talking of reduction in cardiovascular risk in these patients. We are wiser from diabetes prevention lifestyle trials, Cochrane Docking IGT, which said that it is intensive lifestyle which had the best result. So was Finnish diabetes prevention study and diabetes prevention trial, and Indian DPP also by Dr. Ramachandran, where all these studies have highlighted the importance of lifestyle modification. Even the Look Ahead trial, you could see a randomized trial of almost 5,000 obese diagnosed with type 2 diabetes, and goal was to achieve weight reduction of more than 7%, and outcomes are measured in form of fatal MI, CVA, non-fatal MI, and it was almost a 12-year follow-up, 11.5-year follow-up, and at 1 year it was seen that weight loss 8.6% versus the control group, fitness improved, A1C improved, their lipid, their blood pressure, albumin, everything improved within 1 year. Of course, long run it was seen that results were then weaning off, because it is very, very difficult to adhere with the lifestyle over 4 years or 5 years period. So these are the interesting fact that various governments and agencies are trying to intervene. In 2014, Mexico has enacted a tax on 10% per liter on sweetened sugar drinks. Yesterday only I saw in one of the paper publication that was, I'm forgetting it was from which country, and Colombia, yeah. So they have put huge amount of tax on that. Until unless government or different agencies and organization like RSSDA step in, I think these efforts may go in waste. Very simple 5 things you may do. Tell your children that turn off the television when you are eating, because if you are eating, say seeing a India Pakistan match, you are bound to have overnutrition. Important thing, children must walk. This must come as early as when they are 12 to 15 years, teenagers or adolescent, because that goes a long way in getting weight reduction. Must have low fat water or buttermilk kind of thing, beverages, rather than consuming juices or even diet cokes and all that. Fast food is not more than one per week, and fruits and vegetables in plenty. I'm very happy that Dr. Kavita and Dr. Sunil have been putting that concept that whenever you are in a party, you must cut a fruit cake rather than whether you're celebrating your anniversaries or birthdays, because that goes a long way in sending that message. So today the big picture is the burden of type 2 diabetes and obesity is rapidly increasing, which is contributing towards much higher cardiovascular risk in these patients, and we need to have very, very focused you may say initiative based on that, not only for prevention of weight gain, but an attempt to reduce weight so that we can cut down on overall risk or CVD. Very, very old quote which says that inferior doctor, they treat full blown disease. I'm sorry, we shouldn't tell anyone that you are inferior doctor, but most of us, we focus only prevention of coronary artery disease, or we want to do a angioplasty or PTCA. We are not talking of primordial prevention even at that level. We don't very emphatically emphasize that next time if you are smoking, I'll not see you. If someone who comes with fat and NASH, until unless we tell them that you reduce your weight, reduce your calories and don't take alcohol, I think we have half done. So mediocre doctors treat disease before it is evident, but superior doctors, those who are visionary, they are the one who tell their patients much in advance that you follow these instructions to prevent disease. That is how it should be viewed upon. Thank you very much for your patience listening. You have any question, I'll be more than happy to answer that. Yes, sir.
Okay. What is the role of carotid intima thickening in the prevention of the cardiovascular risk in diabetic as well as in obesity?
It is,
give the enlight all these things.
yeah, it is something like what we do today as a workshop. We were talking about BCA, we were talking of sarcopenia measurement, we are talking of NASH by doing an ultrasound. So if you do a carotid intima media thickness and you find that there are already more than 50% block, which is very, very significant. In coronary, it has to be 70%. Here, any block more than 50%, you must caution your patient that you are at a much greater risk for having a TIA or stroke. So those patients, not only the weight reduction, diet control, they have to be on high doses of statin, as high as 80 milligram of atorvastatin, and if mandatory, based on overall profile, on antiplatelet drugs also. Role of
Incretins. Incretins.
incretin in, of course, GLP-1 receptor agonists today are the gold standard. That is why these days we are talking of even before metformin or after metformin, every patient ideally should be on GLP-1 receptor agonist, oral or injectable, if patient can tolerate it, patient can afford it. Possibly these are the best drugs. Those who cannot afford or they don't tolerate GLP-1 receptor agonist, we are banking on SGLT2 inhibitor for other benefits. Benefits with GLP-1 are primarily by reduction of atherosclerotic cardiovascular disease progression. With SGLT2, it is in form of metabolic hemodynamic benefits by reduction of further renal composite endpoints, improvement in ejection fraction, hospitalization with heart failure, but also some amount of reduction in CV death, what was seen in EMPEREC trial, 38%.
Can I ask one question?
Yes, sir.
Heartiest congratulations, Dr.
Thank
Rajiv
you.
Chawla, sir, for
Thank
a
you.
very
Thank
beautiful lecture. My question is, these obese people, usually they are hungry. and obesity, diabetes, and they are always fond of food. Even if their BMI is 45, they don't bother about what will happen in their future. And if it is 120 kg, still they are eating a lot of things. If you observe their plates, they are full of all carbohydrates, snacks, sweets, everything. They don't leave anything. Is there a correlation between excessive hunger and micronutrient deficiency?
Very good question. Today, obesity is a behavioral disorder. It has strong inheritance. It has been seen in various studies that if you examine their eating capacity and their stomach measurements, they can accommodate up to 2 liter of volume of the food as compared to someone who is lean and thin who will be having satiety at 500 to 750 ml. So their stomachs are so bigger in size that it does not get stretched and they don't get negative feedback and they don't get that satiety effect. They have microbiota which needs to be blamed. There are certain microbiota which can get you satiety, which set your rhythm in a better way. It has been seen that these patients have those negative microbiota, huge number are identified now, and ghrelin is to be blamed. They have very high leptin resistance and reduction in adipokines, adiponectins primarily. So there are, so many factors contributing towards obesity. It is not a simple disease. It is a very, very complex metabolic disorder. But definitely, having said that, it is mother of all NCDs. So we need to sit with the patient, do every analysis, still emphasize on lifestyle modification in a great way and certain drugs which can help.
Nice lecture, sir.
Thank you.
As usual. My query is, we know about thin fat Indians and lean diabetics with high visceral fat. So whether the whole diabetes guideline should be applicable to them? Or
Yeah.
should
YY paradox we just discussed. Same BMI, 22, and the amount of visceral fat in Dr. Yagnik is so high as compared to Yudnik. So that fact is known. It is known that we tend to have all those markers of inflammation much higher even at a BMI of 23 just plus, which Caucasian will not have even at 25. That is by virtue of our old frame, our you may say thrifty gene hypothesis and phenotypic expression of that we tend to be obese at much lower BMI. So we need to have our own cutoffs. Fortunately, we have BMI cutoffs. I was discussing with Dr. Mishra also, and there we are emphasizing again that amount of total fat in males should not be more than 25%. In females, it has to be less than 30%. And these parameters are different than what we get in Caucasian. We are also talking of sarcopenic obesity, and we want to identify our own cutoffs because till now we have the values which are Caucasian values. Similarly, when we are talking of body fat composition or BCA, there also we need to have our own cutoffs and we need to validate by doing multicentric studies and all that.
We are not defining them as diabetes. Those patients, are we defining them as diabetes?
Based only yet on BMI or AOS scale, Edmonton Obesity Clinical Scale.
Yeah, because they will be lean.
They will be lean.
So
that is why our BMI normal is 23. 23 to 25, we are already overweight. More than 25, we are obese. So
if you define by definition, they'll not come.
they will not.
Diabetes.
Yeah. I think he was saying that current guidelines which he has already drafted are going to get published in January issue. So maybe we will be wiser.
All restrictions.
All,
should be applicable to
everything.
them
All
as-
Indian criteria he's talking about.
them as well.
Yeah, everything measured, and they are going to put it in that draft and going to release it in January.
Thank you, sir.
Different cutoffs for Asian and Indian patients. Thank you very much. Yes.
Last question, then we'll conclude the session.
Session, but I just want to ask you, what is your takeaway on semaglutide? Because nowadays Rybelsus has been used for weight loss and of course for diabetes. So we should use it regularly, or how you recommend to use it?
See, GLP-1, I just said an oral sema is the best drug available for weight reduction. We are waiting for injectable sema, which may do wonders in form of getting 15% weight reduction. Last night only, I submitted a data of 157 patients on oral semaglutide, and title is "It's a Paradox." We tend to show a moon to every patient that moment you are on sema, you will lose weight. Unfortunately, in real world, it does not happen. You don't get that significant weight reduction because many of those patients still may not comply. So ours is 1 year data. We submitted in ACE yesterday, last night only, that 157 is a substantial number on SEMA, and we couldn't get very, very significant weight reduction in those patients because we were just telling them to be on drug. Probably over 1 year, they have not been complying on lifestyle modification. It is a wonderful drug, but it has to go with lifestyle modification. There is no shortcut to weight reduction until unless you do calorie reduction and you do weight reduction.
So rather, like metformin has been leading vitamin B12 deficiency. So does this drug contain any
No,
deficiency?
no, it doesn't cause.
Thank you so
It's a different mechanism, GLP-1. Yeah. Many patients, they default. Many times this drug is not available. Affording is a problem. And real world is always different than RCT. See, even in RCT, SEMA, you didn't get more than 5 kg weight loss in all the trials. In real world, there are so many issues. Many of your patient, they may take that prescription and come back after 6 months. They might have continued on 7 milligram. They never got upgraded to 14. Even if they got upgraded to 14 milligram, they may not be complying with lifestyle modification. So real world is always different as compared to RCTs.
Yeah. Excellent presentation by Dr.
Thank you,
Chawla,
sir. Thank you very much.
I think with the because of shortage of time, we'll conclude the session.
I kindly request to chairperson to felicitate chairperson.
So we have now one session going on there. I request everyone that session is going to be over, and immediately we'll have both the hall together now. So we have one more session of the other hall here, and one more lecture because there's something happening technically. So that's why we little 5. So I request every one of us to join there, and then we will come back here. Because there's wonderful workshop going on. Wonderful, I'm telling you. Even I don't feel like coming out of that hall. You keep everything ready here. The moment that workshop is over, we'll all come back here.
नहीं ना चालू है इसको बंद करो ना बताना साइड पे से अच्छी
So just let to
Okay, so now we start with the third workshop, which is again a very, very interesting topic, the bright and the dark side of the pre and the post exercise supplementations. So, for that, we would like to invite the moderator, Dr. Tarun Mishra, sir. So, can we have Dr. Tarun Mishra, sir, to moderate the session?
And we request Dr. Ehsan Badar, who's a bariatric surgeon, to join Dr. Tarun Mishra. And we have some more chairperson there? No? No. Okay. Dr. Ehsan Badar to please join him as a moderator for this session.
The
Yeah.
bright and the dark side.
Quickly start.
Good afternoon, everybody. Basically, I'm endocrinologist, and the topic is pre-exercise and post-exercise supplements, bright and dark side, and or you can call it pre-workout and post-work out supplements in the management of obesity. So, I will start because I don't have any slides. The discussion will be started on certain points like. What are the role of the first is the natural substances like caffeine, green tea extract, soluble fiber, and some of the drugs like yohimbine in the as a supplements, and other is the role of the fat burners which are marketed, and how we decide the type of nutrients depending on the type of exercise, whether the patient is doing the endurance exercise like if the patient is doing cycling and swimming, it is endurance exercise. So, and resistance exercise is weightlifting. So, is there any difference in terms of nutrient supplement prescription, and how to what extent these natural substances are effective? Because many of the times it is prescribed when we go to gym, and what are the reality and what are the dangers. So these are the points we can discuss.
Yes. So, yes, with that, sir, I think we invite the panelists here. And so, first, with that, we are going to start with Ms. Meghna Kumare. And, sir, can we have the introduction slide? By the time, I would just like to introduce her. She is the dietitian and the nutrition consultant for more than 20 years of experience in the field of nutrition, wellness, and diet consultation and weight management. And she also runs her own center in Nagpur and Mumbai. And she's authored and conducts many lectures. And I think she has to her credit number of awards and recognition. And we are very much honored to have you, Meghna. So over to you, Meghna.
Good morning, everyone. And today's topic is very interesting, the bright and the dark side of a pre and post exercise supplementations. So before going to ahead, I just want to show something. Yeah, it is here. But this cursor is not. Yeah.
20 से 22 रुपए का आता है आज की डेट में। आधा पाउच 1 लीटर पानी में डाल लेना, थोड़ा उसमें व्हाइट नमक डालना, फिर एक नींबू निचोड़ देना। 2 दिन ट्राई कर लेना, चौथे दिन आप खुद बीसीडब्ल्यू लेना बंद कर दो। ये मैं लिख के देता हूँ, नहीं लिख के दो तो जितने सारी बार 20 रुपए खर्चा मैं देता हूँ, लेना बंद कर दोगे इसको।
ये तो सच्ची बातें हैं, मैं एग्री इसलिए कर रहा हूँ क्योंकि मैं खुद 10-12 साल से बॉडी बिल्डिंग में हूँ और मैं बीसीए की जगह जो आप बोल रहे हो वही लेता हूँ।
हाँ, देखो हो गया ना बचत। वही तो मेरा समझाने का फंडा है ना भाई, आप जितना जहां से बचो बचाओ। और आज की डेट में जो भी यूथ है, चाहे भाई की फैमिली देख रही है चाहे मेरी फैमिली देख रही है, एक ही बात बोलूंगा, स्वैग के चक्कर में ना जिंदगी दाव पे मत लगाओ।
सो इनके चक्कर में हमको भी जिंदगी दाव पे नहीं लगानी है। वी आर मीन्स वी थैंक यू। सो वी आर एजुकेटेड पीपल, वी नो अंडरस्टैंड दिस थिंग्स। तो हमें पता है कि BC इज एंड व्हाट इज़ द डिफरेंस बिटवीन द इलेक्ट्रोलाइट। अगर आप ये वीडियो देखेंगे तो यू अंडरस्टैंड कि ही सेड कि इलेक्ट्रोलाइट में आपको फिर से सॉल्ट डालना है। So as we know already, there is the balance between the electrolyte balance is sodium and all potassium and all that things. सो ऐसे इन्फ्लुएंस से हमें बचाना है सबको. नाउ बिफोर गोइंग अहेड आई जस्ट वांट टू टेल यू, जब भी हम जिम में जाते हैं, जस्ट वी वांट टू डू द एक्सरसाइज एंड 2 days के बाद somebody asking us आपको तो वे प्रोटीन लेना ही होगा. Then after 2 days they insist you to take the BCAA. उसके बिना तो आपको एनर्जी नहीं आएगी. And after another 2 days then you need a pre-workout and then you need a fat burners and all that, and it is going on. So we have to stop these things and we have to look at this ki what are the side effects of a supplements and all that things. So we need a screening, and Gitanjali ma'am will tell you in details how to screening for your supplement and all that things. So today's agenda is health supplement benefits, side effects, precautions, and conclusion. So first, pre-workout supplement. It's a multi-ingredient dietary formulas designed to boost your energy and athletic performance. It consists of amino acid, basically beta-alanine, arginine, and citrulline, and caffeine is the most ingredient, and creatinine and artificial sweeteners for the taste. Pre-workout supplements often include this compound that your body uses to make a nitric oxide, and beetroot juice is the natural source of dietary nitrate. I'm working with the athletes and we are giving this beetroot juice pre-workout. What they do, it boosts the oxygen and nutrient transport to your muscles and which help to increase the performance. Is it safe to take? Yesterday only one of my client came to me and he just asking me कि आपका lecture है तो आप क्या बोलने वाले हो. तो ऐसे प्री वर्कआउट, तो उसने मुझे बोला प्री वर्कआउट बहुत डेंजर होता है और मैंने लिया है और मुझे बिल्कुल भी नींद नहीं आ रही थी. तो मुझे ऐसे लग रहा था कि उसके वीडियो मैं करके यहाँ पे भी दूँ, बट इट इज़ ओके. सो दे आर नॉट कम्प्लीटली रिस्क फ्री बट इट इज़ जनरली सेफ, क्योंकि गाइडलाइन जो है दैट shows that it is safe. Some people may trigger symptoms like a gas and bloating and diarrhea because of artificial sweetness. The major energy boosting element of a most pre-workout supplement is caffeine, and its increased blood pressure, and agar insomnia problem is there, then you have to avoid this. And stress, single dose give you equal to 2-3 cup of coffee, and you know that ki who is doing the gymming, they are more having the black coffee, so it's a danger. Then should you take it? When a lack of energy or difficult to perform your workout even after good sleep, hydration and diet, then you can take natural substitute. Substitute for a pre-workout health supplements are banana, homemade peanut butter and almond butter. I specifically mentioned that the homemade butter, and because nowadays they are adding hydrogenated fat and vegetable fats in peanut butter and almond butter. Black coffee, and how to take it, read the instruction. There is already instruction mentioned in that pre-workout dabba or packet. 30 to 60 minutes before you work out you can have it, and consider the timings. So if you don't have आपको अच्छे से नींद नहीं आती है तो then, और आपका वर्कआउट अगर इवनिंग में है तो you should avoid this pre-workouts. Side effects, beta alanine, tingling sensation, और अगर आप if you are asking the जो भी कोई pre-workout लेते हैं तो they get the sensation over here and sometimes tingling sensation anywhere. Branch chain amino acid, it contains leucine, isoleucine and valine. Role of BCAA, increase muscle growth, enhance exercise performance, reduce soreness and fatigue, and prevent muscle wasting and support liver health. How it works, BCAA is broken down in muscles rather than liver, and so it gives the instant energy production during exercise. BCAA reduce the fatigue during the workout by reducing their production of serotonin in your brain, and leucine plays a biggest role in build the muscles. And nowadays, that's why BCAA is more in. BCAA is reduced soreness and the lowering blood level of the enzymes creatine, kinase, and lactate dehydrogenase, which involve in muscle damage. Which one is the better? Combination with the vitamin B6 and glutamine acid is the better options. According to the study 2017, 5.6 grams after workout had a greater resistance workout, had a 22% greater increased muscle mass. And standard dose combination of leucine 1.5 grams to 6 grams and 800 mg to 3 grams of isoleucine and valine. Standard dosage is a 20 grams of BCAA in 300 to 400 ml of water. And it already mentioned in that package. BCAA continued best time to take is before, during and after workout. These all are the food alternatives than BCAA, like meat, poultry, beans, and lentils, dairy food products, tofu, eggs, quinoa, nuts, and seeds. And it give you around 4 to 5 grams of BCAA. Side effects: leucine 2 to 10 grams and isoleucine 48 to 72 milligrams per day of body weight, and it is safe. Avoiding maple syrup urine diseases. Isoleucine is more than expected amount. Some people may experience the gastrointestinal upset, and it's also correlated with the serum insulin, cardiovascular diseases, and type 2 diabetes. So these are the best food sources of BCAA. If you are look at beef, chicken based, give you that 5 grams of BCAA. Now protein supplements. So first is the soya protein. Soya protein isolate, it is in the form of a soya protein isolate. 90 to 95% is protein. It is the cheapest, and that's why it is most of the people are taking. It is often mixed additional nutrient to improve taste, texture, and nutritional value. 28 grams, you give the 25 grams, 0 grams of fat and 0 grams of carbs. All essential amino acids is present, only less amount of lysine amino acids. So we have to do the combination with the lysine. It's good for vegan. It contains no cholesterol. Soya protein has a less potential for producing ammonia, and soya proteins also contains phytochemical which is support cardiovascular health and prevention of osteoporosis. Soya protein provide a high level of concentration of BCAA, which helps to build the muscle mass, and best absorption of soya protein in combination with when we are taking with the oats or maybe rice because of a lysine. It contains phytate and reduce the availability of iron and zinc. So we have to need the supplements of iron and zinc. So myths: concern is isoflavin and thyroid hormones. Nowadays we know that it is not that means studies are not shows relevant what is called as show very mild effects. It has been linked to lowering testosterone in men and increasing fat. It is an overstatement. Soya isolate protein provider made from defatted soybean flakes and have been washed in ether alcohol or water and remove sugar and fiber. It's a highly processed. पी प्रोटीन पाउडर नाउअडेज इट इज़ वेरी इन. आप कहीं कोई भी देखोगे तो आजकल अगर इंस्टा देखोगे, फेसबुक देखोगे और गूगल देखोगे तो यू गेट इट टू नो दैट की दैट पी प्रोटीन powder everywhere because it is a very hypoallergic. It's a made by extraction protein from yellow pea. It's a high quality plant based protein powder, only low in methionine. Good in it's good for naturally vegan and hypoallergic. Nutrition fact is 20 grams, you will get the 15 grams of, but it is very high in sodium, so hypertension patient cannot have. A great source of BCAA, especially arginine, leucine, isoleucine, and valine, which promotes muscle growth. Easily digestible protein powder, no gas forming, no burpings and all. Rich in iron, keeps you full, so good for weight loss and good for heart health. Way to take it: best absorption with a high methionine rich foods like eggs, fish, poultry, beef, pork, and if you are a vegetarian, then brown rice is the best option. Have with vitamin C because of the iron absorption. Added in oats and cereals and a rice smoothie with vitamin C rich fruits, you can have it blended in any smoothie. Side effects: it is expensive, it's low in fiber, and it's a high in sodium, so not recommended for the hypertension. Whey protein powder. There are two kind of a whey protein powder supplementation. One is the casein and one is the whey protein powder. Casein shows a digestive, take it 7 hours, and that's why the people are taking at night. Casein extended the release of amino acids into the bloodstream, improving nitrogen retention, and casein protein contains a various bioactive peptide, and this peptide partially digested in the stomach. So if you are taking casein at the night, your cortisol and growth hormones are more work at night, and it will really help to increase the muscle mass. Whey protein powder, whey protein concentration, whey protein isolate, and whey protein hydroxylate. So now nowadays we are using the whey protein isolate. WPC, it contains low fat and carbohydrate. It's the cheapest than other two. Concentration 30 to 90%. Whey protein isolate 95%, and whey protein hydroxylate, it's a degraded protein and the taste is the worst, and it is using in cereals and all that things. Even Cerelac जो होता है उसमें भी this kind of whey protein in a smaller amount they are using. Excellent source of a high quality protein. It promotes muscle growth. Whey protein may lower blood pressure. It is good for a type 2 diabetes, highly sustaining, which may help reduce hunger. And whey protein can help you lose weight. And Osteoporosis International 2009 conclude that whey protein intake beneficial for a bone health. So there are 2 studies which concluded that whey protein supplementation during resistance training offers some benefits compared to resistance training alone. And it is also increase the lean tissue mass. Recommended doses of protein, it is according to what is the requirement. Up to 2 grams of a protein per kg body weight is considered as safe, and whey protein recommended doses is 25 to 50 grams per day, but not at a time. For lactose intolerance, WPH and WPI is recommended. People can consume 2 grams of protein per kg body weight daily long term without any significant side effects. Most research indicate that more than 2 grams per kg body weight daily of protein for a longer time is not recommended. Side effects: stomach pain, cramps, reduced appetite, nausea, headache, and acne. And who had the lactose intolerance, it is difficult to digest. Not recommended 2 scoop at a time. So if you want to take the 50 grams, you have to adjust the timings. Glutamine is a popular dietary supplement consumed for purported ergogenic benefits of increased strength and a lean body mass, quicker recovery, decreased frequency of respiratory infection, and prevention of overtrained states. It's a non-essential amino acid. L-glutamine is the important form. It is formed from glutamic acid by the addition of ammonia and vitamin B6. It helps to increase muscle protein synthesis, and glutamine is a vital to immune function. It's beneficial for a disease individual who's suffering from a muscle wasting, and it may be benefit who are not having enough protein. Dietary sources are, these all are the dietary sources: eggs, rice, meat, cheese, yogurt, spinach, and cabbage. How to take it? Standard dose is 5 grams, approximately 45 grams per day for 6 weeks during a period of a high stress. Dose is commercially supplements typically range of 1 grams to 10 grams, and it is very good in the IPD patients for muscle wasting, who older patients basically. How to take? When to take it? Every 2 to 3 hours. Over supplementation of glutamine can contribute to ammonia overload, and glutamine alpha ketoglutarate is recommended. Short-term use is safe, but personally, I'm not recommending that. So conclusion: moderation is the key for a healthy life. Some natural food also provide the same effects. Need to decide the requirement for the supplement to it's a mandatorily required, and we have to do the KFT and another other parameters. Screening test must be there, and it's needed for you. Then take a supplement depending on your goal. Vegan people can have that, and these all are the references. Choose wellness, choose healthfulness, choose your food wisely. Thank you.
Dr. Meghna,
Actually, both budget.
one question is there.
Sorry.
How do you decide the type of nutritional supplement pre-workout depending on the type of exercise, whether it is endurance exercise like cycling and swimming, or resistant exercise like weightlifting? Because what should be the ratio of the carbohydrate and protein? Because if you give only protein, because carbohydrates will be required in a supplement, nutritional supplement, what should be the ratio? And depending on the type of exercise, your nutritional prescription, how it will vary?
Yeah, sir, first of all, we have to understand goal. Supplement requirement, long term supplementation. आप अगर कुछ दिन के लिए जिम जा रहे हैं and all that things, then there is a no need it. I'm a sport nutritionist in the university, and what I found कि अगर आप banana, and if you have the doing the running and all that things, aerobic exercise, you are having the banana or maybe peanut butter or maybe one bread with peanut butter or dates, that is enough for you. And for a pre-workout, like I'm never suggesting the pre-workout because you will get it from the coffee also. If you want to really weight reduction, then if you are having the 1 cup of small shots of a coffee, you will get the same result.
And what is your take home message regarding the natural substances which are available, like the green tea, coffee, and other extracts like soluble fibers, and this
in pre-workout? No, there is a not recommended because
Okay.
fiber is very difficult to digest it. When we are not recommended to have.
So we'll be discussing all this in detail regarding what can be given. I'll be focusing on what fat burners are used, and we have Dr. Imran coming in. So we all three will answer all the practical questions. So I'll keep my presentation for a very short time so that we have more time for discussion to get you some practical insights, because all of us are working in the field of sports.
So all three will present first. What they will give us the knowledge, and then the questions will fire.
So with that, I would like to invite Dr. Gitanjali Bide. She is a renowned young sports and fitness nutritionist from Pune, and she's the secretary and from the Association of Sports Nutrition and Fitness Sciences, and she's also the consultant at Army Rowing Node Lakshya Sports Foundation, and she's the founder nutritionist of Army Sports Institute in Pune, and she's the nutritionist to many elite Olympic athletes. So, and she's also the faculty at Symbiosis International University, Pune, and she has her many courses, and she's also the guide to many students. So, over to you, Dr. Gitanjali.
Thank you, Dr. Kavita, for this introduction. And without spending much time, I would like to discuss about the most important aspects, that is the fat burners, about the bright and the dark side of pre and post exercise supplementation. So, as you all know, the weight gain journey is very long. It takes months and years to gain weight. But when it comes to weight loss, there is a quick fix. People want to move from size XXL to small size in a short time. And that is how people start looking for options which are very simple, very quick, and that gives you quick results. So they don't think about it whether it is really going to have that impact, because the weight gain journey has been very long. The weight loss journey has to be very short. So for that reason, we have a lot of magic potions and pills that are available in the market. So there are fat burners, there are some advertisements which we Google through when we have, it's like what you think you see. It's like that with the AI, and that is the reason people don't want to exercise. They want nothing to do, but they want to lose weight. And how they do that? For the effective weight loss, they don't want to take any efforts, and for that reason, something that is magic pill that comes to their easy access is the fat burners. Very important thing is that first is exercise. Exercise is a priority, but we also see a lot of mishaps and injuries that are happening in the individuals who are overweight or obese. So it is a very important thing that pre-exercise screening is mandatory. All the nutritionists should be taking this history before you consult or give any kind of a subscription for any kind of a supplement. So first analyze their exercise, what kind of exercise they are able to do, and do the PARQ test so that you know whether they will be able to do the exercise. And if they exercise, then comes the fat burners. So the thing that is happening nowadays is like stacks. So you have multiple fat burners. If you, it is very common. I have seen that in some of my athletes and clients, they have no food to eat, but they are eating only supplements. So their budget of the supplements goes beyond 25,000 rupees a month, which is very, very high. And they are stacking supplements which are fat burners, they are thermogenic, they increase lipolysis, then they also promise you to increase the muscle mass, and it is really a very expensive affair. So you can see that there are carnitine, yohimbe, and forxlin, and so many other products that are given to them. There are meal replacers which are available in the market. You will see people carrying this message, lose weight, ask me how. And and what do they prescribe? It is all different kinds of supplements that they are going to give to the individual in order to lose weight faster. So the fat burners and claims are like they are generally a thermogenic supplement, and they either reduce the appetite or increase the satiety. So there is a feeling of fullness, and also increase the lipolysis, that is breakdown of fat will happen, and thermogenesis. So increased use of fat as a source of energy will happen if you consume those kind of supplements, and they help you to lose weight. The next thing is that I'm going to discuss 4 or 5 important fat burners which are considered as fat burning agents, and many people are using them. L-carnitine is one of the most popular fat burner that is used, and its role is it helps in transporting the fatty acid into the mitochondria to be used as a source of energy. So it spares muscle glycogen. It is effective in weight loss, but one word of caution is that L-carnitine is effective only in athletes or people who work out. So if people are not doing exercise, it's of no use. If you don't exercise, no fat burner is going to work. The dose or the protocol that is generally used is 1 or 2 grams before the exercise or before a meal. There are no known side effects. However, there are certain positive things about L-carnitine. That is, it lowers the inflammation. It reduces the muscle soreness. It's very common for a person who goes to a gym. After 1 or 2 days, they start getting muscle soreness in the thighs, and in athletes also we see a lot of muscle soreness. So for that reason, L-carnitine is an effective supplement with no side effects. Then caffeine, as Meghna has also mentioned about caffeine, it helps in lipolysis and it also has a calming effect. We become more alert, and it is a thermogenic supplement. It improves your concentration. Studies have shown that in compared to a placebo, caffeine will increase the fat burning. The fat burning is not as effective as exercise. It just helps in stimulating that. So the dose of caffeine is 3 milligrams per kg of body weight. So it is equivalent to a properly made decoction of black coffee. So that also acts as a fat burner. So there is no need of taking a caffeine supplement. But caffeine supplements are used in various forms by athletes. Like they have a chewable tablet. Also, they have caffeine which is added into a pill form, or it can be added to pre-workouts. However, it is very important to assess the athlete or any individual whether they are caffeine sensitive. So if they are caffeine sensitive, then genetically, then you cannot recommend caffeine to them, and it increases the heart rate, and it's a restricted substance. So if you are looking at athletes, you cannot give more caffeine. Then Garcinia cambogia is again a very popular supplement. The active ingredient is hydroxycitrate, and it can be consumed 30 to 60 minutes before meals. And it is helpful, but it also comes with certain discomforts like headache, common cold, or some may experience gastrointestinal symptoms. Then berberine is again now a very popular supplement. I must say that I have never used it, but it is a bark, and in Ayurvedic medicine it is called as Daru Haridra. So you will see a lot of Google and Ayurvedic prescriptions that are coming up, which are recommended for quick weight loss. The side effects is nausea, vomiting, etc. And it also interferes with a lot of allopathic drugs that are used for treatment. So all these berberine or have to be used with caution, and asking the client about the medications that they are taking is extremely important. Yohimbe is another fat burner, and it is also similar to that, and it is also the extract of the Yohimbe tree, and the dose is around 20 milligrams per day, and it can be consumed 2 times a day. And the side effects are like it interferes with certain absorption of nutrients. So that is the reason it is again to be used with caution. These are some things which are very commonly prescribed by trainers and gym. You will find them in gyms. So many people fall prey to these kind of supplements because they feel that it is going to aggravate their fat loss. But whatever data about the herbal medicine is available, it shows that although there are a lot of evidences like ephedra, Garcinia cambogia, or Google, or many other supplements, weight loss definitely is there, and it improves their satiety, improves their fasting insulin levels. But adverse effects are gastric issues and other headache, dizziness. The most important thing that you all must look at is that all these um, marketing gimmicks like 2 pills a day blocks the fat storage. You can look for this particular website called My Sports Science, which gives you very beautiful information, very easy made creatives which help you to understand what are the claims of different supplement products. It is by Asker Hagenrup, a very well-known sports nutritionist. And facts about burning fat is that exercise is of prime importance. Your diet, intensity of exercise, the climate, gender differences in fat mobilization are also evident. And fat burners will work only when you exercise. So there is no magic pill that is there. There is nothing that is uh, going to help. So you have to exercise to lose weight, or you have to be physically active and also have a proper diet. Way forward for a practitioner is to review the products that are available. We have to be ahead of time. We should be reviewing what is available in the market and from where the source, because so many products are there. You will be surprised to see the comments that you get from your clients that this is the product which is available. Can I use this? But we ourselves are not aware about what are the different products that are available. So you have to be very thorough. Look for a website like examine.com, which gives a thorough investigation of a supplement product that is available in the market, and also request information, asking them questions at what they are consuming. And a consumer should actually seek professional advice and read labels carefully. So I here end my talk, and we can have Dr. Imran to start with the discussion.
Yeah. Before Dr. Imran comes here, I have one important announcement that we have the third session starting, and we have Dr. V.K. Bhardwaj, who has come all the way, who's in charge of NCD project of WHO in Nagpur. He's placed at Nagpur. So we invite Dr. Bhardwaj to please join the esteemed chair there to chair the whole session and also moderate with Dr. Ehsan Badar, Dr. Mishra, and with himself. So we have Dr. Bhardwaj, can I request you to please join on the dais? Yeah, please, please. Over to, yeah, you come, Imran. Yeah.
Dr. Imran Noor Mohammed, he is a consultant anesthesiologist and intensivist, director, Critizone Hospital, Nagpur. He is a certified fitness and lifestyle modification advisor. He is the youngest President Citation Award receiver from Indian Society of Critical Care. He is also a teaching faculty at various workshops and critical care medicine conferences. And he has also participated in various debates on diet and diabetes. Over to you, sir.
Thank you for a kind introduction. And at the outset, let me thank this team for giving me the opportunity for this very passionate subject to me. So, first of all, I have not made any slide for this because Meghna and Dr. Gitanjali, they have already told you about all the supplements. The supplements have been covered in very much detail. I will be speaking mostly on the evidence-based. Why supplement? Who should take the supplements, why, how supplement works. So we'll be keeping it very short. I'll finish my talk in just 10 minutes and then we'll have a good panel discussion with the panelists. So as a doctor, we see patients. 95% of patient comes to us for obesity, for hypertension, for diabetes, and our aim and our goal is for them to lose weight. And we advise them diet, exercise. Okay. So we'll see where supplement comes from. 90% supplement works in athlete. Supplements are for athlete, those who have achieved their goal or those who have some goals like cricketer, a bodybuilder, a person who wants to go on a stage with 6-pack abs and remaining, throughout the year below 10% of body fat. And number two, as a doctor, when we see patient recuperating from severe illnesses, patient with old age, patient who have lean obesity, patient who have sarcopenia, patient who post-operative patients, there we can wonderfully, club this supplement for their improvement. Let's talk about caffeine. Caffeine is a very important ergogenic supplement, mostly found in all kind of fat burners. Okay, so in fat burner, what I have seen, I'll quote the examine.com with Dr. Gitanjali Bhide has said, it is the only caffeine which works as a fat burner and not anything else. Caffeine in the dose of maximum 300 milligram, even 60 milligram of caffeine works as a wonderful fat burner. But how? What is the mechanism of action? It basically reduces your appetite. It makes you eat less. There is slight thermogenic effect also because it mobilizes the free fatty acid for the disposal. It generally helps in more aerobic metabolism. L-arginine. L-arginine you must have seen like how supplements are misused in gym. A person like you and me is going to gym for weight loss. What is the basically the scientific basis about the weight loss is energy deficit. If you are eating in an energy deficit, calorie deficit, no one can stop you from losing your weight and gaining the fitness. Okay, so what happens, you go to gym, you find a gym trainer and he promotes, आपके पास आ जाता है वो कि सर आपको ये सब सप्लीमेंट लेना ही पड़ेगा, एंड वहां से वो वी फॉल इनटू द ट्रैप एंड दैट विशियस साइकिल बिगिंस. 95% of the people who don't need any supplements, they are taking supplements, and those who need supplement, those who genuinely need supplement, they are devoid of it. So I'll tell you who basically needs supplement. L-arginine. Caffeine is good. Caffeine, I recommend caffeine to each and everyone. If you have grade 1 fatty liver, if you are obese, even if you don't have any disease, if you are starting your day with a black coffee and 2 cups of black coffee in a day, mind my language, it's a black coffee. It's not like a regular cafe latte and sugary and milky coffee. 2 cups of black coffee. Now there are meta-analysis. Many hepatologists, some of my friends who are influencers, hepatologists, Dr. Cyrus Abri, Syriac, Dr. Syriac from Kerala, he has done a study that 2 cups of black coffee a day along with vigorous aerobic exercises has brought down grade 2 fatty liver to grade 0. It has reversed the liver fibrosis. So it is a magical. We'll discuss in detail later on. You can Google effect of caffeine on non-alcoholic fatty liver disease. L-arginine, the supplement, L-arginine is very good for hypertensive patients. A hypertensive patient who is joining a gym, who is working out, who is doing a treadmill, we can safely give them L-arginine because it improves the nitric oxide. It is a precursor of nitric oxide. It helps you bring down the blood pressure. So this is a good effect. L-carnitine, as already Meghna and Gitanjali has discussed with you, L-carnitine helps you mobilize free fatty acid into the mitochondria. But why? If you are doing a diet, if you are doing a calorie deficit diet, then it works. Even though if you are eating a calorie deficit diet, you don't need supplement. Many of the time, 99% of the time, you don't need any supplement if you are just looking for weight loss and leading a healthy life. Citrulline maleate, again, citrulline is a precursor of L-arginine and it helps increase nitric oxide and helps, doing some more exercise, doing some more repetition if you are taking L-arginine. Another wonderful and the safest supplement on planet Earth is creatinine. एंड मेनी एज ए डॉक्टर, अगर आपके पास पेशेंट आ रहा है और बोल रहा है कि मैं क्रिएटिनिन लेता हूँ, हम लोग पैनिक हो जाते हैं और हम उसको मना कर देते हैं, बट वी डोंट नो कि व्हाट यू आर डूइंग. क्रिएटिनिन हैज along with some weightlifting benefit. If you are having a creatinine, basically creatinine, what does it do? It helps you generating more ATP. It gives the extra phosphate bond to the already abundant ADP in the body. Adenosine diphosphate plus 1 phosphate. It makes adenosine triphosphate and it makes you exercise little more. So creatinine is a wonderful natural supplement and I think everybody should have it 5 grams a day. But if you are working out, glutamine, essential amino acid, this Meghna has wonderfully covered. There are many herbal supplements like ashwagandha. There are no good scientific literatures. I don't believe in herbal things unless and until you have some good meta-analysis. If you have some good, as a modern medical practitioner, we should always evaluate the good and bad effect. As a doctor, as a modern medicine practitioner, you should not feel trapped to this kind of herbal supplement. Even Herbalife I don't recommend, because if you Google Herbalife associated liver injuries, you will find thousands of references. Herbalife is banned in Europe, completely banned in Europe now. It's only Indian market. It is because of the वो business का chain है और लोग पैसे कमा रहे हैं उससे. And as I already said, के 95% of the time you don't need any supplement if your goal is to remain fit and if your goal is to remain fit. Who requires supplement? It is athlete and old age people. So I think like we can move ahead for the panel discussion. Thank you so much.
Thank you, Dr. Imran, for excellent presentation.
Yes.
I think you said it is creatine, not creatinine.
Yes.
Creatine. And because we are discussing in context of obesity, so my question is because the aim is to lose the weight and make it ideal body weight. And so, what type of supplements you can advocate for the as far as the nutritional aspect of the obesity management is concerned? Is not the,
In my opinion, no supplement, sir. Absolutely, because supplement का role अगर if it is giving you some benefit and if the patient is devoid of that supplement, if the patient is in need, if you evaluate, then only I will prescribe. Otherwise, I am not in favor of supplement at all as far as it is concerned with the weight loss. I'll see the what Gitanjali says.
Would like to add a point when there is protein deficiency, the protein intake is not adequate, then there is definitely a need to add a protein because there are a lot of Indian normal vegetarian population. So they don't meet the protein requirement of 1 gram per kg of body weight. So if they want to lose weight, definitely there is a need to add a protein supplement that weight loss is. That is my opinion.
Sorry to differ in this. As a doctor, I don't consider protein as a supplement. Protein is food. Even whey protein is food. Supplement is माइक्रोन्यूट्रिएंट और जो हमको डाइट में नहीं मिल रहा है. इवन क्रिएटिनिन भी हमको डाइट में मिल जाता है इफ यू आर नॉन वेज ईटर, बट एब्जॉर्प्शन नहीं है और वहाँ आपको नीड है. तो सप्लीमेंट एंड फूड प्रोडक्ट दे आर डिफरेंट. आई अग्री, मेनी कंसीडर प्रोटीन एज अ सप्लीमेंट बिकॉज इट इज वे है तो इसलिए हम लोग को सप्लीमेंट समझ रहे. बट वाई, मतलब फॉर वेजिटेरियन पीपल जिसका फूड से प्रोटीन हो ही नहीं रहा है तो वो वे प्रोटीन ले रहा है. वे इज जस्ट पाउडर है, वो बेसिकली कंडेंस करके बनाया गया है मिल्क को. तो आई कंसिडर इट एज अ फूड, नॉट एज अ सप्लीमेंट.
so you mean that all these products are falsely promoted by media and there is no science behind
Absolutely.
it? None of them are regulated by FDA also.
In India, unfortunately, के nobody knows what you are getting और कौन जिम के ट्रेनर ने बोल दिया तो आप ले रहे हो. Otherwise, I think it has to be regulated. Because now there is adulteration. In the name of pre-workout, people are adding amount of caffeine. People are adding so many herbal things which you don't need, which you don't know how it is working, and people are getting heart attacks in the gym.
Excuse me, I have a question. Do you have different types of supplements and proteins for different season of the year, or you have the same for winter, same for summer, same for rainy, or whatever it is? Does the temperature and the climate and the weather vary, makes you change your prescription?
We don't change as per the climatic conditions, but we actually look at the training program, and based on the training program of athletes, we see the periodization, how there is nutrition periodization for athletes, like we plan the nutrition requirements for athletes. Similarly, the supplement plan is also given along with that. So it is in different phases of training and competition, different kinds of supplements have to be recommended through them. But I think the weather condition is definitely not taken into account. But to add a point here, that as Indians, we know that our dietary pattern changes with the weather. We have different foods in different weathers. All that is already there in our system. So, but for supplements, unfortunately, such kind of work is
See,
not yet done.
what is the old dictum that if you obey the weathers and the fruits which come in the weathers, like mango in the summers and sitafal and all this in jam in the winters, you will have all the supplements given by God. Second is, do you have supplements for rich? Do you have supplements for poor?
I think supplement is a very expensive affair. There is a lot of money involved in it, but we try to, as nutritionists, we try to.
But Meghna showed us that egg contains this, meat contains this. So you can, if a poor person has come to you, if you suggest him a costlier supplement, then you are a failure.
We don't.
For example, I sent a Bengali patient of obesity to a nutritionist. She prescribed her Maharashtrian diet. She came to me, I don't eat anything of Maharashtra. So it is like this. If a poor patient comes to you or poor person comes to you, he wants supplement from you, and you should have a battery of poor things
We do have food combinations to
Can
improve
we
them.
use sattu for poor
Yes,
patients?
we do use sattu a lot. We use ragi malt a lot. And we also have combinations of foods that can increase their protein intake. And eggs is a very easier and cheaper available.
And sorry, one last question. I am a bariatric surgeon. I come last always. When everything fails, the bariatric surgeon comes. One question, last question is, do you have a supplement of protein which maximally absorbs in the lower small intestine?
Whey is the most fast absorbed in the
In
lower intestine.
lower small intestine, like terminal ileum or ileum, not the jejunum. See, in the small intestine, there are two. Upper part is jejunum, lower part 50% is ileum. So after the bariatric surgery, bypass surgery, you have jejunum bypassed. So your food enters the ileum and gets absorbed in the ileum. Do you have any supplement? Because protein supplement in bariatric bypass surgeries is a must, most important thing. So if you can take out a formula which only gets absorbed in the ileum, and most
I
of the
think
world
I,
will.
I think we have whey hydrolysate pre-digested. I'm speaking, sir, here.
Okay, sorry.
So it is a whey hydrolysate pre-digested where it doesn't need digestion because you have bypassed the digestive part. Now you need the absorption only. Okay. So we have whey hydrolysate along with some essential amino acids,
Right.
which gets into the circulation and promotes muscle protein synthesis by adding more and more leucine, as a easy leucine threshold.
Right.
And pre-digested whey hydrolysate, it is a wonderful source.
Thank you.
Pardon? For vegetarian, I think all dairy products, cheese, paneer, buttermilk, curd, along with soy. Even soy protein, there were many myths before that it reduces testosterone, it feminizing kind of, patient get gynecomastia, but actually there is no evidence, scientific evidence behind it. There are many countries where people are eating soya chunks since ages, and they are as healthy as, from other counterpart. So class 1 protein, soy protein, and all kind of dairies, and you can add supplements in the form of whey and essential amino acids. For easy, class 1 protein is always paneer and from animal source, like vegetarian animal source, like milk protein and paneer and curd. The bioavailability of soy is little less, but it does have all the essential amino acid at the same time. So you'll have to eat more soya to get some decent amount of protein. I won't discuss any brands here. I don't discuss. We'll have the in person.
Running short of time, so cutting down here, I would request the chairpersons to please.
Excuse me, just
Okay, sir. Okay.
a lot of artificial sweeteners and other flavoring substances are being added to the protein.
Dr. Bhadla.
I think defending dietary supplements in an obesity workshop is a tough job, but the speakers have done it admirably, and that too with a scientific temperament. Thank you. Let us conclude.
Thank you. Thank you so much. Thank you. You can ask us questions at the time of lunch if anybody has.
May I now request the chairpersons to felicitate the speakers, please? I invite Dr. Sunil Gupta, sir, to please felicitate the speakers. I request Dr. Sunil Gupta, sir, to felicitate the chairpersons as well.
clapping is an exercise.
Thank you, sir. We really has a knowledge busting sessions, and now we have the gems of direction fraternity in TED Talks. I invite Dr. Kavita Gupta ma'am, who needs no introduction. She is to moderate the session. Yes, I also request Dr. Shakti Sharma ma'am to. Yeah. Shakti Sharma ma'am, she is a convener of NSI, Nagpur chapter, who she runs his own clinic, Nutrition and You. She is dedicated clinical nutritionist with a holistic approach. We welcome you, ma'am.
Yes, so thank you.
Up to you.
Yeah, thank you, reporters. And yes, yet today again we are on a very, very interesting topic. We're going to have a quick TED talk of 10 minutes on very interesting topics. I think they are something what we always Google, and especially for the people who are looking for weight loss. So, they are always looking for different options. So we have eminent young dietitians with us who are going to speak on different types of diet. And so before Googling, I think we should also understand there are all these number of diets, whether these diets are really doable. So there are a lot of things. It's food is always attached to us as in like for the mental, emotional, and even like for the physical well-being. So we should always understand whether a particular diet is it doable and can we do it, or is it sustainable and can we really do it for a longer time. So let's listen to our young dietitians over here.
Yes. So we invite our first speaker for today's TED Talk, Mrs. Vinita Mehta. Mrs. Vinita Mehta is MSc Food Nutrition, and she is a certified diabetes educator. Has an 18 years of working experience in field of dietetics. Receives NutriStar 2020 Best Dietitian Award by IDA Nagpur chapter. Presently, she is Secretary, Nutrition Society of India Nagpur chapter, and also an executive member of IDA Nagpur chapter. She delivers diet awareness lectures at various social platforms. She has been running the Nutri Rasoi, Nutri Canteen project, conducted, scripted various skits and role play on diabetes education, has a diet clinic since last 4 years, and contributor for research paper presentations on subjects like gestational diabetes mellitus, cancer, insulin requirements for type 2 diabetics, pregnancies at DCRC Nagpur. We are looking forward to your session. Over to you, Vinita ma'am.
She would be speaking on keto diet. Should be speaking on keto diet.
Thank you so much, Dr. Shakti Sharma ma'am and Dr. Kavita Gupta ma'am. At the outset, I am really thankful to my mentor, Dr. Sunil Gupta sir and Dr. Kavita Gupta ma'am and the organizing team to giving me this opportunity to present my thoughts in this prestigious platform. So I'm really thankful to them. So my topic, weight loss, choosing a diet that's right for you. And my topic is ketogenic diet. So prevalence of obesity. At obesity, like this 1 billion people globally estimated to be living with obesity by 2030. This is the data of World Obesity Atlas 2022. And yes, the World Obesity Atlas data published on the prestigious World Obesity Federation predicts that in every 1 in a 5 women and 1 in a 7 men will be living with obesity by 2030. So this is like a ticking time bomb, and with to tackle with these challenges, we know that obesity treatment is required, and diet and lifestyle modification is the base pillar of obesity treatment, as we are seeing here that multi-components, intensive behavior intervention and prescriptive nutritional intervention is the base of obesity treatment plans, and this pyramid shows it's very well. So yes, finding yourself little confused by the endless promotion of these fancy weight loss strategies and diet plan, we take a look to a ketogenic diet plan. So the history. This is not new at all. 100 years old ketogenic diet plan for epileptic patients. So ketogenic diets have been used to treat epilepsy for the last 100 years. Hippocrates noted that the fasting could reduce seizures frequency. The classic ketogenic diet gained popularity in 1921, but its presence faded with the availability of more anti-seizure medications, which had fewer lifestyle restrictions. As recently as 25 years ago, the ketogenic diet was rarely used as a treatment for epilepsy. The scaling up of keto starts with a study published in Science in January 2012, and it says that anti-inflammatory genes are activated by ketone bodies, which promotes weight loss, anti-aging, Alzheimer's, and some form of cancers. So let's understand ketogenic diet, also known as low carb, high fat diet, keto diet, and low carb diet. The ketogenic diet is a high fat, adequate protein, low carbohydrate diet therapy that in conventional medicine is used mainly to treat hard to control epilepsy in children. The diet forces the body to burn fats rather than carbohydrates. Principle of ketogenic diet? Yes, the principle of the keto diet are mainly based on consuming adequate amount of fats and proteins with a reduced supply of carbohydrate, which is put the body into a state of ketosis. What is ketosis? It's a state of body in when there are more ketone bodies in the blood produced by the breakdown of fats than glucose. Ketosis, the liver produces ketone bodies as a part of gluconeogenesis, a process that produces glucose from non-carbohydrate sources during fasting and hunger. The liver creates three different ketone bodies. They are acetone, acetoacetate, and beta-hydroxybutyrate. When dietary glucose levels are low or absent, healthy humans utilize these substances to fuel their body's cell. Keto diet for weight loss. एंड यस, वेट लॉस का असरदार उपाय जो हम सबको चाहिए, और अब सोशल मीडिया के कारण ये शायद सभी को चाहिए. Since last decade, many studies were published on the ketogenic diet for weight loss, cancer, type 2 diabetes, cognitive impairment, heart failure, autism, bipolar disorder, athletic performance, Alzheimer disease, and even COVID-19 also. How does the keto diet cause weight loss? Simple mechanism: fat is burned for fuel, appetite is satiated from high fat intake, blood sugar cravings are reduced. This all helps contribute to a calorie deficit, as well as helping ensure the calories you do consume aren't high in sugar and are nutrient dense. So the weight loss mechanism works with ketogenic diet makes our body feel complete. And then it is accompanied by major changes in starvation hormones, ghrelin and leptin. Removal of carbs, restricting starch consumption always reduce dietary choices. It will greatly decrease calorie consumption, which is the secret to weight loss. Yes, this is the secret of weight loss for ketogenic diet. Gluconeogenesis, the system transforms fat as well as protein into food carbohydrates. The cycle will consume a lot of extra calories every day. And ketogenic diet can significantly increase insulin resistance, which can greatly improve fuel consumption as well as metabolites. Macronutrient composition of ketogenic diet. So the low carbohydrate, yes, 5 to 10% of total calorie intake, daily calorie intake. Moderate protein, 20 to 25% of total daily calories. High fat, definitely 70 to 75% of total daily calorie intake. This fat is used as the main source of energy in the absence of carbohydrate. Types of ketogenic diet: there are so many ketogenic diet versions are there, and the main is standard ketogenic diet, in which high fat 75%, moderate protein 20%, and low carb is 5%. In targeted ketogenic diet, allows 20 to 30 gram of extra carb intake before and after workouts. And then cyclic ketogenic diet involves higher carb refeeds, 5 keto days and 2 high carb day per week. High protein ketogenic diet is a different, it's an add-on diet pattern. In this, fat 60%, more protein than standard 35%, and carb is 5%. So the traditional ketogenic diet is 4:1. 4:1 of fat to protein and carbs. 90% of calories come from fat, 6% from protein, and 4% from carb. So let's see the keto menu. Your healthy balanced meal thali is where? So what to eat on ketogenic diet? Very, very, very limited sources like eggs, meat, full fat fish, full fat dairy products, healthy fats, nuts, and tea, coffee. Yes, it's allowed. And source of carbohydrate is 5 to 10% only in the form of green leafy vegetables, cabbage, cauliflower, broccoli, and then again tomatoes, cucumber, and berry. Very limited sources of menu in the diet. Again, keto, not to eat on ketogenic diet is simple sugars, sweets, low-fat dairy products, high-starch vegetables, processed sauces with added sugar, and bakery products. Pros of ketogenic diet. Reduce appetite, help reduce abdominal fat, decrease triglyceride, increase HDL, reducing blood sugar levels, fight cancers, and helps in Alzheimer's disease prevention. So the ketogenic diet has been shown in many studies to be particularly helpful for some epileptic conditions. These include infantile spasm, Rett syndrome, and many of them. The disease modifying effect, loss of 15% or more of body weight can have an diabetes inducing remission in a large proportions of patients. Very low carbohydrate ketogenic diet, 600 to 800 kilocalorie per day and less than 50 gram vegetables have been proposed as an appealing nutritional strategy for obesity management. The diet was shown to result in significant weight loss in the short, intermediate, and long terms and improvement in body composition as well as glycemic and lipid profile. Cons of ketogenic diet. The ketogenic diet is not considered a benign, holistic, or all natural treatment. There are so many side effects. The first is keto flu, constipation, kidney stones, low grade acidosis, decrease in bone density, raised level of lipids in the blood. And we have many researchers have suggested that since the keto diets involve high fat, there might be a higher risk of CVD due to a buildup of fats in the arteries. There is a lack of evidence about the long-term safety and effectiveness of the keto diet, and healthcare professionals have called for more primary studies, trusted sources, and evidence before recommending this diet for type 2 diabetes and obesity. So, this is the nutritional fundamentals. We have so many diets: low fat, fully plant-based, paleo, and Mediterranean and keto diet. We need to understand these nutrition fundamentals. Dietary approach: instead starchy carbs, choose whole grains, high quality lean proteins, eat a wide variety of fruits and vegetables, limit sugar, junk food, and alcohol with good physical activity and lifestyle. It may not sound trendy and catchy like keto diet. So, it's very, very simple. You need to understand, and my conclusion is, the contemporary prevalence of the keto diet predominantly endorsed through social media, fitness enthusiasts, and individuals lacking a scientific foundation raise concerns about its potential hazards. And the presentation underscored that keto, when approached as a therapeutic diet, under control measures and expert guidance, can yield desired result. It emerged as a viable avenue for weight loss and proves beneficial for individuals managing type 2 diabetes. It is imperative to acknowledge the importance of moderation and professional supervision to harness the full potential of the keto diet in a safe and effective manner. Thank you so much for your patience listening. Thank you,
Dr. Vinita, for a wonderful presentation. We'll take questions after the
We'll take all the
session of
questions
other
later.
speakers.
Yes.
Yeah. We would also like to invite Sunita Jyotidev ma'am to chair the session. Sunita ma'am is a director of Jyoti Dev's Diabetes Research Center, Kerala, psychologist in the multidisciplinary diabetes care team, associate editor, International Journal of Diabetes and Technology, has several presentations and publications at national and international forums, and she's presented at several international and national forums. Yes, we welcome you, ma'am.
Good afternoon. Thank you for giving me this opportunity, Kavita. And next TED Talk is with Parvinder Verma. She is presently working as a dietitian at Sunil's Diabetes Care and Research Center and the founder of Kitchen the Medicine Box. She is specialized in weight loss and weight gain and all disease-specific conditions. She had been a presenter for the various national and international conferences. And she has given talks in different schools related to diet, and she is actively involved in research in the work of field of diabetes. Over to Parvinder.
Thank you so much, ma'am, for the introduction. First of all, before starting my presentation, I would like to thank Dr. Kavita Gupta ma'am and Dr. Sunil Gupta sir for giving me this opportunity to talk on such a prestigious platform, and thank you RO 2023. Today I am going to talk about on intermittent fasting, which is again like keto is one of the hot topic. History of intermittent fasting. It was started by Folin and Dennis in 1915, and in the starting they were using it only for the obese patients. What is intermittent fasting? Many diets focus on what to eat, but intermittent fasting is all about when you eat. It is a type of diet that focuses more on when you should eat rather than what should you consume. It determines the cycle between the fasting and eating period. Hence, it is a change in the eating pattern. With IF, you only eat during a specific time. Research shows fasting for a certain number of hours each day or eating just one meal a couple of days may have health benefits. How does intermittent fasting works? Studies have showed that after hours without food, the body exhausts its sugar stores and start burning fat. IF contrasts with the normal eating pattern. Study says that if someone is eating 3 meals a day plus snacks and not exercising, then every time we eat, we are running on those calories and not burning the fat stores. Like if we are eating like bulk of in intermittent fasting, if we are eating for some required window period, but if we are eating junk foods and all, it won't work. IF works by prolonging the period when your body has burned through the calories consumed during your last meal and begins fat burning process. Types of intermittent fasting. Intermittent fastings are of different types. The first one is time restricted intermittent fasting. In this, you have you have to snack into a window of several hours and then fasting for the remaining hours of the day. It is the most common approach. Water, unsweetened tea, and black coffee are permitted during the fasting period, and it is very easy to incorporate in your daily life. It has the subtypes: time restricted intermittent fasting. One is 16:8, 14:10, and 12:12. In 16:8 IF, you have to fast for 16 hours, followed by 8 hours of eating window. In 14:10, there is a slightly shorter fasting period of 14 hours and longer eating window of 10 hours. 12:12 IF, there is where many fasters first timers start by eliminating evening snacks so that your body begins the fasting process right after you finish the dinner. These are the basic concepts of intermittent fasting. Like before 12 p.m., you can have tea, coffee, or water. And between 12 p.m. to 8 p.m., you can have your meals. And after 8, only water is allowed. Second type is modified calorie intermittent fasting. It is the combination of time restriction with reduced calorie intake on certain days. It also has the subtype, which is 5:2 method, which is the best accepted method. In this method, you have to eat normally for 5 days per week, and reduced calorie intake is about 500 calories for women and 600 for men for the 2 remaining days per week. Some experts believe that it's more effective because it gives your body a chance to be in a longer fasting state. Next type is the alternate day intermittent fasting. It is again similar like 5:2 plan. It also has two subtypes: complete ADF or total energy restriction, in which no calories are consumed on fasting days. Other is the modified ADF or partial energy restriction, which allows consumption of 25% of daily needs. The fourth type is the OMAD, once meal a day intermittent fasting. This type allows for consuming one meal a day during a 1 hour window, followed by 23 hours of fasting. There are no food restrictions and you can choose the hour you eat. Water, unsweetened tea, and milk-free coffee are permitted during the fasting window. Simple to follow and allowed to consume fewer calories. The serious drawback includes limited food intake, depleted energy, and a crash in blood sugar level among some people. It is highly unsustainable and fallout can cause overeating. Consume close to the recommended calorie intake for your gender, height, and weight. Include a variety of fruits, vegetables, healthy fats, proteins to meet the nutritional requirements. Last type is the extended intermittent fasting, which includes eating pattern that incorporates a fasting window longer than 24 hours. Prolonged fasting could lead to dehydration and even cause the body to kick into survival mode when it starts storing more fat in response to extended period of deprivation. Extended fast should only be done under the supervision of a healthcare provider. What can I eat while intermittent fasting? During the fasting time, water and zero-calorie beverages such as black coffee and tea are allowed. During eating period, try to focus on nutritious meal. Eat nutritious meal. Do not overeat. Like if you are saying I'm on an intermittent fasting and during the eating window you are having pizza, burger or very high-calorie food, it won't work. Does intermittent fasting works? People may gradually lose weight when they practice intermittent fasting because of consumption of fewer calories over the course of day. Additionally, people may lose weight because they eat significantly less and the body produces less insulin. When you eat frequently, insulin helps your body store unused energy as fat. Adjusting to an intermittent fasting eating style. Start by skipping breakfast for a few days to get used to fasting. Gradually shrink the window. It is important to stay hydrated when outside of your eating window. Some studies have shown that the eating style can help people lose weight in the short term. What are the benefits of IF? Benefits include it increases insulin and leptin sensitivity, ghrelin levels, which is the hunger hormone. It increases ability to become fat adapted, decreases triglyceride levels, inflammation and free radicals, and also weight gain and metabolic disease risk. What are the side effects of IF? It includes hunger, fatigue, insomnia, irritability, decreased concentration, nausea, constipation, and headaches. Most side effects go away within a month. Who should not follow IF? Children and teenagers under 18, pregnant women or breastfeeding women, people with type 1 diabetes, people having gastrointestinal discomforts like bloating, indigestion, and constipation, eating disorders, feeling sick, or having low blood pressure, or on certain medications including diuretics and blood thinners. There are some studies which shows that it is one of the study in the Curious which has shown the intermittent fasting benefits, side effects, and quality of life in Saudi Arab population. The study has concluded that the IF diet is an efficient dietary plan for those aiming at a weight loss journey over a short duration, ranging from less than a month up to 3 months. Minimal side effects were found during fasting, being of different intensities, which did not need surgical or medical treatment. Respondents saw excellent weight loss result using the IF diet. Another study is the metabolic impact of intermittent fasting in patients with type 2 DM. In this study, they concluded current evidences suggest that IF is associated with greater weight loss in patients with type 2 DM compared with standard diet, with a similar impact on glycemic control. Another study, which is the effect of intermittent fasting on glycemic control in patients with type 2 DM. Yes. In other study, IF is safe diet pattern and could be implemented for patients with T2DM or metabolic syndrome. Further studies with a larger sample size are needed to verify the effectiveness. In one more study, which is the comparison of effectiveness of intermittent energy restriction and continuous energy restriction diet, which concluded IER can be an alternative to CER because it induces comparable weight reduction and metabolic improvement. Take home message is the most important thing to remember is weight loss isn't one size fits all. Finding something that works you is the key. Overall, follow a healthy lifestyle that includes a healthy dietary pattern and being physically active. IF is a diet that may or may not provide benefits when it comes to greater weight loss, improve metabolic health, or increase lifespan. It's worth keeping in mind that IF is not going to be suitable for everyone, and it is recommended that you seek the guidance of a qualified dietitian. Thank you for patience listening.
Hello. Yes. Now we'll move on to the next session. Insights into the life of a sumo wrestler, medical perspective. I invite Dr. Bansi Sabu sir to chair the session. Thank you. Welcome you, sir.
Over to the next session. And I'm really fortunate to chair the session along with my dear brother, Dr. Banshi. And really, really happy to chair the talk of Slo Gupta, the son of my brother Sunil and sister Kavita. And this is actually a new perspective, we can see that BMI is not the only diagnostic criteria for obesity. We look into the what Dr. Slog is going to tell us. Over to Dr. Slog. I didn't get any thing to introduce. It's fine.
Thank you so much.
Okay.
At the outset, I would really thank you, thank the chairpersons for this, and I would like to thank the organizing committee, the scientific chair of Firocon, for giving me this opportunity to speak today. So, for the past 2 days, we've been really listening a lot about obesity, and today I bring in a very different and a very new topic that came into my mind while just thinking about obesity and athletic. That is a sumo wrestler, which an image that comes into mind since childhood. So my topic today is insight into the life of a sumo wrestler. So this is my agenda. We go into the introduction, a brief insight into history, the facts about sumo wrestling, what these giants are fed. There's this Chanko Nabe versus Indian diet comparison, the risk factors and the mortality rates of sumo wrestlers, the energy-rich diet which these giants are being fed with. Is it a boon or a bane that we'll see? The characteristics of total body and appendicular bone mineral, and so on. We'll go about through sides. So, what does sumo wrestling actually mean? So, sumo in Japanese means wrestling. The history traces back to around 10 to around 1,000 to 1,500 years back, where it was born as a Shinto ritual in order to entertain God. So, it was just not in India where we are very religious. It's also across the community where such tournaments are being organized, and representatives of each province used to travel to a noble court and fight with other representatives. So the sumo stage is called as doyo, which is considered as a very sacred place. And the roof is dressed by purple curtains and tassels that represents the roof of a Shinto shrine. We've been really listening to all things about obesity, and we know that obesity leads to a lot of other obesity-related diseases such as diabetes mellitus, myocardial infarction, hyperlipidemia, and weight-related injuries. So now these are some facts about sumo wrestling. As of today, there are around 800 professional sumo wrestlers, and these sumo wrestlers enter society at a very young age, that is around 15 years of their age, and they have to carry a very hard lifestyle, training for 5 hours daily. An average life expectancy of a sumo wrestler is around 60 to 65 years old, which is 20 years shorter than that of the expectancy of a typical Japanese male. These sumo wrestlers are being fed by a typical high-calorie diet dish called chanko nabe, which is a beef stew and vegetable hot pot. These sumo wrestlers may consume around 5,000 kilocalories of food per day, which is twice than that of what is recommended in average Japanese population. The prevalence of medical condition and injuries is far higher than that of other athletes and general population, which also must have a bad effect on their performance and health. Most recent sumo champions are Mongolians, who are known for their ferociousness. The first sumo match, which was organized, was in late 1500s. The average body fat content in a top tier sumo wrestler is around 30%, and the average BMI of a top tier sumo wrestler is around 36.5%. So when a sumo wrestler goes to a body fat percentage of over 38%, they are at risk of getting eliminated from the fraternity. So they have to lower down their body fat percentage. So the basic rules we've all been introduced to, that the wrestler has to push the other one out of the ring in order to win the game. So now we were talking about chankonabe. What exactly is chankonabe? It is a broth that is containing seaweeds, different meats, fish, vegetable, noodles, which make a very high calorie diet. So these guys, they eat late in the day while going to the bed, and they are fed with stomach full, in which the body responds to a huge flush of nutrients with a rush of insulin, forcing their bodies to store some of it in the cells as fat instead of muscles and nutrients. They also believe that eating together, they eat 40% more as compared to what they would rather eat when they would have eaten alone. So this is what normally the chankonabe consists of. Now, one serving of chankonabe, we compare it with the 24-hour Indian diet recommended intake allowance, that is for Indians, according to ICMR 2020. So a total average intake is 5,000 kilocalories per day in a normal sumo wrestler. One serving of chankonabe contains approximately 2,000 kilocalories, which is about 70 to 80% as the RDA require for Indian male. The carbohydrate content is almost double as that of the RDA, which is of 24 hours of an Indian male. The proteins is almost 4 times as that of the RDA for an Indian male. The total fat content is also thrice in just one serving of chankonabe as compared to the total fat RDA for a 24-hour in an Indian male, as well as cholesterol. Sodium, as we may really see, that sodium content in just one serving is very high. It's almost 100% as that of the RDA for a 24-hour Indian male. The risk factors and mortality. We see that a sumo wrestler's life expectancy is very less, around 20 years less. And the major risk factor is an overweight. So what we've seen is that overweight individuals, overweight sumo wrestlers have a higher mortality rate as compared to other sumo wrestlers. So this was a very interesting study. This is a comparative evaluation of obesity-related parameters in junior sumo wrestlers and children with obesity. So these are not adult sumo wrestlers; these are young children, and there was anthropometric and hematological parameters which are being compared between the two groups. The BMI, obesity rate, waist circumference, systolic blood pressures was significantly higher, and the HDL cholesterol was significantly lower in the sumo group than in the other sports group. See, we are currently talking about individuals who are very young and individuals who are adolescents. So that is one major factor that we have to keep in mind. There was no significant difference found in other blood lipid, plasma glucose, which was significantly lower than that of the reference range, and glycated hemoglobin HbA1c, which was within the reference range among the three groups. So here are the six graphs that we can see, and a good comparison between obesity rate, BMI, systolic blood pressure, diastolic blood pressure. Here we can see the glucose levels in HbA1c, where we can see the glucose is a little lower than what in the control population is, and the HbA1c, which is almost in the reference range. Now we come to the energy-rich diet, which these guys are certainly fed with a very hyper-energetic diet. So is it a boon or a bane? It has been observed that sumo wrestlers have an increased turnover of adenosine nucleotides due to high protein content, which may contribute to hyperuricemia. The total prevalence and the prevalence of gout in these sumo wrestlers is around 6.3%. Now, recognizing cardiovascular risk in new recruits. This was a study which was done in new recruits. Around 800 subjects were taken who were newly recruited by sumo schools, and prevalence of left ventricular hypertrophy was determined by echocardiography. It was also noted that BMI did not significantly correlate with the coronal voltage ECG criteria. So, left ventricular hypertrophy will likely go undetected by ECG in most overweight athletes. Now, next we come to the characteristics of body composition and muscle strength. So, the body composition of sumo wrestlers was characterized by a high fat content and a large free fat mass. And these guys had 1.7 to 1.9 times greater cross-sectional areas of elbow flexors and extensors and knee extensors as compared to the untrained subject. Now, we're talking about everything. We're talking about food, we're talking about environment, we're talking about all the training. Now, what about what is present inside the genes? So, genes, is it a shotgun with loaded pellet? The body composition of 36 professional sumo wrestlers and 39 collegiate male students was assessed. And it was observed that means of body weight, BMI, percent fat, body fat, and for sumo wrestlers were extraordinarily large as compared to the untrained men. And the wrestlers in the professional category had significant larger free fat mass index scores in comparison with the wrestlers from the lower categories. So now to conclude, most sumo wrestlers are deliberately overweight in order to generate a high momentum in order to gain an advantage over their counterparts. They enter the wrestler society, they cannot be independent, so they enter the wrestler society at a very young age and carry out hard training for 5 hours daily. Their expectancy of life is around 20 years less as that of a normal Japanese male. They consume around 5,000 kilocalories per day. The average body fat content in a top tier sumo wrestler is around 30%, and average body mass index is around 36.5 kg per meter square. Only one serving of chanko grabe, which is a very important factor in these subjects, is around 80% of required dietary allowance of energy for an average moderate working Indian male, 3% of RDA for proteins, approximately 2% RDA for carbs, 3% RDA of fats, and almost 100% RDA for sodium and 2% RDA for cholesterol. I'm talking about just one serving, which is just 2,000 kilocalories. So the sumo wrestlers are being fed with around 5,000 kilocalories per day. Mortality rates for sumo wrestlers is much more in obese population than in general population. The BMI score, the obesity, waist circumference, systolic blood pressure are significantly high, along with low HDL levels as compared to the other group. The wrestlers have an increased turnover of adenosine nucleotides, which also gives rise to hyperuricemia. Body composition of sumo wrestlers was characterized by high fat content, and the prevalence of left ventricular hypertrophy, as determined by ECHO, was 9% of the entire group. Means of body weight, BMI, and percent fat for sumo wrestlers were higher as compared to the untrained population. So thank you for your patient listening.
Superb slog, very, very good. And I really congratulate the scientific committee, particularly Sunil, to have this topic because this is something very new and very interesting, for the sumo wrestler. I was also wondering that how sumo wrestlers are surviving, and they are persons who become overweight because of their wrestling, and it's in a sports activity. Is there any data that these sumo wrestlers they play up to the age of 35? I think so, or 40.
Yes, around 40 for 40, 45.
So why they don't go after there once they play or the athletic part is over? Why can't they go for bariatric surgery? I was just thinking, I will say something very interesting because someone with a BMI of 40 and going to die early, they have 20 years. So I'm sure Mahendra must have some data or something. Someone must have worked on these sumo wrestlers. So just want to have your opinion.
Japan, the obesity incidence is very high, very low. In the normal population, only sumo wrestlers are getting bariatric surgery after their
yes. So I mean, the bariatric surgery data also you can include slow because I'm sure they must be getting the bariatric surgery after the age of 40, and this must be very interesting data also. Anyone wants to have any? So they have a lot of cardiovascular risk factor, low HDL and all these things. Yes, sir. Please.
Sorry, sir.
Despite the obesity,
Yes,
are
sir.
they not physically very fit?
Sir, despite the obesity, they're subjected to a very intense training exercise. So they have to remain fit because the main element in their sport is to generate all the momentum. So that the more momentum they generate, the more they have to remain fit and to also overcome all the overweight, the obesity related injuries.
They get a lot of injury also. No? Because yes, sir.
And sir, surprising fact is this: percentage body fat is only 26%. My percentage body fat is 25% with this weight.
You are lean and thin, so you
Still-
are
still.
sumo thin Indian.
so with this much high BMI, I think their muscle mass.
But they have the rule now. More than 30%, they are out.
No, more than 38, sir. So 30 around body fat percent is around 30% average in top tier sumo wrestlers.
But when they are out,
more than 38.
Okay.
So
So
they
you
are
have
being
31.
warned after 38. They are being warned. They have to lower it, otherwise they are at a risk of suspension.
So maybe because of a lot of exercise, their fat percentage is not increasing.
So
That
as
could be
long
the
as
reason.
they are wrestling, even their sugars, their lipids, their HSCRP, everything stays normal.
Because they are doing a lot of exercise also, 5 hours.
And they eat food in kilos. You know,
That
their
is what
food
he has shown already.
consumption is also
Very interesting data. Very, very interesting. Exactly. Very true. The average Indian is also taking 1500 plus calorie.
Yes, sir.
So with this, I think, Sunita ji, please close the session. If anyone is there,
Yeah.
one more person is there.
Thank you, Shlok. Congratulations for the excellent talk
you so
and
much, ma'am.
in a new, unique topic. We got a lot of insights from you. Thank you so much for the opportunity and
Thank you.
wish you all the best.
Thank you. Thank you so much, sir. Thank you so much, ma'am.
Thank you. Since Sarita ma'am has to leave, I would like to request Kavita Gupta ma'am and Sunil Gupta sir to felicitate Sunita Jyotidev ma'am with the memento. I would like Sabu sir to. Mhm. Now, after this, we'll continue with our TED Talks.
Thank
Over
you
to
for
you,
this
ma'am.
Power-packed, high-energy session. Now we move on with our next session, and we invite the next speaker for the TED Talk. Next speaker is Miss Meenal Boyer. Meenal, are you ready? Meenal would be talking on the vegan diet. Another hot topic for the day.
Yes.
Meenal is consultant clinical dietitian and lifestyle consultant, head chief dietitian at 7-Star Hospital, Nagpur. She is a certified clinical dietitian and owner at Nourish and Heal Weight Loss Clinic. She consults more with fit belly obesity. Certified diabetic educator, has 12 years of vast experience in diet management of diabetes, female nutrition and wellness, obesity, critical ill patients and onco-nutrition. Executive Committee member, IPIN, Nagpur chapter, and she has been contributing to social work, education, women and youth welfare. Awarded National Spirit Award and also awarded at Rashtan Tughroji Maharaj National Award 2012. So we're looking forward to a session on the vegan diet.
Thank you, Shakti ma'am, for kind introduction. I thank Dr. Sunil Gupta sir and Dr. Kavita ma'am for this very prestigious opportunity at RO. My topic for today's presentation is vegan diet for weight loss and its potential benefits. Then, what is vegan diet? Vegan diet is based on plants such as vegetables, grains, nuts, and beans, fruits made from plants. A vegan diet or veganism tends to omit animal products for ethical, health, or environmental reasons. Vegans do not eat foods that come from animals, including dairy products and eggs. History of vegan diet. The term was coined in 1944. The concept of flesh avoidance can be traced back to ancient Indians and East Mediterranean societies. Vegetarianism is mentioned by the Greek philosopher and mathematician Pythagoras of Samos around 500 BCE. Followers of Buddhism, Hinduism, and Jainism also advocated vegetarianism, believing that humans should not inflict pain on other animals. There is a lot of confusion between vegetarian diet and veganism. So there is a slight difference actually. Vegan is a diet that excludes all animal products, including meat, eggs, and dairy, whereas vegetarian is something that includes all meat but may still include eggs, dairy, and other animal products. There are three reasons for which people go vegan. First one is ethical reason. Ethical vegans strongly believe that all creatures have a right to life and freedom. Vegan lifestyle is considered to be more healthier lifestyle, and to avoid pain and suffering of the animals, people go vegan. There are many health benefits, like it promotes weight loss, it reduces your risk for heart diseases, and it lowers your chances of getting certain types of cancer such as colon cancer, manages diabetes by lowering A1C levels. Researchers have studied vegan diets and weight loss. Most recently, a 2022 study published in the journal Obesity Science and Practice found that people who went on a low-fat vegan diet for 16 weeks did decrease body weight, body composition, and improved insulin sensitivity. Third reason is environmental reason. According to recent data, animal agriculture heavily contributes to greenhouse gas emissions, which cause climate change. Meat eaters are thought to be responsible for 2 to 2.5 times more GHGs than people following a vegan diet. The research shows that vegan diets resulted in 75% less climate heating emissions, water pollution, and land uses than diets in which more than 100 grams of meat a day was eaten. Vegan diets also cut the destruction of wildlife by 66% and water use by 54%, the studies found. I found this key statistic and facts. 60% of US consumers say that they are vegan, 500% increase compared to just 1% in 2014. More than 5 lakhs participants signed up for Veganuary 2021 challenge. Animal agriculture is responsible for 18% of all greenhouse gas emissions, and US retail sales of plant-based foods have increased 11% from 2018 to 2019. Is a vegan diet good for weight loss? The short answer is yes. Research suggests that following a vegan diet can help you maintain a moderate body weight. What latest researchers say about vegan diet for weight loss? A systematic review published in January 2020 analyzing 40 diet and weight related case studies or cohort studies reported that those following a vegan diet were less likely than those following any other diet to be overweight and had lower BMIs. A plant-based diet in overweight individual in a 16-week randomized clinical trial. Objectives were a plant-based diet is an effective strategy in the treatment of obesity, and findings were that this study demonstrated that the quality and quantity of dietary protein from a plant-based vegan diets are associated with improvement in body composition, body weight, and insulin resistance in overweight individuals. Here is another study, a plant-based diet for overweight and obesity prevention and treatment, and conclusion was individuals consuming plant-based diet tends to have lower BMI than those consuming non-plant-based diets. Like that, there are another 2-3 studies stating the efficacy of plant-based proteins or vegan diet for weight loss. The principles of vegan diet are same as any other diet for weight loss. Like, it focuses on whole foods, encourage individuals to prioritize whole unprocessed plant-based foods such as fruits, vegetables, whole grains, legumes, nuts and seeds. Portion control, this is the mainstay for any weight loss diet. Optimize protein intake, healthy fats, inclusion of healthy fat increase the satiety, provide satiety and contribute to overall satisfaction of the meals. Mindful snacking is very important. It is not like a vegan is very natural food and healthier food, so you can have it in n number of quantity. There should be portion control and mindful eating. Regular physical activity and balanced macronutrients are also important. Here are some cons of this diet. Common nutrient deficiencies can be seen in a vegan diet follower, like vitamin B12, vitamin D, calcium, omega-3 fatty acids, zinc and iron. Here are some common food sources to overcome common nutritional deficiencies, like for calcium, green leafy vegetables and sesame seed, hummus can be included. Like that, there is a number of sources are elaborated in the slide. Here is the beginner's guide to ease into your vegan diet. The key to adopting a vegan diet for beginners is to slowly begin incorporating more plant-based foods into your diet and build up from there. Stock your kitchen with the essentials. This is the most important thing for 100% compliance of any diet plan, because if you don't have the things available in your kitchen, you will end up in eating anything which is available or may not be healthy for you. So if you want to be successful with your vegan diet plan, ultimately reap its health benefits, you need to load your fridge and pantry with basic staples like fruits, seasonal vegetables, beans, nuts and cereals, etc. Expect some initial changes to your digestion. You initially may notice some changes in bowel habits, more gas or even a little bit of abdominal pain. So make sure you are hydrating really well during your transition to a vegan diet. Consider meeting with a qualified dietitian. I think everyone will everyone will be supportive for this. It is very crucial to get the necessary nutrition education in order to adopt a well-planned, balanced, nutrient-dense vegan diet so that the maximum benefits can be achieved. Meeting with a dietitian periodically can ensure you are getting all the nutrient needs, particularly those ones that are easy to lack when following a vegan diet. Facts. Can you get enough protein on a vegetarian diet? This is the commonest question asked to any vegetarian or vegan person. Yes, you can get enough protein in a vegetarian diet. Dairy and eggs are a convenient source of protein for vegetarians, together with meals that combine higher protein sources like tofu, lentils, mixed beans, nuts and seeds is the best source. Here are some vegan sources of complete proteins that ensures your vegan diets is doing really well, and there will be 100% compliance, like tofu, tempeh, edamame, amaranth, buckwheat, hemp seeds, chia seeds, nutritional yeast. Together, rice and beans contains all 9 essential amino acids to form a complete source of protein. Are plant proteins incomplete proteins as compared to animal protein? This is another question asked. If you combine proper foods together, we will get all the essential amino acids and the dish will be a complete protein. How to build muscle on a vegan diet? Here are some tips. Do regular strength training, eat high protein plant food, eat this food with every meal and snack. Sleep for a minimum 7 to 8 hours each night. Include a soy or pea protein supplement to increase your protein intake. Take home messages, protein intake considerations. Combine different plant-based protein food to complement their amino acid profiles for more complete proteins. May limit food options as on social occasions, so be well prepared for that. Vegan plant-based can significantly increase the nutritional quality of a person's diet, mainly those who have swapped from a highly processed westernized diet with little amounts of fruits and vegetables. Many health benefits to a plant-based diet for weight loss, health and athletic performance and recovery. Be wary of nutrient deficiencies and supplement wherever needed. Thank you.
Promoting more of vegan and the other speaker talking on more of keto diet, the panel discussion is going to be a good talk. What to choose now?
It's going to be a tug of war
Actually, it
between
should
both
be
of
all
you.
customized
Yes,
only.
yes.
Many people are
Yeah.
very resistant to fat
Yes.
absorption.
We'll
Many
talk
are-
more on
We'll
this
have
in the
a
panel
panel.
discussion.
Not
You'll get
everyone
time
can
to speak.
digest this much of fiber
Definitely.
also.
Yes.
Thank you,
So,
Meenal.
yeah,
Yeah.
I think then moving to the last session, I think, of the day, and that's the most important session. And I think our WhatsApp and
So-
other social media is all with that. So we have Dr. Shweta Chabrash, who will be speaking on gluten-free diet, and she's done her PhD from Nagpur University. She's a certified gene practitioner and a diabetes educator. She's the joint secretary of IDA Chhattisgarh chapter and founder of Nourish Me, and she has a long experience of more than 15 years or 17 years of experience in nutrition, and we keep on watching you and Insta with your lovely reels.
Sorry to interrupt. I would just like Kavita Gupta ma'am to please felicitate Dr. Jitendra Gupta sir. We are having Jitendra Gupta sir here. I request. Okay, please continue, sir.
Good afternoon, everyone. Thank you, chairpersons. Thank you, Kavita ma'am. Thank you, Gupta sir. And thank you, organizers, for giving me this opportunity. So it is the last day of the conference, and since yesterday we are listening all about obesity, and I am ending this session with a very trending diet, that is gluten-free diet. So nowadays, all health experts like dietitians, doctors, and the common public taking gluten-free diet on their own or consulting with a dietitian without knowing that is it beneficial for them or not. So I will try to fulfill this conclusion that whether it is helpful or not with my PPT. So I'll start with the introduction of gluten. Basically, what is gluten? So gluten is composite of proteins found in wheat, barley and rye. It gives elasticity to dough, helping it rise and maintain its shape during baking. Gluten is naturally occurring, but it can be extracted. Nowadays, there is one wheat, people are claiming that khapli wheat is not having the gluten. So still we need to see so many studies about that. So there they are extracting gluten from the wheat also. And in the same way, it can be added to the food and other products to add protein, texture and flavor. It also works as a binding agent to hold processed food together and give them a shape. To more about understand gluten, let's see how it works. Gluten is having two main proteins, that is gliadin and glutenine, and when it comes in contact with water, it form a bond and that become a gluten mesh. For more understanding, we can compare it with a balloon. Like balloon has strength, elasticity and starchiness, as the same way gluten has the same qualities. We can convert dough in any shape and then it can come again to the original shape. So this is the qualities of gluten. So the very important thing is gluten-free diet good for me? So in our human body, there are so many enzymes which works for the food breakdown, and protease is one of them. Protease works for the protein breakdown, but it can't do breakdown of gluten completely. Then undigested gluten goes into the small intestine and then it can be digested, means large number of population can handle this undigested gluten, but very few percentage cannot digest this gluten and they form autoimmune disease called celiac disease. And the other, we can see the gluten alpha amylase trypsin inhibitors and fructan that cause gluten intolerance. So there is a big difference in between gluten intolerance and celiac disease. The people who are having celiac disease, they can't take gluten at all. But the people who are having gluten intolerance, gluten may be suitable for them or may not be. So we can see the difference of gluten intolerance and celiac disease. So the gluten intolerance is not autoimmune disease, celiac disease is autoimmune. No damage to the small intestine in glucose intolerance. In celiac disease, there is a damage in small intestine. It's a genetic disease, celiac disease. Symptoms are triggered by the gluten in the both conditions, and they give good results with gluten-free diets. So the prevalence of celiac disease in India, so in study concluded by Ramakrishna was found that celiac disease affects only 1% of people in the northern part of India. So very few percentage are having this problem or diagnosed with this problem, because there is no onset of celiac disease. People can feel these symptoms at any age. So we have understood that what is gluten and how it works. Now the very important question, why gluten is important in our diet? Because we are taking wheat since our birth basically, and it is very difficult to leave this very important part in our diet. So for this, we have seen few side effects of gluten-free diets. So I'll show them with few studies. A study conducted by Chang revealed that 27% of overweight or obese adult with celiac disease experienced weight gain on a gluten-free diet. Similar study done on the children. Another big side effect of constipation, of course, because we are taking less fiber and more starch in gluten-free diet. The constipation is a big side effect in gluten-free diet. We have seen many nutritional deficiencies like vitamin B, iron, and some trace animals like trace minerals like calcium and magnesium. In 2005, a survey done, these are the studies which are showing the gluten-free diet side effects. So when we are talking about the side effects, this is the comparison between gluten versus gluten-free in major grains. So you can see the grains who are having gluten, they are high in fiber, and the grains which are not having gluten, they are low in fiber. So that's why these side effects happens with the gluten-free diet. Gluten-free diet has correlation with some other health conditions like PCOD. So PCOD have some individuals give good result with gluten-free diet in PCOS. PCOS often associated with gluten resistance and inflammation. Some studies suggest that a gluten-free diet may have potential benefits in reducing inflammation and improving insulin sensitivity. It helps reduce insulin resistance by increasing PPRA gamma. It also called reverse insulin resistance receptors. Gluten and IBS. So there are few studies which shows good results on gluten-free diet. In IBS, the common symptoms are bloating, irritable gut, nausea. So when gluten-free diet has given, they have showing good results. So the very important thing, gluten-free diet and weight loss. So is there any evidence that gluten-free diet give weight loss? So we have not found any study on this. Contrarily, we have seen many studies which says that gluten-free diet gives weight gain for celiac disease patient or if taken by a healthy man. So these people, these reports includes that a significant percentage of overweight or obese patient with celiac disease body, they may actually increase on a gluten-free diet. So, and one other health and condition we have seen that gluten-free diet and cardiovascular health, as the same way in weight loss we need high fiber combination with high protein diet. For the CVD also we need high fiber diet. On the other story, when we give the gluten containing food for weight loss like wheat bran, barley, broken wheat, broken barley, so we are seeing very many studies, good studies, they says that gluten containing diet gives weight loss. So the bottom line, although a gluten-free diet is the primary treatment for celiac disease and may help to alleviate symptoms in various conditions related to gluten sensitivity, but currently there is no evidence showing that a gluten-free diet is effective for weight loss. For individuals who don't have celiac disease or gluten sensitivity, there is no need to restrict gluten consumption. A healthy dietary pattern typically includes higher amounts of whole grain and lower amount of refined food and added sugar. I will show some last two interesting slides for the mainly celiac disease patients because they can't resist gluten at all. So apart from the major grains, hidden gluten presents in many syrups, in many beverages, cheese, packaged food and frozen food. So as a nutritionist, it's our responsibility to educate them that before buying any product from outside, you have to see the ingredients. And lastly, whenever it comes in our mind that we have to give the gluten-free diet, so it comes rice, corn, bajra, jawar, but there are many other flours which are good source of fiber also, multivitamins also and protein also, which we can include in their diet. But my last suggestion is whether we want to go on a gluten-free diet or not, don't search for the Google or don't follow any other diet steps. Just consult with the health expert that whether gluten-free diet is good for you or not. And when you are planning a gluten-free diet, it should be having high fiber, high protein and multivitamins. Being a nutritionist, we should not give such diets where client or patient can manage with other nutrient deficiencies. So we have to plan a balanced, complete diet for everyone. Thank you so much.
Shita ma'am, we invite all the speakers of the TED Talk on the dais. And at the outset, we congratulate all of you for performing so well and giving so evidence-based research on this. I think we're moving back to the traditional diets because again, she said going from gluten also. Till they come, we always see it is individualized because nowadays, as ma'am was talking on gluten, I would like to add, there are a lot of genetically modified wheat which is coming up. Only NIRI has said they have developed 64 varieties of genetically modified wheat, which is causing the changes in the gluten and people are becoming more sensitive to gluten. So if it is gluten sensitivity, I think going organic is again the word, khud ka khet lo, khud khana hoga aur khud khao. So
But again, you are
yes.
not going to escape from gluten. So I think that again is a lot
We
of
can open the forum for 2 or 3 questions if you have. Yes, we'll take 3
quickly
questions.
because we need again to wrap up the call.
Can we give the mic to the audience?
Yeah, quick. You can just be,
Yes.
it's audible. You're audible. You
Mention of the lipid
no, whom do you want to ask? You can just specify. We have 4 panelists.
to Vinita Di.
Yes.
So the raising lipid levels about which you mentioned and the cardiac risk also which you have mentioned. So as because keto many people are following. So what is the safe limit or the period which we can safely follow and what is the risk period where we can claim that it can develop cardiac disorders? Because since it is utilizing fat, so I have read few studies which says that in the initial phase it raises your cholesterol, LDL and TGs, But in the later phase, it is again utilized and it reduces. So what's your take on this?
As a keto diet intervention, I really recommend for it's a short term diet therapy. So we can start with minimum 1 month observational plans for that, and after particular time, for after 2 or 3 months, we will check this lipid profile, and then the result of the client, and then we will proceed for that.
So basically, we also need to check on all the biochemical parameters, your
Yeah,
lipid
can I add
levels,
to
your
this?
uric
Yes,
acid,
yes. She's
because
given you
there's a
very
lot of
well.
nausea, headache, and irritability in the initial period, and it's very important that they consume a lot of water as well.
Moreover, it also the function of liver. See, when you're trying to move your fats, it has to come to the liver to get processed. So first, see how good the liver is, how much they can process the fats coming up, and then put the patient on keto diet.
Because
And moreover,
fatty
more
liver, yeah.
fatty liver is seen in them. So moreover, also include more of vegetables, because magnesium is very important when you're managing a patient with keto diet. Any other question?
Quickly.
Yeah.
No. Provided with black coffee or black tea, you have to stay hydrated. Like you have to take plenty of water, so that you should not have the acid reflux or other any problem. Because एकदम आप सिर्फ 2 meals लेंगे तो बीच में these are you can say like 0 calorie beverages you can take.
And
Not
they are
too
fat
much,
burners
less.
also. Like in
One
the
or two
previous
cups
session, they said they are fat burners. So
Yeah.
the
And
yeah.
it increases your metabolism also, black tea and black coffee. You have to take in moderation. Moderation is the key in every diet.
See, acid reflux occurs when lower esophageal sphincter is loosened and the food comes up. So you should work differently on that also. Nobody should have acid reflux. The food should stay in the stomach. So if patient is having acid reflux, work on that. Why? That could be because of stress also.
If somebody do not take coffee or actually get acidity, person like me actually get acidity. I take a one or two
Simple
sip
plain
of
water
coffee or
works.
tea.
That is simple plain water works.
Plain
Yeah,
water, or
yeah.
you can have lime
Zero
water
energy
also.
drink,
You
basically.
Lime
don't
water,
have to have
coconut
extra
water you can
calories
have.
during that window period because it's a time restricted eating. So you do not have to eat anything. You have to have 0 calorie whatever beverage that
Does
time.
any 0 calorie drink work?
Water.
Apart from that, if somebody wants,
So you can have
Put a
coconut
lemon.
water,
Yeah, yeah.
lime water,
Yeah,
or
you can
jaljeera.
put
You can have.
cucumber.
They are
You can
also
put
0
mint.
calories.
There is one
It is
alkaline water.
individualized.
There is one alkaline water, and that is lemon water with the rind. When you make a detox water and put the entire lemon with the rind also, because lemon is acidic, but the lemon skin is alkaline. So make a detox water with lemon and mint. That's an alkaline water.
boil it or
No, just
just
detox.
have it.
Yeah. Yeah.
So
My
I
question
think
is
that's
to
the last question we'll
yeah.
take. Yes.
So to that point, I would like to ask: is barley water is better, or okay?
Detox?
Not
For
work.
detox process,
So
barley
my
water is
question
good.
is to Vinita ma'am that what about vegetarians? If I suggest them a keto diet, what thing can I include for vegetarians? Because if a patient is saying I want keto but he's a vegetarian patient, so what we can do for that case?
Frankly speaking, very less choices is there, and this, like it's tough to manage vegetarian keto diet. And frankly speaking, I cannot, I'm not recommending any ketogenic diet in my clinic. So I'm really looking forward.
So
to
yeah,
see the
I
So-
agree. I agree. So for a vegetarian to follow a keto diet is absolutely difficult because increasing it to 20% of proteins and with 70% of your fat, it becomes really difficult and it's really challenging, not only for the patient but also for the caregiver. The one who's going to prepare meals for them. Again, it's going to be a little difficult. For
you so
non-vegetarians, it's very easy. You know, they have a
Nowadays,
big
people are using
almond
tofu
flour
and
and all
almond
that.
flour
Yes,
and
there
soy
are.
and
But
paneer.
again, the finance part,
Yes,
it's going
pocket
to be,
matters
it's going to be
Yeah.
a big hit on their
Huh,
pockets.
Yes,
that's the
yes.
thing.
Financially, these all
Yes.
trending
So
diets are
everybody cannot
expensive.
really afford
So basically,
that.
all trending diets are expensive.
And
If
I
you will
feel
see
with
financially, because they are not our childhood diets, basically.
and
These all are trending diets.
with
So
the almond flour, I think there's not much research also how good it is going to be for us to go on keto diet.
So finally, I think I would just like to keep a word. Actually, there are a lot of research papers on different diets, what we have seen. But again, what we have observed that all these RCTs or like whatever the research papers, they say that they are all very short term. So it may be for a few weeks. So maybe it is IF or keto or gluten free. They've been done on very short term basis. So for a few weeks or 4 months, we do not have any long term data to prove that okay, this particular diet is the best diet. So I think the take home message for all of us, I think no, one size does not fit all the diets. It has to be individualized. We have to see whether that particular type of a diet what we are prescribing, is it affordable and can it be sustained by that by your patient, and it can be taken for a longer time, and whether their biochemical parameters or is allowing us to prescribe that particular diet to them. So when we are talking about IF, so we cannot prescribe that to maybe children or pregnant women or elderly or someone with the GDM. So all these things keeping in mind, I think we as dietitians or as healthcare professionals, we need to take care that it has to. And finally, I think mindful eating should be followed by each one of us. Yes, sir.
It's a superfood, and if taken, it does boost the metabolism of your body. So taking fenugreek seed has shown. See what happens when we're talking about herbs. They were always there in our diet. What we are crossing now is the limit we use it. Like yes.
So again,
how much
Methi, there
amount
are
and
number of
Yes.
how to
there are
How
number
much
of
amount?
research papers on methi. The important point is the dosage, because if you're not going to use that amount of dosage, like it will not have its
acidity and all this.
the
Yeah.
effects. So it's around, most of the
Yeah.
studies have around 20 to some papers have even 80 or 90 grams per day. And again, important thing is like you also have to understand whether it's suiting that person, because some people have acid reflux or even like bloating problems. So if they are going to have a higher amount of
With moderate amount, what will you recommend?
so
One
around
teaspoon
20 grams, around 20
around
grams
20
per
grams.
day. So it can be
Should it be
taken in
soaked
a
in night in
sprouted
the water?
form, or it can be taken in a powdered form also, or even like soaked. So people, as per their taste, they take it in different forms. It can be taken in powdered form or in a soaked form or even a sprouted form. Sprouted is even like better because it increases the fiber content as well.
Thank you so much, ma'am.
So I yes. So
Thank
I
you
think,
so much to everyone for being a patient audience today, and to the wonderful panelists today. Thank you so much with you.
Yes, thank you, young panelists, and it was really nice to have you all. And I think being the last session, I again take this opportunity to thank all the speakers, all the panelists, and all the chairpersons for having all of you here for the Obesity 2023. And I think we would also like to felicitate
Yeah.
our.
I kindly request the chairpersons to felicitate the speakers. So please join. Yeah. We have with us Vinita Mehta ma'am. Makar sir, please join. We have Meenal Bhuir ma'am. We have Shweta Chhabra ma'am. We have Parvinder ma'am.
Come for group photograph.
Now I request to felicitate this chairpersons.
Woo!
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 Now I request all the repeaters to please come up here. We will have a
Good afternoon,
felicitation.
everyone. So, with the end of the last session, we come to the conclusion of this meeting, and it. कुछ बुला रहा हूँ मैं वापस हाँ तो और क्या और किसी को बुलाना है तो बता So we are coming to the conclusion of this meeting, and it is indeed a. First thing is, I think we should have a big round of applause for Dr. Sunil Gupta, Dr. Kavita, and team for putting this wonderful conference. And I am going to invite Sunil for the final remarks and the felicitations. Sunil. Sunil.
Yes. So it was a 3 days meeting. We started with 1.5 day, extended to 2 days, and ultimately ended up with 3 days meeting. The first day was virtual, and fortunately it went very well to the extent that every speaker was there. It was an international virtual meeting, which was attended by across the country, all chairperson, moderators, and speakers from US, South Korea, and Malaysia. And that was attended by almost 500 to 600 delegates across, and it is very much available even online today, and it's being watched. We have circulated to across the country through for all educators as well as all family physicians. Now, this 2 days meeting, we started with a very slow pace, and Bansi Bhai and Makkar Saab and Mahendra Saab were little skeptical whether Sunil will be able to do it or not do it. To the extent that sometimes to say यार मेरे पास पैसा नहीं, मैं क्या करूँ कैसा करूँ, तो मंशी सेठ के ओके एक काम कर, कुछ नहीं तो मेडिकल कॉलेज में कर रहे हो, मीटिंग तो करनी है. So we started with medical college first, then we even went up to धर्मशाला कि धर्मशाला में कर लेंगे. Yeah, medical college option, but end with every good, when you start thinking something on a very very positive note. My message to all youngsters is, even if we did not had RO had some issues with the accounts, they were seized because of COVID gap, and 3-4 years it was all not functioning. So we had a lot of difficulties getting this done. But at the end of the day, Dr. Makkar says, "Karna to hai tune." Sir, तुम्हारा मेरे को है, करना तो है तूने. And Bansi bhai and everyone around here have were as a backup, and everyone supported me, and that's why we could do this particular show. I'm thankful to all three major organizations: Diabetic Association of India, Academy of Medical Sciences, and Indian Dietetic Association. Nevertheless, RO executive body was always very, very supportive. With one phone call, everyone was available. Even all senior people, they were so much courteous and very positive for this. And then everyone told me that they will be all there here for 3 days. I had a wonderful team, which Kavita will be now calling the names, and we will have the felicitation of our all people. Me and Kavita are just the face, but then there are a lot of big work and large amount of efforts required to make such program a big success. And this venue was also chosen for the first time, and we were little even not very confident on this, but ultimately we had wonderful meeting for 2 days. I know you must have missed some of the cultural activity yesterday. It was expected to be done. But we had to cut it down because our all senior people have told that we should respect the mandate from the government, and that's why we just kept a very simple dinner yesterday because of something going on in the. So better we remained attached to the academics. We started with academics and ended up with academics, and that's the beauty of this RO meeting. And let's give a big hand to every one of us, including the RO National EC. Senior members, patrons like Dr. Durinder from US, and many more people, and all members. RSSDI headquarter have also supported it directly, indirectly through their members. We have senior people like Dr. Rajiv Chawla, Dr. Jaggi. Amit is very much, was always there calling me up, sir kuch kaam hai kya, mere ko batao, I'll do from Delhi. So everything, to the extent Makkar साहब said, तेरे पास पैसा नहीं है मोमेंटो देने को, तो मैं वहाँ से भिजवा देता हूँ दिल्ली से, कितने मोमेंटो चाहिए, और what more you want and expect from your people. And then even Mahendra from Ahmedabad. So this is a very big, it's a big family now, and we really want to strengthen this organization with the support of every one of you. I appeal the EC has taken a decision that we will starting the membership in the month of April. The moment it is open next year, I will appeal every one of you to become the member. And also on behalf of Dr. Bansi Sabu and the RO team, we have the next meeting in the month of December in Ahmedabad, which he is going to declare. We have that flyer in the morning I gave you. So you also can, we will have the introductory offer also for the registration, which Dr. Bansi will declare in his address. The next one? Yeah, this one. So, the next one. तीसरी थी, 3 था ना? Next एक और था ना? We have one more slide, I feel. Check it, check कर लो. So now I hand over this mic to, hey, it's there? Yeah, it's 6th to 8th of December next year. So please block your date from now. And there will be some early offers for registration, especially for those who have attended Nagpur meeting. I'm sure that Bansi will declare some wonderful offer on this platform. And over to now Dr. Kavita to run the show. Kavita, now be here and just... whether our President Mahendra, you want to say something before Kavita joins?
I think last year when I took over as a president, we were having very few members in Ahmedabad, and we decided to do it then this meeting in Nagpur. That time, first time I met Sunil And since then, we had good company in Hong Kong when we were attending AOCO. And that time we decided that how to give the shape and all. And what Sunil has done is wonderful. The topics were so amazing that my surgical colleagues were asking whether they can join online, and people were watching online. So it was a fantastic program. I don't think anybody has put in so much effort to create such a advanced program. And we had the best speaker from the country. Dr. Anup Misra has delivered 2 talks. He's such a senior scientist kind of person. Dr. Makkar and everybody, I think all who's of our country were here, and everybody was with us for 3 days, and really we enjoyed a lot. Thank you very much, Sutil, Dr. Makkar and Bansi and all my friends for hosting this in Nagpur, and first time we've seen a 0 mile. Thank you.
Before I forget, if without any unintentionally, if someone has been hurted because of any of the disciplinary things which happens sometimes, I or Kavita or some of our volunteers or some MOC or chairperson has had some unintentional, if someone got hurted, please excuse us on this, because we all have practically I'm very hard on this and very harsh on this. Rather, we have practically focused only academics and the time discipline in 3 days meeting. So for running the show in time, running the show, keeping it to the science, we had some decision, but I don't think anyone has done anything intentionally. So please excuse us for this. Thank you very much.
So yes, I copy the same words. So first, yes, do excuse us for whatever I think wrong we have done, or unintentionally whatever we have done. But yes, nevertheless, I would again like to give a big round of applause and a big gratitude to each one of you for always standing besides us, guiding us, and especially Dr. Makkar sir and Dr. Narwaria sir and Dr. Banshi Sabu sir. They have always been a guiding force कि नहीं सुनील हो जाएगा कर लेते so yes so I think that simple word हो जाएगा is like that was a booster for us and शायद उस वजह से we it just happened, and at the end of the day we are really happy, yes, we could make it, and thank you for believing in us. Thank you, sir. And we would just like to there are many hands who have gone to make up this 2-3 days possible, and we would like to thank our rapporteurs, because they have been here since not only these 3 days, but more than that, a week or so, and they were there with us, and they were consistently making up the CVs and different things. So to start with that, and no particular order, so Dr. Zakir Siddiqui, if he's here, please be here. We would just like to felicitate you. Dr. Zakir Siddiqui, Dr. Shantanu Karwa. Yeah, please be here. Thank you, Dr. Shantanu. So he's just joined us very recently, and he's a young doctor. Yeah. So he's with us for the RSSDI certificate course. So well done, Dr. Shantanu. Dr. Arshi. Dr. Arshi Beg, thank you. Are you here around? Yes. Please be fast, I think, because thank you, Dr. Arshi. And we have Dr. Shruti Jalke. They are also our DCRC pillars. So Dr. Shruti Jalke, thank you. We have Dr. Sachin Gate. Do we have Sachin Gate here? No, he's not been here. So Miss Priyanka Santiago, Dipansha Wankhede. So they are our dietitians. Yes, thank you, Priyanka. Dipansha Wankhede. Nikita Patil. So they are very young and dynamic And we are proud to have them all. Sarita Kale. Nice, I'm not there यार, मेरे पैर पड़ने लग जाते सब लोग अभी से बुड्ढा बना देते. So Sarita Kale, yeah, and round applause, a big round of applause to Sarita because she's been taking care of all the datas. That is very very important. And सबसे ज़्यादा डांट जिसको पड़ती है वो है Sarita. So we have Nikita Patil. Thank you, Nikita. And the lovely functional baskets what we have got is from Nikita. Then we have Shweta Gupta. Okay, Kiran Patil. Kiran again. Come soon. Again, she is the dietitian with us. Yes. And we have Shweta Gupta, who is the manager of everything. Yeah, and yes, thank you, Shweta, always being there. Then we have Dr. Pratibha Dingra, ma'am. Is she here around? She was there from right in the morning. So I think she's left, or probably she must be. So, Dr. Okay, Miss Sakshi Patil. Dr. Piyush Kherde, if he's here, sir. Dr. Kabra. No, Dr. Khan. Dr. Piyush Kherde. No, Dr. Khan. No. And so fine. Dr. Khalid Khan. Yes. Thank you, sir. So, and these are the people, the reporters, they opted themselves. So we never told them that, you have to do. I think they came forward and they said, ki, sir, kuch kaam hai to batao. So we, it was totally on their call. And now we have Parvinder Bamra. Parvinder, where are you? And she's a very senior dietitian attached to us and holding a lot of responsibilities on her head. Parvinder, मिल गया? हाँ तो क्या हुआ? ये वाला तो नहीं मिला. So thank you, Parvinder. Yeah, and keep working together. And finally, we have Vivek Nagrare on the list, the Hanuman of Woo! So yes. So again, Vivek Nagrare, we all label him as Hanuman of Dr. Sunil Gupta. So he's always there, always with us and guiding us and, telling us what has to be done, what not has to be done, and even shouldering a lot of responsibilities. So thank you, Vivek, for always being there. And we have the Sun team. That again, as I think that the entire Sun team needs a big round of applause for doing the wonderful pick and drop, because that's the most crucial area. If you really are not able to, the pick drop is a very important thing. So we have Mr. Srirang Kulkarni, Manoj Mankade. So can we have the entire Sun team? I'm not going to specify everybody's name because it's a big team. Yes. So from morning, say maybe 5 o'clock to night 2 o'clock, they were there, and we had a special WhatsApp group where this pickup is done, this drop is done. So we were having every minute data on that. So thank you so much for being so efficient always. It's not only this meeting. For the last, I think, I don't know how many, 15 years, they've been really the same efficiency, the same consistency is there, and hats off to that team. And I think with that we are done, or do we miss out? Have I missed out on some name? Yeah, for that I did thank So, yeah, there are many hands. So, Gajanan, Yash, Mithun, audio, video. Yes. And yeah, you know, one more thing what Nagpur is known for is Yash audio videos. And they're everywhere, wherever we go, whether it's Ahmedabad, Jaipur, Delhi, Yash is there.
I was there in the national conference of Foxy, and Foxy conference is gynecologist. That is supposed to be the biggest conference in the country happening, and that was Bangalore. And I was there to speak on GDM, and there are around 8, 10 halls, 12 halls, something like this. And there are big kind of क्या बोलते हैं, pandal where their audio visual was there. So someone told me, okay, that is a place where you go to put your presentation, preview room. So I went there and gave. Someone just received me, sir. मैं लगा कि मेरे को कौन बैंगलोर में पहचानने वाला है और गायनेकोलॉजी में कौन पहचानेगा मेरे को. So then he said, I said, who are you? Sir, we are from the Yash Engineering. Yash? फिर वो, then they took me everywhere. I felt so much proud. Such a big meeting of, around 25,000 delegates that time. That too in Bangalore, and Nagpur person is audiovisual, doing audiovisual, was a big honor for the Nagpur. So now Nagpur will not be only known for Haldirams and oranges, but also on Yash Engineering. So congratulations to you.
So yes, that day somebody was asking me what Nagpur is known for. So I said first on the list is oranges, then Haldirams, then even Zero Mile. And so yes, even the Sauji food, Vishnu ki rasoi, we went yesterday. So we have the chef Vishnu ji with us in Nagpur. And yes, the Yash Engineering. And yes, a big round of applause to the Radisson team. So thank you, Jaypal. Thank you so much for the warm hospitality, for the amazing food. Thank you so much. So our confidence has increased, Otherwise, we were little skeptical whether we should shift to Radisson or not. But now we are, I think, we are more sure about it. So thank you. Thank you. Yes, I think
I would just like to add something. I would just like to add something
from the audience.
Yes, yesterday I had the pleasure and blessing to see Dr. Sunil Gupta sir's clinic. There I met staff who are working in the clinic for 30 years. Now it is not usual in today's ये कि some employees working with the organization for 30 years. It speaks volumes of the kind of leadership and thing Dr. Sunil Gupta ma'am, sir, and Kavita Gupta ma'am have. So I think they deserve a round of applause and their entire team.
So actually, basically, we are a family. So we call it as a DCRC family. So it's not a workplace, it's a second home for all of us.
Very good. Very good.
And yeah, finally, we would also like to thank our event, the Puja graphics, the designers, so Manoj Singhi and Sable, Jignesh Sable, for making this event possible, and the young girls, Himani and Ashlesha, come. Would just like to thank you, and the third one, but I do not know, Akansha. So thank you for the promptness. Sanjay, yeah, for all the designing part and all the event. So thank you. Yes. So I think this is now over to Dr. Banshi.
I invite everyone here for next year meeting Obesity 2024. For formal invitation, we have with us organizing chair, who is currently president of Arrow. We have with us organizing secretary, Dr. Arya. Come, Arya. Then we have from Team Ahmedabad, Maulik. Come, Dada. Naam mana ekdam ti yaad nahi come. And where is Vishal? So we have few persons from Ahmedabad who are here. We have with us our national secretary, who will also invite everyone to be in Ahmedabad for 2024. Only problem is we may not have those many volunteers. So we request you, and you will hire from that. The audio visual also we can hire from here. The only thing is what we can have. Yes, we can hire the Sunil Gupta for complete event to be done for that matter. I invite you all for Ahmedabad. Ahmedabad city is first World Heritage City of India. I mean, it was declared as the first World Heritage City. So many of you may not be knowing about it. Before even Delhi and Jaipur, the older Delhi and Jaipur is later declared as also World Heritage City, but it was the first one in Ahmedabad. And probably by next year, 2024, for 2036, we will get Olympic in India, and that will be Ahmedabad. So we will be invited for Olympic City of India in Ahmedabad, and we will have a grand show. Definitely, we would like to do our level best. A grand show, which is expected by the National Committee also. Thank you.
So just, my pleasant duty to finally say a word of thanks for every single person who has contributed to the success of this Obesity India 2023. I know, the formal vote of thanks has been done by Sunil and Kavita beautifully, but from the RO executive, I convey my regards and my heartfelt thanks to every single person for making this meeting successful and a good academic activity. And I am sure you will be there for the next Obesity India 24 in Ahmedabad. And for Ahmedabad, Bansi, you have to be here. There are two famous chai walas in Ahmedabad. One is Modi and second is Bansi.
Sorry.
So there are, I was telling, there are two famous chai walas in Ahmedabad, Bansi and Modi is one and second is Bansi. So you will have very good tea in Ahmedabad, that I can assure you. With that, thank you everyone and safe journey back home. Thank you.
We have Mr. Ansari from the Reddish and Blue, who has really cooperated us wonderfully well. Thank you very much, Mr. Ansari. Let's we'll have a picture with you. We will have a group photograph. Every one of us, please join us. Yeah, all reporters, volunteers, please join us. Photographer, to please see to it that everything gets settled here quickly, because we have to have a flight also. Have to go home and then बच्चे लोग कुछ खड़े बैठ जाओ, फिर उसके पीछे खड़े हो जाते हैं. दोन मध्ये होऊन जाईल ना. हम लोग नीचे आ जाए.